Okay, good morning to the judges, the moderator, and the postgraduate students. We are live now. Just one request all the postgraduates, please rename yourself. Look at the chat box, use the last four digits of your DENTOCON registration number as your name. And I request Dr. Babita to please take over the session.
Good morning. A very warm welcome to DENTOCON to Advances in Holistic Dental Care, organized by Faculty of Dentistry, Jamia Millia Islamia in association with IESR Foundation from our very own Heart of Nation, New Delhi. My name is Dr. Babita Meena. I am working as Associate Professor in Department of Conservative Dentistry and Endodontics. Our team is very excited to have you join us online for this 60-minute session of shortlisted PGE posters out of more than 50 posters received from all over India. Each poster presentation is of 3 minutes pre-recorded video, followed by 2 minutes of live Q&A session. I am delighted to introduce our esteemed judges. First on the panel is young and dynamic Dr. Nafees Ahmed. He is working as professor in Faculty of Dentistry, Jamia Millia Islamia, New Delhi, since 2010. He has completed his BDS and MDS from King George Medical University, Lucknow. He has more than 14 years of teaching experience. He is awarded with various awards and honors on national level and delivered invited lectures in multiple national and international forums. His area of expertise is not only limited to dentistry, but he is a notable expert in the field of nutrition, food habit, and metabolic diseases. He has given significant contribution in university in capacity of assistant proctor, warden, deputy dean, students welfare, and member of anti-ragging games and sports committee. Welcome, sir. I would
Thank
also
you.
like to welcome Dr. Preeti Sharma. She's working as professor in the Department of Oral and Maxillofacial Pathology, Subharti Dental College, and has an experience of 11 years after completing the post-graduation from Swami Vivekanand Subharti University. She was awarded the prestigious International Fellowship by International College of Dentists, India, Sri Lanka, and Nepal section, and Fellowship in Forensic Odontology recognized by Board of Indian Association of Forensic Odontology. She has won several awards in national conferences and she was awarded Sushruta Medical Sciences and Excellence in Research by National Level Novel Research Academy. She has around 34 research publications in various national and international journals. Her areas of interest includes oral malignant disorders, forensic odontology, and scientific research writing. So let's get started. Our first presentation is poster number 00178.
Greetings to all the judges. I, Dr. Aishan Sharma, would like to present my poster on the topic microbial identification of P. gingivalis in chronic periodontitis patients using genomic analysis at the esteemed platform of DENTCON 2022. Bacterium genetics reveals information about the metabolic pathways and secretions that can potentially hamper the host defense system. P. gingivalis, a keystone pathogen implicated in periodontal diseases, show considerable genetic heterogeneity. It is well established that the bacteria may be similar in its serotypic and phenotypic characteristics, but the genotypic behavior varies considerably. Hence, the objective of the pilot study was the identification of genomic sequence of P. gingivalis strain isolated from chronic periodontitis patients. So moving on to the methodology, plaque sample collections were done from 5 chronic periodontitis patients having probing depth greater than equal to 5 mm. Plaque samples were transferred to the Eppendorf tubes containing thioglycolate broth as the transferred media. This was followed by P. gingivalis colony culturing on blood agar plates. Finally, the procedure for genomic sequencing was done, that is, the DNA isolation of the strain, oligo16S DNA specific sequencing, and finally the gene mapping procedure was done. The result table shown on the lower left side of the poster shows the total number of genes, the percentage of genes that belong to the core genome, and the number of accessory genes in each strain genome. The graph shows the distribution of the strain, that is the occurrence rate of different virulent strains of P. gingivalis. W50 strain shows the highest amount of occurrence amongst them. As far as the clinical perspective or the clinical implications are concerned, this genetic analysis would serve as a guide tool in early diagnosis, identification, and treatment of chronic periodontitis. This study gives an insight into the inter-individual variation of P. gingivalis strain, which would contribute for different clinical presentation of the disease. Also, in future, this study could be used to check the evolutionary changes in the P. gingivalis genetics. So in conclusion, I would like to say that the strains of P. gingivalis shows inter-individual variations and the type of strain differs significantly. The specific genotypic presentation of W50, F0566, ATCC underscore 33277 underscore 1 in chronic periodontitis patients may be imputed to P. gingivalis virulence. Thank you for your time and your patient listening.
Judges are requested to ask the question, please.
Good presentation. I just want to ask a very simple question. How is this going to help in the treatment plan?
Good morning, ma'am. I'm audible, ma'am.
Yes, sure. Go ahead.
Ma'am, as we are moving towards the era of more specific treatment that is based on evidence-based practice, so this can actually be helped to formulate a chairside tool that can help to diagnose the patient more accurately according to what type of strain of P. gingivalis that the patient he or she has. So, ma'am, since we all know P. gingivalis is imputed as a major pathogen in chronic periodontitis patients, and all of the genomic or all of the genetic variations that we see in P. gingivalis do not always lead to chronic periodontitis at the same point of time also. So yes, it can be served as a chairside tool to detect and to treat the patient more specifically for that specific strain of bacteria or specifically P. gingivalis in this presentation.
Okay, thank you.
Most welcome, ma'am.
Our next presentation is 00215.
Ayurveda, our inspirational ancient medicine. The great thing about Ayurveda is that its treatment always yields side benefit and rarely side effects. A very warm welcome to the esteemed dignitaries present between us and my dear fellow colleagues. The topic of my study is healing herbs, evaluating the effect of mint and tulsi on salivary properties and bacterial load. There were mainly two major objectives of my research. One, to evaluate the changes in the physicochemical properties of saliva, such as the pH and the flow rate on chewing of tulsi and mint leaves. And second, to evaluate the viability of chirogenic bacteria on chewing of tulsi and mint leaves. The null hypothesis of my study was that tulsi and mint do not have the potential to be used as antimicrobial agents. A total sample size of 33 was included in the study based on the inclusion and the exclusion criteria as mentioned here, and the salivary samples were collected at 4 different intervals. First was T0, that is collection of the saliva sample before any intervention. T1, collection of saliva sample after performing oral prophylaxis. T2, collection of saliva sample after chewing of tulsi and mint leaves in the case groups, and after 5 to 10 minutes after performing oral prophylaxis in the control group, and T3, in which the saliva sample was collected 30 minutes after step 3. Right after collection of saliva samples, the pH of the saliva samples was measured using a pH meter to avoid any time-based change in the salivary pH. For evaluation of the bacterial load, the samples were diluted to -2 dilution using phosphate buffered saline, and then they were streaked onto brain heart infusion agar plates and incubated anaerobically for 24 hours. The colony counting was then done using a colony counter, as you can see here. Coming to the results of my study, the first parameter that was evaluated was the pH, and it was seen that there was a significant rise in pH after chewing of mint and tulsi leaves. The results were found to be better in mint as compared to tulsi. The second parameter of my study was flow rate, and it was seen that there was a significant increase in the flow rate after chewing of mint and tulsi leaves. The results were found to be better in tulsi as compared to mint. The third parameter of my study was bacterial load, and when the bacterial load was evaluated between interval T0 and T2, it was seen that there was a significant decrease in the bacterial load. Similarly, when the bacterial load was evaluated between T0 and T3, there was again a significant decrease in the bacterial load. The results were again found to be better in tulsi as compared to mint. The fourth parameter of my study was the percentage reduction in the bacterial load, and it was seen that there was a significant increase in the percentage reduction of bacterial load after chewing of tulsi and mint leaves. The results were found to be better in mint as compared to tulsi. Thus, from my study, I can say that on chewing of medicinal plants such as mint and tulsi, there is release of herbal extracts that in turn release an increase in the pH as well as the flow rate, thus increasing the probability of remineralization of tooth surface and further preventing caries. It is also seen that medicinal plants like mint and tulsi have strong antibacterial agents such as caracol, terpene, sesquiterpene, beta-caryophyllene, and also have strong antioxidative properties. Similar studies have also been done in the past, and they have been cited here. Thus, the null hypothesis of my study was disregarded. I would further like to conclude that tulsi and mint have the potential to be used as antimicrobial agents and can be incorporated for preventing and treating oral infections. Since they are readily available, they are widely used, they have no local or systemic side effects, and they are one of the cheapest means to improve oral hygiene, they can be easily inculcated as an adjunct to the daily oral hygiene maintenance regime, especially among the younger generations. Thank you.
Nafisa?
Hello.
Sir, you are not audible.
Okay, sorry. Do you have any name of the extract, the chemical name of the extract which is extracted from mint and tulsi to act as a, or second question, whether they are the bactericidal or bacteriostatic?
Very good morning, sir. So actually, we had given the raw form of leaves to the young children to test this study. When these studies have been done in the past, the raw extracts that were used, the chemicals that are present are the natural phytochemicals, which include caracol, terpene, sesquiterpene. Basically, the menthols and the phenols and the flavonoids are the basic ingredients which are present in these leaves that have antibacterial and anti-inflammatory properties. So they are, and according to my study, if I try to correlate it, it is bactericidal in nature as well. That means if we see the bacterial load in the children, the bacterial load that was evaluated before the intervention and after the intervention, there was a significant decrease in the bacterial load. So that means that along with the pH and increase in the flow rate, so as the flush rate of the oral cavity increases, it tends to reduce the overall bacterial load of the oral cavity.
Do you have checked the MIC of this extract, which are you claim as a bactericidal and all these things?
No,
MIC?
sir. No, sir, I haven't. I
No
would
check.
want to go in detail about the study further.
Okay. All the best.
Thank you, sir.
Thank you.
Right.
Next in the list is poster number
Next.
00242 00187.
A very good morning to one and all. Myself, Dr. Manmeet Kaur, and today I am going to present my poster on the topic COVID-19 saliva testing, a boon for healthcare workers. The world has been facing a global pandemic of COVID-19 since the past 2 years. And in this war against the deadly COVID-19, our healthcare workers are protecting us at various steps. The collection of nasopharyngeal swabs for the diagnosis of COVID-19 requires specialized healthcare personnel and is associated with non-negligible risk of viral transmission. Hence, the COVID-19 salivary diagnostic test is the need of the hour. Evidence states that the COVID-19 salivary diagnostic test has a mean sensitivity of 85% and specificity of 90%. Some drawbacks of the NPS: pharyngeal irritation, sneezing and cough during the sample collection, risk of viral transmission for the operator, requires specialized medical personnel. Advantages of the saliva test are rapid and reliable result, self-collection without any discomfort, no risk of viral transmission. The rapid salivary antigen test is a test based on the lateral flow assay identifying the spike protein in the saliva. The saliva is collected and applied to a sample pad of nitrocellulose membrane. Waiting time 5 to 10 minutes. When both the test line and the control line are visible, the test is positive. When only control line is visible, the test is negative. Uniqueness of antibody testing in saliva. presence of IgA antibodies, which are detectable earlier than IgM or IgG, possibly as early as 2 days after the onset of the symptoms, makes the antibody testing in saliva unique. Suitable settings for each salivary diagnostic procedure. First level point of need, first level screening at airports, cinemas, etc. Examples, lateral flow assay, smartphone based microfluidic system with biosensors. Second level point of care, examples, colorimetric artery lamp, Sherlock technology, Raman spectroscopy. Third level, hospitals, tertiary referral centers, centralized laboratory facilities, hospitals, etc. Conclusion, salivary RT-PCR provides relevant, reliable data that can be used in addition to the standard nasopharyngeal swab to detect the false negative cases by respiratory swab analysis, thereby increasing the overall sensitivity of the standard molecular-based testing. Moreover, it does not require specialized healthcare personnel and reduces the risk of the operator. Thank you.
Preeti ma'am, please.
Yeah, very good presentation. I just want to ask you that you said it is going to increase the overall sensitivity. So how do you justify that?
Ma'am, actually in saliva testing, the error of collection of the nasopharyngeal, if the nasopharyngeal swab is collected in a wrong way, or it is not collected like deep enough, or that human error is escaped, that technicality is escaped. The patient just have to collect the saliva and the test has to do its work. So definitely the true positive result will be improved for the saliva testing, ma'am, based compared to the nasopharyngeal swabbing and oropharyngeal swabbing, ma'am.
Okay, thanks. Thank you. Good presentation.
Thank you.
Next in list is poster number 00243.
Thanks to one and all. The topic of my poster today is Buzzy, a contemporary approach towards painless dentistry. Effective pain management is extremely important, especially in pediatric dentistry, to instill a positive attitude and deliver proper treatment to the child. A recent technology, Buzzy, that utilizes pre-cooling as well as vibration, has shown to have good results in that. Thus, the aim of the current study was to compare and evaluate the effect of vibration system and transcutaneous electrical nerve stimulation, that is TENS, on pain and anxiety reduction during injection of local anesthesia in children of 5 to 12 years of age. The ethical approval and patient and parent consent were taken. Selection of children was done based on the inclusion and exclusion criteria, that are children of 5 to 12 years of age having positive or definitely positive frankel behavior and receiving treatment on dental chair. Those children who had to undergo treatment in general anesthesia or had any systemic diseases or allergic to local anesthesia were excluded from the study. A total of 60 children were included in the study, who were divided further into 3 groups. First, receiving the vibration system, that is the Buzzy, as an intervention. Second was TENS, and third did not receive any intervention. These were further divided into 2 groups, receiving maxillary infiltration and inferior alveolar nerve. Initially, demographic data, modified dental anxiety score, preoperative pulse rate, and oxygen saturation levels were recorded to assess the preoperative anxiety levels of the children. This was followed by the intervention for pain and anxiety reduction according to the groups that they were allotted to. During the administration of local anesthesia, pulse rate and oxygen saturation were recorded to as an objective score, and FLACC and SEM score was done for the subjective score. After the treatment, the child was asked to fill up a VAS score to assess the discomfort felt by the child, and post-operative pulse rate and oxygen saturation was measured. Coming to the results, before the procedure, no statistically significant difference was seen in age or anxiety levels among the 3 groups. FLACC and SEM score that were recorded during the procedure, conventional group with no intervention showed the highest score, followed by TENS, and the least was shown by Buzzy. after the procedure, when the child was asked to administer the VAS scoring, they were most comfortable during the Buzzy procedure. Thus, it can be concluded that Buzzy as well as TENS can be used to elevate pain caused by the local anesthesia by increasing the overall pain threshold of the children. Thank you.
Sir?
Okay. Good question. Good presentation. The first question is, can you explain the Buzzy?
Yes, sir. Good morning, sir. Good morning to everyone.
Good morning.
So basically, Buzzy is a combination of vibration system and pre-cooling. So it has a body, and like I had shown the picture of it in the poster. So it has a body which is in the shape of the bee, like it's like the bee's body, and it has two wings, which is the ice pack. So basically, that ice pack needs to be kept in the freezer, and when we have to basically keep everything else ready, when we are ready to like start the process, start giving LA to the child, we have to take it out as the ice pack remains like can function properly for 10 minutes. So and we have to attach it to the body, and there's a button in the device up, like in the device only. So we have to put that on, and we have to put it like when I was doing inferior alveolar nerve block, it has to be kept 5 centimeter above the place insertion of your LA. So 5 centimeter above that, and it has to be kept there for 30 to 60 seconds, and then we have to start the procedure. So that is how it works, like basically. And it has to be kept throughout the procedure, basically.
Oh, great presentation. All the best.
Thank you so much.
Next poster is 00356, 00453, and 00537.
Predicting the future isn't magic, it's artificial intelligence. Good morning, everyone. Today, I will be presenting a poster on the role of artificial intelligence in oral diagnosis. In 1956, John McCarthy coined the term artificial intelligence, which is concerned with the computational understanding of what is commonly called intelligent behavior and the creation of artifacts that display such behavior. Growing interest in AI and machine learning in the diverse industries is mainly due to the rise of deep learning, a process through which AI recognizes the patterns using various forms of neural networks, which resemble the human brain. Nowadays, computer-based diagnosis in healthcare is also accelerating due to its ability to discern and diagnose lesions that may go overlooked to the human eye, thus resulting in holistic practice. In the oral medicine branch, AI can help analyze the data and thus provide reliable information and improve the decision-making process for diagnosing complex disorders. Genetic predisposition for oral cancer for a large population can also be detected by AI in the near future. Furthermore, it plays a key role in managing the patients by coordinating appointments and sending the reminders. In emergency cases, it also provides tele-assistance when the doctor is not present. In the oral pathology branch, for the pathologist, the effectiveness of cancer diagnosis is time-consuming, subjective, and inconsistent due to the inter- and the intra-observer variations. AI will, in the near future, not replace the pathologist, but by performing routine repetitive tasks quickly and accurately, allow the pathologist to give time to more complex cognitive tasks and enable them to play a much greater and effective role in cancer diagnosis and therapeutics. AI has various advantages, like identification of the normal and abnormal structures, diagnosis of the diseases, and prediction of treatment outcomes. It reduces the intra and the inter-observer variability, and it also reduces the cost. But where there are pros, there are some cons also. There are some challenges that we might face while working with AI, like management and sharing of the clinical data, safety issues, lack of technical knowledge, ethical and legal challenges also. There is a common perception that artificial intelligence will replace the doctors, which is one of the main reasons that they have been quite cynical in embracing it. In fact, the inclusion of these techniques will increase the efficiency of the specialists and contribute to better patient care. It should be understood that humans invented artificial intelligence, so it will never be able to enslave them in unfamiliar situations unless it is trained to do so. And if in a case when AI is not able to achieve its goal, it can become destructive and then AI would not be less than a devil. The use of AI should be viewed as a complementary asset to assist the dentist and the specialist. It is crucial to ensure that AI is integrated in a safe and a controlled manner to assure that humans retain the ability to direct treatment and make informed decisions in dentistry. Thank you.
Ma'am?
What do you think the artificial intelligence, is it going to replace the radiologist one day? What is your take on that?
Good morning, ma'am. I don't think that AI will replace, just because we have created AI and it is in our hand that how will we take it? Like, how much part of AI has to actually work? So I don't think that AI will replace the oral radiologist or any of the doctors. It's basically we are going to use a part of it and not let control the humans.
How is it going to help in conservative dentistry, artificial intelligence?
I'm sorry, I don't have idea about it.
Okay, good presentation. Thank you.
The next in line is poster number 00403.
The greatest enemy of knowledge is not ignorance, but the illusion of knowledge. Through this poster, I will be depicting two major controversies that shook the entire world of dentistry. One such controversy is the famous amalgam war, which was initiated in 1926 through the publication of Dr. Alfred Stock condemning amalgam restorations due to the health hazards caused by the inhalation of mercury vapors. This controversy was further carried forward by Dr. Huggins in 1970s, who once again highlighted the plethora of diseases caused by mercury toxicity, which included cardiovascular, neurological, immunological, and allergic disorders. Much of this controversy was fueled by media and scholars like Dr. Robert Atkins, who warned public masses regarding the potential dangers of amalgam restoration. Today, evident data exists regarding the mercury toxicity at much higher level than required for amalgam restoration. However, over a period of time, various aesthetic and mercury-free restorations have evolved, such as composites, which have entirely ruled out the amalgam restorations. Another major controversy was regarding the fluoridation of public water supplies that basically arose due to political, moral, ethical, economic, and health consideration due to water fluoridation. This controversy first occurred in 1950 in Wisconsin, where the opponents questioned regarding the efficacy and safety of these water fluoridation programs. The fear among public masses due to fluoridation was largely due to the reputation of fluoride-containing compounds such as insect poison, which contain much higher concentration than required for water fluoridation. Since then, water fluoridation programs have been subjected to multiple litigation and court cases wherein activists have sued multiple municipalities. Till date, no federal appellate court or state highest court have found water fluoridation to be unlawful, and nowadays it is a common practice among various parts of the developed nation. Thank you.
Sir, please.
Okay, so some good presentation about the side effects of the dental materials. Can you tell me which one is very safe materials today, and how do you segregate it from the previous one, the amalgam and the fluoridated kind of the programs?
So presently, the materials which are in market, they all are tested before they can be used on patients, and no, without safety testing, any of the material is not allowed by the allowed by the agencies in order to for the benefit of patient, and therefore the as I already stated that fluoridation program, they were better, and the amount of ppm of fluoride should be the priority on the central basis, so as we can reach maximum amount of population in order to reduce the incidence of dental caries.
Yeah, that's fine, but I'm asking the benefits of the current materials over the amalgam restoration, the which are replacing, that is composite restoration. Are they safe?
So the only the aesthetic consideration is the benefit for the patients. Otherwise, the
and the
competitive
concern of the health hazard, concern of the health hazard, not aesthetic one.
Sir, I think I would like to go with the composite. I would like to go with the amalgam restorations only as far as the health of patients are concerned, sir.
Okay, Khalid.
Sir.
Nice one. All the best.
Thank you, sir.
Yes, rightly said, 00403. The next in line is 00456. Please.
Hello everyone. Topic for my e-poster presentation is polycystic ovarian syndrome and its impact on periodontal health. Polycystic ovarian syndrome is a complex endocrine disorder which affects the women of the reproductive age group, characterized by the abnormal increase in the level of luteinizing hormone and follicle stimulating hormone, with the prevalence of 9 to 36% in India. Diagnostic criteria for polycystic ovarian syndrome includes polycystic ovary, which can be diagnosed by an ultrasound, oligomenorrhea and hyperandrogenism, which can be diagnosed by patient history and making some blood tests. Polycystic ovarian syndrome is also associated with insulin resistance, obesity, type 2 diabetes, and periodontal diseases. Many researches and articles on the same have also shown that PCOD leads to periodontal diseases, and the mechanism for it is such that PCOD leads to insulin resistance, hyperandrogenism, oligoovulation, and oligomenorrhea, which in turn leads to elevation of pro-inflammatory cytokines IL-6, IL-17, TNF factor alpha, leading to low-grade chronic inflammation, which ultimately cause periodontal diseases. Clinical parameters which are used to diagnose the periodontal diseases are gingival index, periodontal index, clinical assessment scale, and the proben test. Akali et al. By using RT-PCR and ELISA found the rise in the level of P. gingivalis, Ephneoplatum, Streptococcus oralis, and Tenerella forsytha in the women with PCOS. On examining the patient with polycystic ovarian syndrome who have not been under any treatment for the same have increased level of gingival index, periodontal index, clinical attachment loss, and the periodontal length. At the end, I would conclude that female diagnosed with polycystic ovarian syndrome and are not undergoing any kind of medical treatment for polycystic ovarian syndrome indicate greater likelihood for developing of periodontitis as compared to the healthy women or women undergoing treatment for the same. Thank you.
Ma'am, please.
Yeah, could you please justify your conclusion? I have not exactly understood that how in day-to-day practice you're going to diagnose PCOS. Can you just justify your conclusion, please?
Good morning, ma'am. Good morning, ma'am.
Yeah.
Ma'am, the PCOD is one of the disease that is most neglected even in today's scenario. So, if a female patient was coming and she is having PCOD, and a dentist is not aware about it, like even if the patient is not aware about it, and we are giving her a prophylactic treatment or anything we are doing, like there will be no results of the treatment because the patient even if the patient try to maintain it, then also there will be factors like there will be more plaque accumulation, there will be more inflammation, and they will not get the better prognosis for the treatment.
Okay, thank you. Okay.
All participants are requested to switch on their cameras during Q&A session, and they are requested to rename their IDs as their last 4 digits of registration number, please. Next in line is poster number 0048546.
A very good morning to all of you. The topic for the poster presentation is early functional, aesthetic, and the psychological rehabilitation of young child with a non-syndromic oligodontia, a case report. The registration ID includes 00485 and the 486. To introduce, missing teeth are the common developmental abnormality in humans. Early treatment and the follow-up are the key to successful rehabilitation of young patients with congenitally missing teeth. Mucosa bone removal prosthesis are the commonly selected treatment option for the young patient who present with the oligodontia or the anodontia. This clinical report described the aesthetic, functional, and the psychological rehabilitation of a young boy with severe oligodontia in maxillary arch and the anodontia in the mandibular arch. A treatment plan was made to fabricate the overlay denture for the maxillary arch and the conventional complete denture for the mandibular arch. As we can appreciate the first picture as a preoperative view, on the radiographic examination, it was revealed that the both permanent maxillary first molar along with the permanent maxillary left and right central incisor were present. Intraoral examination revealed severe atrophic knife-face mandibular ridge. As the patient was previously had been treated here in the department of prosthodontics, the previous denture was utilized for the primary impression. Following primary impression, the primary cast was obtained. Onto that, the special cast was fabricated. For the maxillary denture, polyether impression material was utilized for the final impression, and the mandibular impression was utilized for the green stick impression compound as well as the light body impression material. The baseboard transfer was done. Your lesson were taken, and the arrangement was done using the monoplane teeth, and the trine in the overlay denture was done. The second picture is describing the tissue surface of the overlay denture. As we can appreciate the incorporation of mesh into the maxillary denture and the poly surface of the overlay denture and the post-operative view. So coming to the advantage of overlay denture, it includes enhanced mastication aesthetics. Alveolar bone is maintained by the retention of teeth, increased proprioception, and compared with the complete denture because of retained teeth with the proprioception periodontal ligament. In comparison with the overlay over denture, denture is a common economical, needs less chairside time and does not require any specialized tooth preparation. It also has an excellent retention and the stability, as well as the positive psychological support to the child. Child may be saved from the peer harassment and resulting in the increased self-esteem and the confidence. Coming to the advantage of incorporating the mesh includes the more strengthened maxillary denture bases. And coming to the advantage of use of monoplane teeth, it will be having less horizontal forces, hence better masticatory efficiency. To conclude, the individualized conservative graded approach in the prosthetic rehabilitation with removable acrylic processes help to achieve the aesthetic functionality and the psychological benefit of the patient. Thank you.
Okay, good presentation. Yeah.
Your expertise.
Yeah. How do you eliminate this is a non-syndromic one? First question.
Sir, as the very good morning, sir. As the patient came to us, sir, first the clinical examination was done. Suppose the hair examination was done, nail examination was done, and her sibling examination was also done, sir. To rule out there was no deformation in the nail, skin, as well as the hair was present, as well as her sibling was also not present. Sir, we did the karyotyping. It was shown that the chromosomal aberration was 46XY, and that was normal. So, in collaboration with the sir, pediatric department as well as the medical side, we concluded that it was a case of non-syndromic oligodontia.
What could be the reason for this oligodontia?
Sir, several reasons have been attributed to the attributed for the oligodontia. It may be along with the syndromic, or it may be along with the non-syndromic. Coming to the sir syndromic cases, it might be along with the ectodermal dysplasia, along with the Rieger syndrome, van der Waals syndrome, and Down syndrome also. But non-syndromic oligodontia are attributed to the mostly to the gene factor, that is MSX9 and PAX1 gene, sir.
Okay. Second, the prosthetic part. This you put the monoplane occlusal scheme. What is the benefit? Benefit, you said, okay, this is the least lateral forces, but the patient is young. So how he chew and domesticate from this kind of the
sir, on the intraoral examination, sir, the mandibular ridge was very thin and the knife edge. If you could have used the anatomic teeth or the semi-anatomic teeth, more forces will be there, sir. That will be detrimental. That will be more detrimental in the future. So coming to going into a conservative approach, we use the monoplane teeth so that the less forces will be distributed to the ridge. Hence, better.
But for the young patient, because mastication is the main thing, na? So how can he masticate with the monoplane occlusion scheme and the non-anatomic teeth? So this is the main disadvantage, having such a huge kind of, you given a huge time of the denture, but patient is not masticating properly with this non-anatomic teeth. So this should not be for the young patient, I think.
Yes.
And monoplane occlusal scheme or the non-anatomical teeth are preferably given to the older patient, which are for the least mastication and the food taking ability is very less as compared to the younger ones.
Yes.
So this is, I think, you should take care for the next cases.
Yes. Thank you, sir.
Okay. All the best. Good presentation.
Next in line, poster number 00509.
Today, I will be presenting the poster on the topic Pediatric Silolithiasis, a case report. Silolithiasis is a formation of calcareous concretion in the salivary ducts or glands. Submandibular glands is one of the most commonly involved gland, and also predominance is seen among the boys. The main reason for the formation of silolithiasis is the salivary viscosity. If the viscosity of the saliva is thick and ropey, the chances of silolithiasis is more. Also, if there are large and curved duct present, there are chances of formation of silolithiasis. Silolithiasis is very rare among children, as the salivary flow among children is more and also faster. And also the formation of silolithiasis takes time. So formation of silolithiasis in children is very rare. In the present case report, the 10-year-old patient complained about swelling and pain in the lower left back region since 1 month. On taking history of present illness, it was found that the appearance of swelling and pain was only seen while having food. The patient also gave history of visiting a physician where he was given an antibiotic therapy, but no effects were seen. Hence, on clinical diagnosis, it was found that the bimanual palpation of the gland was quite painful and the gland palpated was swollen. Also, the hard stone-like palpation was seen near the proximal to the opening of the duct. Hence, on these clinical findings, we decided to take a radiograph and also a CBCT. The other investigations such as silography or MRI was not feasible or possible. So on taking the occlusal radiograph, it was found that 2 stones of 1 mm were found, one which was proximal to the duct and the other stone was distal to the duct. The distance between these 2 stones were found to be 9.6 mm. There are various treatment options which are suggested in the literature, such as Nally et al. Has given a treatment option of siloendoscopy. To T. Gonzalez et al. Given the option of laser lithoscopy. Marva et al. Gave the option of conservative therapy. Hence, in this patient, as it was 10 years old, we decided to take a conservative approach. In conservative approach, we asked patient to consume some citrus fruit or some orange candies, which naturally acted as in silogok. As these both the constituents were naturally available, it was quite easy for the patient to get them. And we also instructed the patient to consume lot of fluid and also to massage the gland after every meal. Follow-up was taken for 15 days and further after 2 months. In 15 days follow-up, it was seen that the distance between 2 stones were reduced and also the proximal stone was shifted little forward. Hence, after 2 months, it was seen that the distance was more reduced and also the size of the stones were reduced. After 2 months, the patient also did not give any complaint regarding swelling right after the meal. But still, the patient is further kept on follow-up to observe further radiographic changes. Hence, I would like to conclude that the conservative management of a silolith with very natural remedies should be always preferred, especially in case of pediatric patients instead of the surgical options. Thank you.
Ma'am, please.
Yeah, a good presentation. No questions.
Thank you.
Next in line is poster number 00517.
Good afternoon, everyone. My poster topic is on clinical approach to cheilitis granulomatosa, a case report. Cheilitis granulomatosis is a rare, persistent, painless, and idiopathic chronic swelling of the lip that is generally a manifestation of orofacial granulomatosa, and it is characterized by non-necrotizing granulomatous inflammation of both oral and maxillofacial teeth. Clinically, cheilitis granulomatosa represents a label enlargement and perioral and mucosal swelling, along with oral ulceration and gingivitis. A male patient, 45 years old, referred from Department of Dermatology with a complaint of swelling in the lower lip and upper lip for past 6 months. And also on examination, patient had a generalized conjunctival irritation with localized enlargement in lower and upper lip was found. In investigation part, we have done lung investigation, chest X-ray, and non-test text, which were negative, and biopsy was performed in the lower label mucosa. This area indicates the site of lower biopsy done, and histopathological examination shows a presence of peri and paravascular inflammatory infiltration in the fibrous connective tissue. Along with that, few non-caseating granulomas with Langerhans cells type of giant cells are seen. The overall conclusion gives an impression of diagnosis of granulomatous cheilitis. And after that, treatment plan was done along with opinion given by dermatology. Medications were given like antihistamine, topical corticosteroids, and along with that, clofazimine, that is an anti-leprosy drug, which was given for the patient for 2 weeks. The post-treatment part, patient were reviewed after 2 weeks, and there was the swelling of the orofacial region and the enlargement of the lower and upper lip has been drastically reduced. And in the discussion part, the orofacial granulomatosis is an increasingly recognized disease, where the etiology is not known, and therefore precise treatment and long-term prognosis remains uncertain. And also, the cheilitis granulomatosa has no predisposition to any race, sex, or age, with incidence rate of 0.08 in the general population. The differential diagnosis for this cheilitis granulomatosa are Provence disease, vaginous granulomatosis, and sarcoidosis, etc. The clinician should know about the proper history and along with the clinical features and histopathogenesis of this disease should be known to the clinician, and to provide a various treatment mode like surgical or radiation depending on the facial risk determined. Coming to the conclusion, the present case highlights mainly the thorough investigation in the diagnosis of the lesion, and clinicians should be very aware of this unpredictable nature of the disease, and further emphasis should be given on long-term follow for the patient. Thank you.
Jaya Chandran, please mute yourself if you are not poster number 509. Yes, sir, please.
Okay. My question is, what is the cause of this? There is another angular cheilitis. The name of this is angular cheilitis. What is the cause of angular cheilitis? Mentioned in your DD. Do you know angular cheilitis? Hello, participant.
Is poster number 00509 is present? Please respond.
Ma'am, my presentation is already done.
Sorry, 00517.
Just who presented just before? No, she is not responding, I think.
Oh.
Okay, next. Okay, next presentation, please.
Participant is saying, sir, she is not allowed to talk.
Hello?
Vetri Vimal. Please allow her, Vetri Vimal.
Okay.
Okay. We move to our next presentation. Poster number 00517, please. Jaya Chandran, please mute yourself.
Ma'am, it is 518. The next presentation.
Okay. Presentation number 00518.
Yes, ma'am.
Please start.
Good afternoon, everyone. I'm going to present a case report of an atypical appearance of odontogenic keratosis cyst. It is a rare and benign but locally aggressive developmental cyst. It is reclassified from keratocystic odontogenic tumor due to its marked evidence of morphogenesis and biological behavior. Now coming to patient description, a 34-year-old male reported the department with a chief complaint of pain and swelling in the right lower back tooth region for 15 days, in which the swelling is gradual in onset. On examination, externally, there is a mild swelling in the right mandibular region, extending slightly below the lower border, which is tender on palpation and firm in consistency. On intraorally also, there is a swelling in the right tetramolar region, extending upwards behind the maxillary tuberosity, which is soft in consistency and tender on palpation. Investigations of aspiration and biochemical analysis of aspirated fluid and cholesterol crystals evaluation in aspirated fluid microscope and external radiographs of orthopantomogram and CBCT are taken. And the aspiration revealed the positive aspiration with purulent material and blood mixed with it. And biochemical analysis of aspirated fluid revealed the total protein content of 5.8 gram per deciliter, which correlates the case report of odontogenic keratosis in literature. And cholesterol crystal evaluation in aspirated fluid appeared as a new open book appearances. And the orthopantomogram revealed the radiolucency extending from the vertically impacted teeth of 4-8 to up to the sigmoid notch. But this is a OPG which is taken after the incisional biopsy and removal of vertically impacted teeth. On 3D reconstruction, there is a osteolytic destruction of acylgramus of the mandible. This is a coronal section which is showing the radiolucency with minimal cortical bone expansion surrounding the unerupted tooth. This is axial section which is at the level of cervical region of the adjacent teeth. And then the patient referred to surgery department. Then they have planned, in where they planned for a cyst enucleation and application of cornized solution. As per histopathology, it is diagnosed as odontogenic keratosis of right posterior border of mandible. Let's coming to discussion. In 25 to 40% of the cases, there is an unerupted tooth involved in the lesion. On panoramic radiography, mandibular unilateral odontogenic keratosis may show few or incomplete septae within the lesion, but this is more common in larger cases than in smaller. Then why it is called atypical is because of its absence of multilocular appearance and absence of scalloped border and absence of septum. Let's say conclude that definitive diagnosis of cases on a clinical and radiographic basis is not possible. But with the appropriate and advanced imaging modalities, we can strongly suspect this entity and assess the necessary treatment protocol for this aggressive tumor. These are my references. Thank you.
What about the histopathology? You have not elaborated on that. What about the parakeratinized and the orthokeratinized variants? Because there is a different behavior of these two, the parakeratinized and the orthokeratinized. Can you just briefly summarize what I'm saying? How is it different? Which is more aggressive? I could not see a very good histopathology picture also in your poster. Can you please elaborate?
Ma'am, good morning to all, ma'am. As per my part, we have done many investigations from my oral medicine and radiology department. In histopathology, they appeared as a parakeratinized and picket fence appearance, ma'am. And there are also cholesterol crystals seen in this aspirated fluid, ma'am.
No, cholesterol crystals, they are not diagnostic. They may be seen in radicular cyst. Also, it was just an inflammatory or odontogenic keratosis. That is why you could appreciate those. Okay, thank you. Okay.
Okay, ma'am. Thank you, ma'am.
Next poster is 00580.
Extending my sincere regards to the esteemed judges of the panel, I would like to begin my presentation with the topic Basal Implants, a boon or a bane for atrophic ridges. Basal implantology was applied in practice in 1972 by Dr. Jean-Marc Juliet. In the mid-1980s, French dentist Dr. Gerard Sortecki improved the system with matching surgical tools and called them disc implant. They are the implants that employ the basal cortical portion of the jaws for implant retention. There are mainly four types of basal implants available as the screw, disc and the plate form. The screw form includes the compression screw design, bicortical screw design and the combination of both. The disc form includes the basal osseointegration or transosseous implants, also called as lateral implants. They are mainly indicated when several teeth are missing or extracted, when bone augmentation has failed and in patients with severe atrophy of the jawbone. Here, a case of 66-year-old male patient with severe atrophy of the jaw is included. He was wearing dentures for the last 40 years. 5 years ago, he was given implant-supported mandibular overdenture but was unsatisfied. Therefore, tuberopterygoid screws and BCS implants were placed for him into the sinus floor bilaterally. This avoided the need for sinus lift procedure in addition to providing support for the posterior maxilla. For the mandible, the inferior alveolar nerve was bypassed and the implants were placed posteriorly to the mental foramen, thereby avoiding the bone augmentation in the atrophied region. These are basically the advantages of this technique. However, everything comes at a cost. As observed, there are numerous disadvantages such as lack of osseointegration, compromised aesthetics, and overload osteolysis if the load is not distributed properly. So in conclusion, whenever there is robust surgical procedures are involved, this implant system comes to the rescue and they fits the principle of primum nihil nocere, which is the first do not harm. However, despite of the data available on their success, more concrete data is required to prove it a revolution or a revulsion. Thank you.
Sir.
Okay. Can you tell me, explain the overload osteolysis? And because this is the main disadvantage of this basal implant system. And sometime patient may come after the fracture of the jawbone, like mandible or maxilla. So how do you explain overload osteolysis, and how can you minimize during placing the basal implant? She is not responding. म्यूट तो नहीं कर दिया इसको?
Mr. Ranjan, please देखेंगे poster number 00580.
580.
Co-participant 00581 present है यहाँ पे, वो आंसर दे सकते हैं प्लीज?
Vessel implant 1. No, she is not there.
I think she is not there.
Okay, next.
Okay. We are moving to next poster, that is 00581.
Ma'am, I think it's wrongly written because it's repeated. I think the next is 668, what I think is.
No, there are two participants.
Okay, but the numbers somehow are same, 00581 and 00. Okay, they are alternated.
Yeah.
Okay, right.
Next
right.
poster is 00581.
Okay.
Elders and respected judges of this esteemed panel, the subject of my presentation is self-inflating soft tissue expanders, a controversy or a panache. These expanders were first described by C. Radovan in 1982 as a method of creating soft tissue with minimal scarring and little donor side morbidity. Charles D. Newman was the first who mentioned its potential for reconstructive surgery. Later in 1982, Oersted and Rose first described the osmotic tissue expanders. The osmotic self-filling expander is made of polymeric methyl methacrylate or vinyl pyrrolidone ensheeted within a silicone shell. The use of these expanders are indicated in various surgical procedures that include augmentation of restored edentulous ridges, bone regeneration, and onlay grafting procedures, and also in intraoperative procedure in cleft lip surgery. Under local anesthesia, a submucosal patch is created with the help of a small incision without leaving the periosteum for easy insertion and removal of the expander. Proper stabilization of the expander is achieved. It can be removed after 2 weeks. The self-inflating stage takes about 40 to 60 days to complete, followed by its termination. It involves combination of properties such as creep, mechanical, and biological stretch, but in triphasic swelling, the tissue is stretched without affecting the quality of the original tissue. Advantages of this includes better wound closure without compromising the blood supply and eliminating the need for harvesting connective tissue graft. But the complication comes in hand with it, such as hematoma, deflation of the expander simultaneously or iatrogenically, migration of the expander, and pain during removal. Thus, with the use of these expanders, improvement in quality and quantity of the soft tissue can be achieved. However, more clinical trials authenticating in intraoral use is needed to bring out such a promising option forward. Thank you.
Ma'am, please.
Can you please explain how is it a controversy? The presenter, you have written it now. It's a controversy. Why do you think it is a controversy?
I think both the presenters are absent, ma'am.
Okay, let's go ahead then.
Next poster is 00668.
Greetings everyone. Title of my today's presentation is Forensic Periodontics and New Horizons. Forensic odontology is an ever-evolving science which deals with collection, evaluation, processing, and presentation of the dental evidence with respect to justice. Forensic odontology has a fair share of significance in the field of forensic sciences due to the unique ability of the oral and the perioral structures to withstand extreme conditions when compared to other parts of the body. As the anatomy and the physiology of a child differ from that of an adult, it is very important to know the pediatric aspects of forensic odontology. So the various applications of forensic periodontics include the personal identification, which can be done by DNA analysis. The various sources of dental DNA include the tooth, especially the cells of dental pulp, cells from the oral epithelium, and cells collected from the saliva sample. Comparison of the antemortem and the postmortem clinical photograph, dental cast records, and dental radiographs by blood group analysis, studying of the palatal Ruge pattern known as rugoscopy, studying of the lip print pattern known as cilioscopy. An age estimation, which can be done by assessing various eruption and shedding sequence of the teeth, various
materials used are
foliation stages as seen in hand-based radiographs and skull radiographs, and also various tooth calcification stages, biochemically by the amino acid chromatography, histologically by counting the cementum annulations. Various authors have devised various methods for age estimation, which includes the Dermisian's index, Gustafson's method, and Johnson's index. Then sex determination can be done by amylogenin gene chromosomal mapping for the presence of X and Y chromosomes. Then also assessing the cells collected from the oral cavity for the presence of Barr bodies, which is an inactivate X chromosome present in the females. And also by noting the morphological differences of various teeth in females and males, especially the canine dimorphism. The other major application of forensic periodontics is the crime investigation, especially in the cases of child abuse and neglect, which can be identified by various features, which include the unexplained burns, intraoral lacerations, intraoral phenum tears, retinal hemorrhages, hemorrhage behind the ear, fractures of various facial bones, nasal displacement. In case of bite marks, the analysis can be done by metric analysis of the bite mark, taking impression of the surface and fabrication of the models and comparing it with the suspect models. Thank you.
Okay.
Poster number 00668 is present.
Yes, ma'am.
Yeah.
Good morning.
Okay. Only one question. How do you differentiate this forensic periodontology with the adult forensic periodontology? What are the difference, basic different kind of parameters?
So basically, coming to the tooth sizes, the tooth dimensions are different. The various tooth calcification stages are different in case of children, and also coming to the skull radiographs and also hand-based radiographs, there are different calcification stages of the bones. So that is what the difference that need to be noted regarding the anatomy and the physiology.
In the physiology and anatomy.
Anatomy.
Any difference within the karyotyping? what cells are need to become after the eruption and the completion of the primary teeth and the before permanent teeth? Any changes in the serological type?
So there are no significant changes in the serology typing. It is mainly the calcification stage and the translucency of the calcified structures that makes
That is
the difference.
already
And also
already
the
anatomical.
neonatal lines and the incremental lines which we can see.
Okay. Thank you. All the best.
Thank you, sir.
Next poster is 00451.
Greetings of the day. I am here to present a poster on hybrid ameloblastoma, clinico-radiologic and histopathologic correlation. Ameloblastoma is the most common odontogenic tumor and accounts for 18% of all odontogenic tumors, with peak incidence in the 3rd to 4th decade of life. Hybrid ameloblastoma is defined as a rare histopathological variant, including combination of classic follicular or plexiform type, along with areas of desmoplastic type. Depending on the type of ameloblastoma, imaging features vary from unilocular to multilocular lesions with a characteristic soap bubble appearance. A 75-year-old male patient presented with the chief complaint of swelling on the left side of the lower jaw for the past 4 months. Patient gave a history of jaw surgery 12 years back for a similar complaint, and he had biopsy records showing a previous history of plexiform ameloblastoma, which was conservatively managed. Here we can see the clinical image showing the swelling in the lower left alveolus with displaced tooth 3-5. The provisional diagnosis was given as recurrent ameloblastoma in the left mandibular region. OPG reveals a multilocular radiolucency with mixed density involving the left side of the mandible from tooth 4-3 region to the distal part of tooth 3-8. There was a floating tooth appearance in relation to 3-5, and there was involvement of the mandibular canal and discontinuity of the lower border of the mandible. The CBCT scan shows a mixed hyperdense and hypodense lesion in the left mandible extending from 4-3 region to the left anterior border of ramus. There was bicortical expansion that is seen with greater expansion on the buccal side. Internal structure showed a multilocular appearance posteriorly and a honeycomb appearance in the anterior mandible. Coronal section showed discontinuity of the lingual cortex near the lower border of the mandible. Here we can see the histopathological pictures. A represents the desmoplastic areas, B represents the acanthomatous areas, C represents the plexiform areas, and D represents the follicular areas. So discontinuity of the lingual hybrid ameloblastoma in the left mandibular region. Conventional radiographs like orthophantomographs show distinction only between the tumor and the normal bone, whereas extension into the soft tissue cannot be determined. Here, CBCT scan is of higher diagnostic value. So the 4 classic radiographic features of ameloblastoma that were seen in this case were expansion of the cortical plate, presence of the corticated scalloped margins, multilocular appearance, and the resorption of adjacent tooth roots. So since here the confirmation of clinical diagnosis was done with the use of an incisional biopsy. Hybrid ameloblastoma, being a rare histopathological variant, has an incidence of only 1.1 to 4.3% of the total ameloblastomas. So the most common treatment plan is advocated as resection, and this patient is also planned for surgical management of the lesion. If the case is not severe, a conservative approach like enucleation and curettage is followed. Thank you.
What is the significance here? Like you were saying, it is hybrid ameloblastoma. So how will the treatment plan for the patient differ? If I am a pathologist, I'm signing it out as hybrid ameloblastoma, and I'm writing all the types which you mentioned. So is it going to help the surgeon in any way? Can you explain how is it going to affect the treatment plan, or is it not going to affect? And second question is, which is the most aggressive type of ameloblastoma? 2 questions you have to answer.
Good morning, ma'am.
Yeah, good morning.
In case of hybrid ameloblastoma, the progression of the disease is more severe as there are the different variants present. And acanthomatous type is known to be the most aggressive type of ameloblastoma that's seen. Both follicular and plexiform histopathological forms of ameloblastoma are the most common forms. And when it comes to acanthomatous type, when there is, in this case, as we see that there was an initial history of plexiform ameloblastoma 12 years back. So then after that, whenever there is a recurrence of the ameloblastic lesion, generally there is a tendency for it to go acanthomatous change with squamous metaplasia and desmoplasia, which leads to the occurrence of a hybrid ameloblastoma. That's why it's a rare condition. And in case of the treatment plan, we would for hybrid ameloblastoma, the most preferred treatment plan is resection with a margin of at least 1.5 to 2 centimeter of healthy bone. And there should be an annual follow-up for about 5 years, both radiographically and clinically, and followed by a 5-year biannual follow-up clinically and radiologically.
Okay, thank you.
Thank you.
Last poster of today's session is 009393.
Good morning, everyone. This is Dr. Kirtana, second year postgraduate. Our topic for today's poster presentation is SLA, a guide and lead. SLA is defined as a process of creating a 3D outcome by using a UV laser beam to convert a liquid polymer resin to 3D structure by curing it layer by layer. And here comes the procedure. 3D CAD model, STL file, slicing software, layer slices and toolpath, 3D printer, and 3D object. Out of lot of formats used in this 3D printing, the most commonly used file format is STL file format. So the whole ideology behind this poster presentation is to elevate the importance of stereolithographical file format and its important applications in the dentistry. So what is STL? STL is nothing but storing the information of the 3D models by using a simple concept called as tessellation. Tessellation is nothing but slicing software which helps in tiling the surface of the object with different geometrical shapes without any overlaps or the gaps. This is nothing.
సిగ్నల్ దొబ్బింది ప్లే అవ్వట్లేదు.
Mr. Ranjan, poster stopped.
Good morning, everyone. This is Dr. Kirtana.
Can you jump it, please? Can you jump
it? Topic for today's poster presentation is STL file, slicing software, layer slices and toolpath, 3D printer, and 3D object. Out of lot of formats used in this 3D printing, the most commonly used file format is STL file format. So the whole ideology behind this poster presentation is to elevate the importance of stereolithographical file format and its important applications in the dentistry. So what is STL? STL is nothing but storing the information of the 3D models by using a simple concept called as tessellation. Tessellation is nothing but slicing software which helps in tiling the surface of the object with different geometrical shapes without any overlaps or the gaps. This is nothing but tiling of the house floors. So coming to the applications of stereolithography, it is used in smile designing. It is used as a depth guide in the veneers. It is used in guided endodontics in the calcified canals. It is used in the osteotomical guide, and it is used in internal resorption cases and also the surgical guide in the apical surgery. So why not use this idea in our dentistry by giving a post and code? These are the two case reports which have been used to give the post and code. In the first case, the patient has been presented with a lot of gross structure, tooth loss structure with the classical case of apical periodontitis. And here the treatment plan was to give a post. So in order to avoid the compromising of radicular dentin removal, this hybrid post has been emerged. And the case procedure is done in this way. Taking the GP of ProTaper F2 and F3, blue light scanner has been used to scan this GP, and this is the CAD design, this is the metal laser centering, and the hybrid post has been given. And coming to the case, the working length has been taken, obturation has been sectional in the distal canal, and post has been placed without lot of post space preparation and removal of the radicular dentin, and the core has been given. So this is the post-operative picture of the patient after treatment. In the second case, the DigiPost has been given. In this, the patient has been presented with the class 4 Ellis fracture due to the trauma. And here the post-space preparation has been done. After that, CBCT image has been taken, STL file, extracad images of this STL file, and complete DigiPost along with the crown and the post has been given to the patient directly without any wax pattern preparation and casting errors. So why does it matter? It eliminates the need for the lab scanners. It has a faster turnaround. It gives entirely digital workflow, reduced chairside time, improved guide fit, and reduced casting errors along with the manual errors. So, conclusion of this poster is that using the stereolithography in the innovative ways, it allows for the more predictable clinical outcomes and improved efficiency of the treatment. Thank you.
Sir?
Actually, was a good presentation, but very fast. The speed was very fast. She was explaining and skipping at the time. Okay, can you tell me what is the role of SLA in the implant dentistry? The placement of implant?
Yes, sir. In implant dentistry, it is useful for designing the depth guide so that we can use the drills properly without any damage to the nerves and all, and without more removal of the bone and accurate placement of the implant in the position without removing more bone, sir. So it will give a proper osteotomical procedures without excessive amount of removal of bone and without any errors in placing the implant, sir. We'll get the dimensions along with the report if we give for the CBCT scan. So it is very important in implant placement also, sir.
Second question, in the second case, you're showing the kind of the post and core system, no? So
Yes,
post and
sir.
core system, what are the benefit to remain the circumferential dentine around the root canal?
Yes, sir.
GP,
Actually,
post.
yes, sir. In the first case, we have done post and core in the molars, sir. Usually for the molars, if you apply the metal screws that we get commercially, we tend to remove it with the GG drills and piezo reamers, lot of dentin, sir. So in order to avoid this, the exact pro-taper shape that we have prepared while doing the root canal, that pro-taper itself we are sending for blue light scanner, sir. So the post we get is very thin. It's not that broad. So it is unnecessary to remove the radicular dentin with the piezo reamers because it exactly replicates the shape of the pro-taper GP point that we have placed for the obturation. So we are doing it with sectional obturation with the GP, and we are cutting the sectional amount, that is to get the perfect snug fit without removal of the radicular dentin, sir. This avoids the excessive removal of radicular dentin so that strength of the tooth remains good. Instead of using the fiber post or metal post and removing the lot of dentin with the piezo reamers, it gives a proper amount of removal of without any removal of radicular dentin. It gives a perfect snug fit, sir. So we are opting for this hybrid post.
Good.
Thank you, sir.
This concludes our session. On the behalf of entire organizing team, I would like to extend a very hearty thanks to all the presenters for gracing your important work and sharing with us for your findings and opinions today. I would like to thank our distinguished judges for making this scientific session thought-provoking and very meaningful. We are highly obliged with your presence. Kindly accept these certificates as token of gratitude from entire organizing team.
Thank you, Dr. Thank you, Dr. Babita.
Welcome.
Thank you so much, the organizers. Thank you so much, Dr. Deepika and Dr. Babita.
Thank you so much, ma'am. Result of this session will be announced during valedictory function. Thank you so much for your cooperation. Stay safe, stay healthy. Jai Hind.
Jai Hind.
Thank you. Thank you all.
I request Dr. Bushra to start the next session without any further delay.
Okay, good morning, everyone. I feel proud and extremely overwhelmed to be part of Faculty of Dentistry, Jamia Millia Islamia, where we are not only taught within the four walls, but also beyond. It gives me immense pleasure to welcome everyone on the day 2 of DENTOCON. I feel privileged and honored to be given this opportunity to welcome our judges and all the dignitaries. I welcome Dr. Shamimul Hassan Sir, Professor, Oral Medicine and Dental Radiology Department. Sir is a keen academician. He has more than 11 years of experience and has received various awards and is actively involved in conducting national level conferences and CDEs. I welcome you, sir. Moving on to our second judge, Dr. Pooja Dudeja, ma'am, Professor from Conservative and Endodontics Department, ESIC Dental College, Rohini. Ma'am has more than 17 years of teaching experience and has been awarded Dr. Satya Bharat Memorial Award in the year 2019 and R.C. Katkar Award in the year 2005. She has been involved in conducting various national level conferences and CDEs. I welcome you again, ma'am. With your due permission, now moving fast towards our UG poster presentation.
Yes, you may start.
Thank you, ma'am. DENTOCON 0078, our first UG poster presenter. Please. Unmute yourself and start presenting. Good morning, ma'am. 0078.
Good morning, ma'am.
UG poster. Student, please start
Good
presenting your
afternoon, everyone.
poster.
I'm going to present a poster on silver diamine fluoride, a game changer or just a fad. Silver diamine fluoride, a cavity-fighting liquid, let kids avoid dental drills. SDF recently gained approval from US FDA in August 2014 for its arrest of dental decay. Its composition at pH 10 is 25% silver, 8% ammonia, 5% fluoride. That is why it is known as 38% SDF, which is most commonly used and also available in India as ESDF. Other globally available concentration are 12% and 30%. Its mechanism of action. Silver ions act on bacteria as they are broad spectrum antimicrobial, and these ions act as tiny silver bullets that damages bacterial cell wall and disrupts bacterial DNA synthesis and replication. These killed bacteria act as a carrier for silver ions and can kill living bacteria in a process known as zombie effect. Fluoride contributes to remineralization and fluoroapatite formation, producing harder, more caries resistant to the structure. Silver fills the microtubule and prevents dentine hypersensitivity. SDF also inhibits collagen degradation by blocking matrix metalloproteinase and proteolytic enzymes. Its method of application. First of all, remove gross debris, isolate the tooth, apply a drop of SDF with the help of microbrush on affected area for about a minute. For interproximal area, use floss for SDF application. Leave for 3 minutes and clean the excess. Its indication, high caries risk patient, cavitated caries lesion presenting with behavioral or medical management challenges, dentine hypersensitivity. Contraindications, exposed pulp, silver allergy, open oral sores like herpetic gingival stomatitis. Advantages, no aerosol generation, painless and non-invasive, simple, cost-effective, ease of application. Disadvantages, irreversible dark stain, metallic taste, gum irritation. Emphasis of SDF in COVID-19. It prevents aerosols generation, minimally invasive, treatment sessions are short, so helps in controlling spread of infection during pandemic. Conclusion, at its last, SDF is a new black magic that shifts surgical management of dental caries to medical management. Thank you.
Any questions, please? Shamim sir or Pooja ma'am.
A good presentation. One question from my side. Is there any way to prevent the black staining associated with silver diamine? Good morning, sir.
Good morning, sir. Sir, for the black staining, we can use potassium iodide, but it has not given a good result. But we can use a smart technique, silver modified atraumatic restorative treatment. In that technique, we use silver diamine fluoride to arrest the caries, and we can use GIC for the restoration so that it will give aesthetic results also and prevents the discoloration.
Okay.
Thank you, sir.
Can you tell me, am I audible?
Yes, ma'am.
Can you tell me the mechanism of action of fluoride as an anti-karyogenic agent?
Ma'am, fluoride helps in remineralization because it's help in the formation of the fluorohydroxyapatite crystals, which is at this bacteria. Ma'am, it acts in less critical pH. It has less critical pH, so it helps in remineralization and forms the hard enamel and dentine. So it helps in preventing arresting the caries.
Hard enamel and hard enamel basically and dentine because of formation of what?
Ma'am, fluorohydroxyapatite crystals, and it also form calcium fluoride. Ma'am, calcium fluoride. So it acts as a reservoir, and it helps in pH regulated fluoride supply.
It basically forms fluoroapatite, and there are two more mechanisms. Can you elaborate?
Ma'am, two more mechanism of silver and
no, two more mechanisms of fluoride acting as an anti-karyogenic agent.
Ma'am, fluoride contributes to remineralization by forming fluorohydroxyapatite, and ma'am, it also forms calcium fluoride.
Okay. Just explain the zombie effect to me once again.
Ma'am, in zombie effect, when we apply this karyogenic agent, karyostatic agent SDF, then these bacteria are killed by silver because it is antimicrobial. But these killed bacteria also act on the other living bacteria and kill them. This effect is known as zombie effect.
Thank you.
Thank you, ma'am.
We can move on to the next poster.
Yes, ma'am. I'll now call upon the next number 00269. Please start presenting your poster.
The topic for presentation is CAD/CAM dentistry, computer-aided design and computer-aided manufacturing. CAD/CAM is a field of dentistry and prosthodontic using computer software to improve the design and creation of the dental restoration, especially dental prostheses like crowns, RPDs, and FPDs. Uses the computerized engineering to give an incredibly precise and realistic finish to a product. It allows dentists to take perfect measurements and images to design the product in short span of time. Let's move on to the principles of CAD/CAM system. All CAD/CAM systems consist of three components. First, a digitalization tool that transforms geometry into digital data. It includes scanners and data collection tool that measures three-dimensional jaw and tooth structures, then transforms them into digital data sets. Basically, there are two different scanning possibilities. Optical scanners, which are completely digital, example LavaScan ST and laser beam. And second, mechanical scanners like the Porcera scanner. Second, the design software that processes the data and produces a dataset for the product to be fabricated. With such softwares, crowns and FPD framework can be constructed, designing a full anatomical crowns or partial crowns, inlays, and telescopic primary crowns. Third, a production or a processing technology that transforms the dataset into the desired product. The construction data produced with the CAD software are converted into the milling strips for the CAM software, and finally loaded into the milling device for production of final prosthesis. Moving on to the materials used in the CAD/CAM processing. Depending on production system, some milling devices are specifically designed for the production of zirconia frameworks, while others cover the complete palette of materials from resin to glass ceramics and high-performance ceramic. The materials normally processed by CAD/CAM system include metal, resin material, silica-based ceramic, infiltered ceramic, and oxide ceramics. To list the advantages of CAD/CAM, eliminates the impression making and model preparation procedure. Chairside manufacturing of the restoration is possible, thus saving the patient as well as clinician's time. Cross-infection control is possible. Excellent aesthetic, marginal integrity, and shade stability. better flexural resistance, precision fitting, and occlusal analysis, giving a long life to the restoration and complete patient satisfaction. But there are a few drawbacks too: need for costly equipments, need for extended training, technique sensitivity, and inability to image in a wet environment. Now, to conclude with, CAD/CAM technology has become a core part of dentistry. All ceramic restoration fabricated using this technology tend to be expensive but more stronger and tougher. Hence, day by day, it is gaining more popularity. Thank you.
Any questions? Sir, ma'am?
Good presentation. No questions, please.
Ma'am?
No questions, please. Thank you.
Now we will be moving on to our next presenter, 695.
Hello everyone. Our poster today is based on something that easily escapes our focus but carries a lot of importance in our day-to-day life. Today, we will be presenting a poster on the topic of the circadian cycle and how it affects the oral cavity and how we can use that information to come up with more holistic ways of treatment. Have you ever considered why nighttime is considered as the time to sleep and daytime is considered as the time to work? Who decides these things? Well, the answer to this lies in our very own bodies. Most physiological processes in mammals display circadian rhythms that are driven by the endogenous circadian clock. The master of the central clock is located in the hypothalamus and is called the suprachiasmatic nucleus, whereas clocks in other parts of the bodies are referred to as peripheral clocks. So where does the oral cavity come in? Teeth play a major role in satisfying the basic human need of food uptake. Several observations strongly suggest that dental demineralized tissues formation is under the control of a complex biological clock. In our study, we aim to see the variations in the form and function of the oral cavity with respect to the circadian cycle and ways to tailor the care of the oral cavity around the circadian clock. The objectives of our study include to study the relationship between the condition of the oral cavity in night and day shift workers and to study the potential of the circadian clock in the treatment of the conditions of this oral cavity. The method employed to carry out this research included sending out a structured Google form in recording the relevant responses of night and day shift workers assessing the condition of the oral cavity. The results were then assessed and statistical analysis were performed and conclusions were drawn.
The results that were obtained were as follows. Our research focused on 4 main parameters that included gingival bleeding, pain in teeth, reasons for tooth loss, and smoking status. 6 day shift workers said that they experienced gingival bleeding sometimes, whereas 1 said very often. As opposed to this, 10 night shift workers reported that they experienced gingival bleeding sometimes, with 4 saying that they had it always and 2 saying very often. Coming on to pain in teeth, 8 day shift workers reported having pain in teeth sometimes, whereas 11 night shift workers said the same, with 4 saying very often. When inquired about tooth loss and reasons for the same, it was found out that the average tooth loss in both the groups was around 2 to 4 teeth, but the number of people in whom all teeth were present was found to be marginally higher in day shift workers. Smoking status inquiry showed that almost half of the people surveyed were smokers in the night shift group. 16 people were active smokers, whereas 4 workers used to smoke in the past. The habit of smoking was much less in day shift workers. Only 4 admitted to smoking in the past. This increased trend of smoking in night shift workers indicates a staunch reason for their poor oral health. These results show a clear picture about how different the conditions of people working in different periods of time can be. The circadian cycle can't be denied as having a role in this. Thus, there is a need for coming up with more holistic ways to treat the conditions of such patients by tailoring the treatment plan around the circadian cycle. Chronodentistry is that holistic tool. In periodontics, the raised interleukin-1 beta levels in clavicular fluid are considered as markers for gingivitis or periodontitis, and decreased levels correlate with successful therapy. Interleukin-1 beta levels show variation during day and night in people without periodontal inflammation. To conclude, there is evident disparity between the oral health conditions of day and night shift workers. This suggests that the circadian rhythm plays an important role in the maintenance of form and function of the oral cavity tissues. Thank you.
Any queries? Any questions? Ma'am and sir.
Yeah. Does a brain have nerve supply? Participants? Presenters?
Both the participants.
Hello, ma'am. Good morning.
Good morning.
Am I audible?
Yes.
Yes.
Yes. Ma'am, brain does have nerve supply, and it is the source of all the nerve supply in the body also.
Do you know when neurosurgeons perform surgeries, brain surgeries, they don't give anesthesia because brain tissue does not have nerve supply. Anyways, can you just explain the reason for circadian rhythm?
Ma'am, good morning, ma'am. Ma'am, the circadian rhythm is present because of the main regulating hormone, which is melatonin. So the changes in this hormone regulate the different systems in the body, causing changes during the day and during the night. So, ma'am, for example, the gingival clavicular fluid, it shows an increase during the daytime till the nighttime, and then following that, there is a continuous decrease in this gingival clavicular fluid.
Okay, thank you.
Okay, two questions from my side. Can you associate any disorder which is associated with the circadian rhythm that has definitely oral manifestations?
So disorder as in?
Means clinical implication क्या है इसकी?
Sir, tumors are actually, we can use the circadian rhythm when it comes to tumor biology, because angiogenesis, cell growth, all of that is related to the circadian clock. So it has been found that there is a growth in cells at certain points during the day, and then a subsequent decrease in the turnover of cells during the night time. So when it comes to tumors of the oral cavity, we can
tumors like
tumors like maybe squamous cell carcinoma, because it is a malignant tumor. So there could be a different turnover of cells during the daytime, which causes an increase in the amount of cell growth.
Okay, and if you want to shift this study to a clinical setup on patients, what will be your biomarker? I mean, what you going to test? Any hormone that you're going to test via saliva or blood?
So we can test the levels of GCF. They vary according to the circadian cycle, so we can keep that as a biomarker.
Something in GCF you will so in the saliva or blood. Any hormone that is strongly associated with the disturbance of circadian rhythm?
So melatonin, which is responsible for the circadian rhythm.
No. Anyways, chalo, it's a good presentation. Carry on.
Thank you. Thank you.
Thank you, sir.
Thank you, sir. Moving on to our next presentation, 00452. Please present your poster.
With the advent of invisible orthodontics, clear aligners have been a popular resort. Controversy exists about the complexity of orthodontic cases that can be successfully treated with clear aligners. In 1997, when Invisalign was first introduced by Align Technology Company, it was for cases with minor crowding or spacing. Since then, the clear aligner technique has been continuously evolving owing to digitalized designing and development in dental materials. Clear aligners have been greatly enhanced to treat cases from mild to severe malocclusions. Studies by Lee et al. Found no statistically significant difference between conventional fixed appliance and clear aligners in orthodontic effectiveness, which was evaluated by methods from American Board of Orthodontics Phase 3 examinations, results of which were supported by meta-analysis by Zhang et al., which illustrated that there was no significant difference in effectiveness evaluation done between the two appliances. Contrary to this, popular studies by Field et al., Larson and Wang et al. Concluded that the buccolingual inclinations and occlusal contacts were inferior with clear aligner as compared with the fixed appliance. Moreover, the relapse observed was greater in clear aligners. least predictable movements being rotations and vertical movements. So, the controversy regarding whether the clear aligners can be a viable alternative to braces is still not clear. Further prospective controlled trials are required to support with sound scientific evidence. Thank you.
How do you compare the two systems cost-wise? I mean, like conventional brackets and the clear aligners?
Are you there? Rita?
Good morning, ma'am. Am I audible?
Yes.
Please answer the query fast, Rita.
Ma'am, I was not connected. Can the question be repeated, please?
Yeah, how do you compare the two systems, clear aligners as well as the conventional orthodontic bracket system? Cost-wise.
Right, ma'am. Ma'am, the conventional what we are using is the Roth pre-adjusted edgewise appliance, that is both the overhead and the O2 slot. And in the aesthetics, that is the clear aligners, that is we are using the biocryl sheets. So comparing the cost, ma'am, the sheets are costing us about 1,000, and the kit which is costing is 800 to 900. So cost wise is not that differentiable. Difference is not there, ma'am.
Okay. Sir?
No questions from my side, please.
Thank you. Now I call upon the next presenter, 468. Please start presenting.
Good greetings to one and all present. I'm here today to present a poster on needle stick injuries in COVID era. Needle stick injuries are puncturing of intact skin or mucous membrane by used needles or syringes by accident. This is one of the most common occupational hazards faced by the medical and paramedical personnel. The present time where corona is prevailing at such high rates, the chances of such injuries has increased multifolds, be it the vaccination sites or care units of the COVID patients. The most common pathogens which transmit via needle stick injuries are HIV, hepatitis B, and hepatitis C virus. Healthcare workers while dealing with COVID patients also faces needle stick injuries which lead to the question, does corona also spread by such injuries? The answer lies within the various researches that underwent in recent times. The data tells that such transmission is less likely to occur as the amount of body fluid in the needle is very less, which does not deliver enough organism to the person. Thus, they don't contract the disease. Also, the blood and its products are collected for transfusion after 28 days of negative RT-PCR test, which again does not transfer the organisms to the recipient. Now, what should one do if they get accidentally pricked by a used syringe? OSHA, or Occupational Safety and Health Administration, states 4 steps. Number 1, one should bleed it. Let the blood ooze and flow out to prevent inoculation of the site of injury. Number 2, wash it under running water and with soap to wash away the pathogen. Number 3, cover it. The injury must heal and not be exposed to further contamination. Number 4, report it to the higher officials and get promptly tested for the suspected infection and get post-exposure prophylaxis. The most importantly, do not panic. OSHA also states some preventive measures, focusing on safe disposal and NSI protective devices like retractable syringe, sharps, which blunt after one use, and much more. Also, healthcare workers must be trained beforehand for handling and disposal of these items. One must never dispose these items in recycle bins or flush them down the toilet. Rather, they should always use a puncture-proof, anti-tumble, color-coded, and labeled box for discarding items. Never force these sharps in the container. Never put your finger in the box. Never recap, remove, or bend the needle. Never hand the syringe over to another person or put it down for further use. As a conclusion, I'd say that annually 1 million cases of needle stick injuries are reported. So, one should always practice safe, sharp etiquettes and should not be 1 in 1 million. Thank you.
Any queries?
Yeah, one question from my
Ma'am,
side. Is it HIV or it is hepatitis virus that is the most dangerous complication of needle stick injury? And if you can tell the percentage of acquiring the particular infections.
Beta, are you there? Did you get the question? Hello?
Hello, am I audible?
Yes, please answer.
Good morning, sir.
Good morning.
Sir, both of these have a very high rate if we consider them transmitting through the needle stick injuries. But for as a dentist, if I talk about the most hazardous, according for our occupation, is hepatitis B virus, which along with the needle stick injuries can also be transmitted through the oral cavity.
Okay, it is hepatitis C. Anyways, chalo, carry on.
Ma'am?
Yeah, just tell me, how do you discard the syringe part?
Ma'am, the discarding of the syringe part generally occurs in the recyclable plastic color-coded boxes, which are of yellow or blue colors. Yellow color, not blue. Blue is for the syringe, for the needle part, and yellow is for
just tell me, excuse me, sorry to interrupt. जो yellow bin होता है आपका, उसमें what type of articles do you discard?
Ma'am, in the yellow boxes, we discard the probable infected and the recyclable plastic wastes.
How do you dispose of the material discarded in yellow bin? उसका treatment क्या होता है आगे?
Ma'am, in the higher centers, they're first disinfected by being placed in large hole sieves and using disinfectants, and then they are sent for further recycle process in the higher.
Yellow bin में जो articles होते हैं, they are incinerated basically. So yellow bin के अंदर जो articles होते हैं, they are all contaminated articles. You cannot discard plastics in yellow bin because you cannot incinerate plastics. So जो syringe होती है आपकी, you cannot discard in the yellow bin. Okay, yellow bin में you have all blood-soaked bandages, basically पट्टियां जिसे हम कहते हैं, those things which can be burnt, incinerated, वो हम yellow bin में discard करते हैं. So ये कहाँ discard होता है? Plastics किस में discard होते हैं? Syringe part I am talking. You just dismantle the syringe and discard it where? Plastics कौन से bin में जाते हैं?
Did you get that question?
Yes, ma'am.
If you are unable to respond, can we move ahead, please?
We discard them in the red bins. Okay, so we can move ahead.
Thank you, ma'am. Thank you. Moving on to our next presenter, 00472 here. Are you there?
Yes, ma'am.
Quest for the best, wonder tissue for brilliant smile. Greetings to the dignitaries and our fellow delegates.
We would like to thank Jamia Millia Islamia University for giving us this opportunity to present a poster in front of you all. The aim of our poster is to evaluate the effectiveness of amnion membrane as dressing after depigmentation procedures of gingiva.
What is the amniotic membrane? The amniotic membrane is the innermost avascular layer of the fetal membrane, which is derived from the full-term placental tissue and is treated with antibiotics for its collection. The amniotic membrane has the properties of pluripotency, anti-inflammatory properties, antibacterial and antiviral properties, anti-angiogenic and re-epithelialization properties, which contribute to the efficiency of the amnion to be a part of the dental surgical techniques. What is gingival depigmentation? Gingival health and appearance are the essential components of an attractive smile. There are several factors such as keratinization, pigments of the epithelium thickness, other physiological, pathological, and genetic factors which contribute to the pigmentation of the gingiva. There we have shown some of the gingival techniques which have their own supremacy in efficiency and have some drawbacks. Now, let's move on to our clinical study.
Our study is based on 3 patients who reported to the Department of Periodontology with the chief complaint of black-colored gingiva that aesthetically interfered their speech and smiles. So they went for depigmentation procedures using surgical scalpel technique. Here, as you can see, we have also attached the clinical pictures of one of our cases. Post-depigmentation procedure, a section of amnion membrane was attached on one side of the maxillary arch, whereas the other side of the maxillary arch was left open for open wound healing. Differential evaluation was done using the hydrogen peroxide test from 5th to 15th day of wound healing. In this, 3% of dried hydrogen peroxide was applied to the healing wound, and bubble formation was assessed. On the control side, it was observed that bubble formation was present till the 13th day of wound healing, suggestive of incomplete wound healing. Whereas on the test side, it was observed that bubble formation ceased from 7th to 11th day of wound healing, suggestive of complete wound healing. So from this study, we concluded that better wound healing with faster rate of epithelialization was seen at the test time, where the amniotic membrane was placed as compared to the control site.
This preserved amniotic membrane is a tissue-engineered biomaterial that is emerging as a powerful tool to generate biological substitutes and regenerate for damaged tissue. Therefore, the healing touch of this neoteric membrane is beneficial for periodontal wound healing. Thank you.
Thank you.
Any questions, sir and ma'am?
May you expect any complication associated with the use of amniotic membrane in the oral cavity?
Good morning, sir. Sir, the amniotic membrane has various biological properties, and as there is no grafting required and it is self-adherent, so there are no such complications which are faced due to.
Okay. Are there any issues associated with the biocompatibility?
Sir, the amniotic membrane is bio and so.
Okay.
Ma'am?
Yeah.
No.
Can lasers be used for gingival depigmentation?
Yes, ma'am. Lasers have also shown very good results in gingival depigmentation. From causing less tissue damage, and but the thing is that lasers, they are not that much cost effective as compared to surgical scalpel techniques. Therefore, we go for surgical scalpel technique because it shows almost same results as laser and is cost effective also.
Can you tell me the names? मतलब कौन सा लेजर यूज कर सकते हैं हम?
Ma'am, lasers, I don't have the clear idea about it.
You don't have the clear
laser.
idea. But laser के साथ में मतलब I will rather go for lasers because it's a bloodless technique and they're much safer to use. It's a one-time investment, but it can help you in many, many things. Okay. So, but you should know at least कि laser कौन सा आप use कर सकते हैं. So, thank you. We can move ahead.
Thank you, ma'am. Now I call upon our next presenter, 00542. Are you there, Vita?
Good day to everyone. Today, I got an opportunity to share a fascinating topic with all of you. Yes, we are talking about chitosan here. Most of you might already be familiar with this concept, while for others, this might be a newer concept to delve into. So let's begin with the basics. Chitosan is an aminopolysaccharide produced from the deacetylation of chitin, which is obtained from crustaceans and insects. A little confusing, right? Let me simplify it for you. Chitin is a protein found in the exoskeleton of crustaceans and insects. It is demineralized with HCl in order to prevent any allergic reactions to the human body, followed by deacetylation, which leads to formation of chitosan, the product of interest. Well, now who thought that the exoskeleton of crustaceans can prove out to be boon for the humans? To understand better, let's delve into uses. Chitosan is being tried in various aspects of dentistry, like wound healing, hemostasis, localized drug dealing, and for bone augmentation at implant sites. Isn't it enough? Well, not in the case of chitosan. Chitosan can also be added in the chewing gums or toothpaste in order to promote remineralization of tooth surfaces, hence preventing caries. A study conducted by the Department of Oral and Maxillofacial Surgery, PGIMR Chandigarh in 2018, gave some conclusive proof that chitosan, when added in the extraction wound, estrelates healing process, therefore making it a revolutionary product in dentistry. Now, coming to its working mechanism. Firstly, how does chitosan act as a hemostatic agent? Chitosan, being positively charged, bind with negatively charged erythrocytes and lead to formation of a clot. Similarly, it also binds the bacterial cell wall and leads to the inhibition of bacterial growth. Another striking feature which fascinates me the most is that the chitosan modified glass ionomer cement has been found to be greater fluoride releasing with superior mechanical properties. With the heaping benefits ranging from being a biodegradable substance to being non toxic, chitosan has certain disadvantages as well. It is a costly material with a limited availability right now, but it is a material booming with potential. Still, many researchers are currently trying to comprehend this material. But with whatever knowledge we currently have, it can be culminated that chitosan is truly a hidden gem and a potential advancement in the holistic approach for treatment. With this, I would like to end my presentation. Thank you very much.
Thank you, Vita. Please, Pooja ma'am or Shamim sir, any queries, any questions?
कोई commercial name preparation बताओ chitosan modified GICK.
Ma'am, researches are going on yet, but there are bandages used like HTD in USA. Hemodento bandages for bleeding control.
No, chitosan modified GIC glass ionomer cement आपने mention किया है ना? Can you tell me any commercial preparation?
No, ma'am, that's a research. They have proposed an idea that it can be incorporated, and researches are going on. We have also proposed this in our college.
Okay. Thank you.
Okay. Any other drug that can be used in the drug delivery system other than chitosan, which are more commonly used?
Sir,
collagen can be used.
Any drugs?
So BMPs, like we can deliver bone morphogenic proteins with the help of chitosan.
Okay. We will proceed to the next one, please.
Thank you. Thank you, Beta. Now call upon our next presenter, number 601, 00601. Are you here? Please start presenting.
Hello everyone. Today I am presenting a case report with the title Diagnostic and Treatment Challenge in Exclusive Luxation Injury. A 26-year-old female patient presented to the OPD with chief complaint of pain in her upper front teeth region since 4 days. She gave the history of trauma and pain in upper front teeth. She reported to a nearby dentist and access openings were made, after which the pain increased. On careful clinical examination, we found that the incisal edge of 1-1 was lower than 2-1. Also, the 1-1 and 1-2 were painful, tender on percussion, and slightly mobile. This pointed to the diagnosis of lateral luxation injury, which was confirmed by radiography, showing that there was periapical radiolucency in respect to 1-1 and 1-2. Also, the PDL space was empty in respect to 1-1. And the diagnosis was made as exclusive luxation in respect to 1-1 and subluxation in 1-2. And treatment plan was designed. Then the positioning was done for 1-1 and a passive and flexible splinting was done from 1-3 to 2-3 using 23 gauge stainless steel wire and flowable light wear composites. Then the access cavities were modified and root canals were prepared, after which we placed calcium hydroxide intracanal medicament for 2 weeks. After 2 weeks, when the patient was reassessed, it was found that the pain reduced, tenderness reduced, the tooth was good, nicely in position, and the radiograph showed disappearance of periapical radiolucency on repositioning. Then we obturated the root canals using gatta parcha, and restoration was done with light cure composite, and the splint was removed. Then on 6-month follow-up, it was found that there was no pain, no tenderness, no abnormal mobility, and radiograph showed absence of any periapical lesion. So at last, I would like to conclude by saying that correct diagnosis is the key to correct treatment. Thank you.
Thank you, Beta. Any queries from Sir?
No question from my side, please.
Pooja ma'am?
What is the difference between subluxation and extrusion? Yeah, extrusive luxation.
Good morning, ma'am.
Good morning.
And ma'am, subluxation is the tooth is in position, but has had some injury. But exclusive luxation is tooth has moved out of the socket, partially out of the socket, in occlusal or incisal direction.
What is the hallmark sign of subluxation?
Ma'am, clinically?
Clinically, of course.
Ma'am, there is bleeding in the gingival sulcus. You can see the bleeding. And the tooth is tender on percussion.
Okay, good. Thank you.
Thank you. Thank you, ma'am. Moving on to our next presenter, 00624. Are you here, Beta? Please start your presentation if you're here. Please.
Hello and welcome. Today I will be discussing about the current concepts and recent advancements in local drug delivery system in periodontics that we use in the management of periodontitis. Periodontitis is an inflammatory disease which is characterized by progressive destruction of the periodontium. It is one of the major causes of tooth loss among the population. Since the pathogenesis of the disease involves complex and dynamic interaction among the bacterial pathogens and the host periodontium, there is a use of antibiotics along with the scaling and root planing. For a localized site or the deep pocket which is present locally, subgingival administration of antimicrobial agent can be considered sufficient. There are various systems that we use as an antimicrobial agents, including chlorhexidine, tetracycline, metronidazole, which can be administered in different forms. For example, chlorhexidine chips and films, tetracycline fibers, minocycline gel, and microspheres, etc. Microspheres and the nanoparticle, along with the in situ forming gel, are one of the recent advancements. In situ gel systems includes the liquid preparation that can be injected into the periodontal pocket
and they hardens under physiological condition that could be change in pH, temperature, etc. to form the gel of custom geometry according to the patient's pocket. There are various advantages of local drug delivery system that includes effective drug presence with a sufficient concentration at the target site. It overcomes the side effect of systemic administration, and since there is no systemic resorption, there is no risk of toxicity. In situ gel system provides some added benefits, such as it has strong adhesive properties which prevents accidental expulsion of the implants from the patient pocket, which can be seen as major obstacles by the clinicians. It ensures sustained and prolonged release of the drug. It can be easily prepared and administered. It has good stability and biocompatible properties. There are various systems, various type of in situ gel system depending on how it triggers the gel formation. For example, the temperature triggered gel system where a mucoadhesive formulation is made which has a polymer that changes into gel along a temperature range of 25 to 37 degrees Celsius. pH triggered gel system where the solution gel transition occurs due to the change in physiological pH. Photopolymerizations allows a monomer and a photoinitiator. They get polymerized at UV visible wavelengths, example, acrylates. The whole scene can be concluded as the in situ gel systems offer remarkable potential for treatment of periodontitis, allowing controlled drug release, site-specific management of the periodontitis, intense adhesive properties, and adequate mechanical strength that ensures reliable and prolonged residence in the pocket. The further focus should be in vivo profiling of these systems and better accessibility to new technique for management of periodontitis. Thank you so much.
Any queries, ma'am? Any questions?
Yeah,
No,
one question.
no,
One question
no
from my
questions
side.
from my side.
Yeah, one
Great.
question from my side. Other than the conventional use of tetracyclines in metronidazole, is there any recent drug that is being used as a local drug delivery system?
Yes, so there are various modifications like we are seeing newer drugs, for example, clarithromycin, ofloxacin, even statins are used as
Statins,
local
yeah.
drug delivery systems.
Statins are
Yes.
the most recent ones. Yeah.
Yes, sir. And there are curcumins, like in herbal, we are using green tea chips, we are using curcumin, turmeric, etc. Thank you, sir.
Fine. Yeah. Good
Thank you,
presentation.
sir. Now I would like to call upon our last presenter, 00726.
Medical emergencies are an inevitable aspect of one's dental practice. One may encounter a medical emergency 10 years after having begun their practice or right in third year on our first clinical exposure. Bottom line is, no one knows when an emergency can strike. The only way to effectively manage medical emergencies is early recognition and being prepared to deal with it. Foreign body airway obstruction is one of the most common medical emergencies which is seen in the dental office. It is very sudden in onset and critical in nature. There is great potential for small objects to drop into the oropharynx of the patient owing to the supine or semi-supine position during dental treatment. These small objects like burrs or crowns may subsequently be swallowed or aspirated. When objects are swallowed, they usually enter the GI tract via the esophagus, and more than 90% of these swallowed objects pass completely via stools without any complications. But if aspirated into the trachea, FBAO can lead to death. Acute airway obstruction is the major cause of non-traumatic cardiac arrest in infants and children. Objects can enter into the right or left main stem bronchus, more commonly in the right stem. Some simple instruments and techniques used to prevent aspiration and swallowing of objects are isolation of the operative field using rubber dams and oral packing via pharyngeal curtains, securing cotton rolls and endodontic instruments with dental floss not only prevents such an incident but also makes their retrieval easier. Patients clutch their necks demonstrating the universal distress signal for an obstructed airway. Airway obstruction may be complete or partial with good airflow or with poor exchange. Victims with partial obstruction with good airflow who are able to cough forcefully and are breathing adequately should be allowed to continue to do so without any intervention. In cases of complete airway obstruction or partial obstruction with poor air exchange, Establishment of a patent emergency airway becomes the immediate goal of treatment. Manual non-invasive procedures are used whenever possible. Surgical procedures like tracheostomy and cricothyrotomy are used as a last resort since they are technique sensitive and require proper equipment. Some commonly used manual techniques are finger sweep, back slaps, abdominal thrusts, and chest thrusts. Blind finger sweeps are not recommended as they may further worsen the situation. Attempts at manual retrieval should only be made if the object is visible. Back slaps are an integral part of management in infants. Heimlich's maneuver is the recommended primary technique in victims 1 year and older. Manual thrusts to the upper abdomen are designed to produce a rapid increase in the intrathoracic pressure, acting as an artificial cough that can help dislodge the object. Chest thrusts should be used in patients who are pregnant or obese. Trachothyrotomy is considered to be the surgical procedure of choice as it's easier and quicker than tracheostomy and the incidence of complications is significantly lower.
Any questions to Pooja ma'am and Shamim?
No question from my side. Thank you.
Pooja ma'am?
What is the difference between aspiration and ingestion?
Good morning, ma'am. Am I audible?
Yes.
Ma'am, in cases of aspiration, the object gets aspirated into our respiratory system, either the bronchus or eventually even the lungs. And ma'am, in cases of ingestion, it reaches our stomach via the esophagus.
Okay. Fortunately, swallowing occurs more frequently than aspiration.
Yes, ma'am.
Okay, thank you.
Thank you.
Thank you, ma'am.
On the closing note, foremost, I want to thank our respected judges of the session for sparing their precious time and bestowing drops of their vast experience upon the participants. Thank you, Pooja ma'am and Shamim sir.
Thank you.
Thank you.
Secondly, I would like to thank all the delegates for attending the session with utmost patience and hope this experience will bring them again to attend future endeavors by the Faculty of Dentistry, Jamia Millia Islamia. At last, I would like to take this opportunity to thank all the participants and hope our conference will incultivate them and feed them with more passion and enthusiasm for future work and motivation for others. Now I give the baton to Dr. Deepika ma'am. Thank you, sir. And
Thank you. Thank you, Dr. Bushra.
Thank you, Dr. Bushra.
Thanks for being here.
Thank you.
Right. Thank you. I think we conclude this session and we'll just take a short break for 2 minutes and meet again for the next morning session. Correct?
Okay. Thank you.
Thank you. Thanks a
Bye,
lot.
sir. Thank you, ma'am.
Bye.
Again. Thank you.
Good morning, Dr. Vikas.
Good morning, Dr. Sanjay. How are you?
All well, all set. Yeah. Dr. Jagat is not there. Hi, good morning, Dr. Jagat.
Hi, Jagat bhai. How are you doing?
Unmute kariye Jagat bhai. Good morning, Dr. Jagat. Unmute yourself, Dr. Jagat.
Good morning, Dr. Jha here.
Good morning, sir. How are you?
Fine, thank you.
Morning, sir. Good morning, everyone. Good morning.
Good morning, Dr. Ashu.
Good morning. Good
Morning,
morning.
ma'am.
Good morning. Good morning. Good morning, Dr. Sanjay, Dr. Vikas, Dr. Jha sir, and Dr. Jagat Bhushan.
Good morning, ma'am. How are you doing?
तो recorded है ना मैंने.
Good morning, Dr. Sanjay. Can you hear me now?
Good morning, Dr. Jagat. Very good morning. Am I audible, Dr. Jagat?
Yes, sir.
Dr. Jagat की आवाज नहीं आ रही.
बैठो. आ रही नहीं ये.
Yeah, brother. Good morning.
Good morning.
आपकी आवाज नहीं आ रही थी.
अभी आ रही?
You are audible.
Okay.
आप बोलिएगा.
ठीक है. Okay.
Rabindranath Tagore has rightly said, the highest education is that which does not merely give us information, but makes our life in harmony with all existence. Good morning, everyone. We would now like to commence the first session for today. The theme for this session is Emerging Trends in Dentistry. In this session, we would be having 3 lectures by eminent dignitaries in the field of dentistry. The first lecture will be on the secret ingredients of painless anesthesia, the intraosseous technique by Dr. Marina Papacroni ma'am, followed by sleep apnea, a dental perspective by Dr. Puneet Batra sir, and concluding with artificial intelligence in dentistry by Dr. Mohammad Yusinil Putera sir. May I invite Dr. Ashu Bhardwaj ma'am, Professor and Head of Department, Periodontology, Faculty of Dentistry, Jamia Millia Islamia, to introduce the chairpersons for our first session, Dr. Vikas Dhupar sir and Dr. Jagat Bhushan.
Thank you, Dr. Deepika. First of all, I would like to welcome and congratulate the entire team of DENTOCON 2 for successful completion of one day of the conference of DENTOCON 2. Now, it's my pleasure to introduce Dr. Vikas Dhupar. Dr. Vikas has completed his BDS from Goa Dental College and Hospital, Bambolim, and MDS from KLE Institute of Dental Sciences, Belgaum. He has teaching experience of more than 26 years and is currently Professor and Head of Department of Oral and Maxillofacial Surgery, Goa Dental College and Hospital, Bambolim, Goa. He has more than 40 publications in national and international journals in his name. He has formulated guidelines for use of nitrous oxide in dentistry in India, as well as guidelines for webinar for DCI. His research interests include trauma, orthodontic surgery, cleft lip and palate, reconstruction, and implants. Welcome, Dr. Vikas. A very warm welcome in cold winters of Delhi, virtual cold meeting. Dr. Jagat Bhushan, welcome to Delhi in a virtual meeting. Dr. Jagat Bhushan, he is the Professor and Head of Department of Conservative Dentistry and Endodontics at Dr. H.S. Judge Institute of Dentistry, Punjab University, Chandigarh. He has more than 23 years of teaching experience, and he has contributed in various textbooks of operative dentistry and endodontics. He is on review board of various index journals, and he was also the chief editor of Annals of Clinical Dentistry. He has also held the position of Vice President of Indian Association of Conservative Dentistry and Endodontics in 2016. He has served as a specialist in multi-specialty intercontinental medical mission to Malawi, Africa in 2016 and Uganda, Africa in 2018. Welcome, Dr. Jagat Bhushan.
Thank you, ma'am. Thank you so much. Thank you.
And welcome to Faculty of
Thank you, ma'am. I would kindly request you to felicitate our esteemed chairpersons with a token of our appreciation.
Thank you, Dr. Deepika. I'm really thankful to Dr. Vikas for being present, for taking our time in this session organized by Faculty of Dentistry, and along with IESRF. So welcome and thank you for coming here and being a part of the scientific session. Thank you, Dr. Vikas. And I would like to also appreciate Dr. Jagat for taking out time on a Sunday morning and, especially attending and chairing the session, scientific session. Thank you so much, Dr. Jagat. Thank you.
Thank you, ma'am.
Thank you, ma'am. May I kindly request all the dignitaries to switch on their video cameras for a group photograph. Thank you, everyone. May I now request our esteemed chairperson, Dr. Vikas Thupar, sir, to introduce our first guest speaker.
A very good morning and welcome to this session on a lovely Sunday morning. I believe it's very cold in Delhi, but it's very hot. And when Madam said to welcome to a cold weather, it's just started pouring in Goa, surprising in this time of the year. I thank Dr. Sanjay for giving me this opportunity to be with you, and also Dr. Juneja, and a wonderful introduction by Dr. Ashu. Our first speaker for today is Dr. Marina Papakroni, who did her graduation and post-graduation in pediatric dentistry and 2 years master's degree in dental materials from Dental School of University of Athens. She is the treasurer of the board of Hellenic Academy of Clinical Dentistry and a member of Hellenic Society of Pediatric Dentistry, European Academy of Pediatric Dentistry, and International Association of Pediatric Dentistry. A dynamic member of the Public Relation Committee of IAPD. Lately, she has been lecturing on bioactive materials, dental trauma, restorative pediatric dentistry, therapy of primary and young permanent teeth. The current focus of the clinical research is involved in painless anesthesia techniques in children. From 2019, she is a lecturer and clinical trainer of intraosseous anesthesia and a member of Dental High-Tech Academy. She is also a key opinion leader of Polydentia SA in Greece. Dr. Papakroni maintains from 2000 her private practice in Greece and emphasizes on aesthetic and microscopic pediatric dentistry. May I invite Dr. Marina Papakroni for her first lecture, Secret Ingredients of Painless Anesthesia, the Intraosseous Technique.
Topics, the intraosseous anesthesia. Thank you so much for the invitation.
The cuisine is not an old, tired dish. Miserable, overcooked asparagus. In this restaurant, the cuisine is not an old, tired marriage. It is a passionate affair of the heart.
Some of you already know that I start all my presentations about intraosseous anesthesia with this video because it is described accurately my relationship with this kind of dental anesthesia. It is a passionate affair of the heart. It was love at first sight. And after I started working with this technique, I never went back to conventional anesthesia. So today we are going to discuss the secret ingredients of this technique, of the intraosseous technique. And my purpose is to be as much practical as I can, like a cookbook, because I love cooking and I like solutions and not problems. I graduated in 1995 from the Dental School of Athens University, and in 1995 I received my pediatric dentistry specialization certificate from the same university, and in 2000 my master's degree in dental materials, again from the University of Athens. From 2001, I retain an office practice limited to pediatric dentistry, Patras, Greece, and from 2019, I am a lecturer and clinical trainer of intraosseous anesthesia. We will start with this video, which I like to share always, because it is a boy 4.5 years old with 2 class 2 cavities. It is his first time at the dentist. The first time he experiences dental anesthesia, and the first time for intraosseous anesthesia with Sleeper 1 device. And you can see here in the video how relaxed you're going to see the procedure of the anesthesia. And here, his mother asked me to take a photo because she sees how relaxed he is. I start with a touch gingiva, he watches TV and laughs. I want you to understand that always we keep encouraging and always we go with behavior management. He doesn't move. There's no stress at all. You can see here the second step, the penetration. I keep encouraging and he's still enjoying. He asked me if we are going to, if he's going to experience any pain during the procedure. And now I'm saying, I am going to ask you after the procedure if you felt any pain. Now he says nothing. He answers my question and says nothing. I don't feel pain. And here he laughs with what he sees, with what he watches on the TV. And here is the end of the most stressful procedure, both for the dentist and the child. And what can we ask more for our patients? Let's start with the benefits, the clinical and business benefits of this technique. We obtain stressless and painless anesthesia. We eliminate collateral numbness and lip or tongue biting. We have immediate success even in mandibular molars with pulpitis. And the business advantages is that we increase patient loyalty and satisfaction. The intraosseous anesthesia, it is the most common things that parents share for my practice from lip to lip, it is the most, the best marketing for my office from the day zero I started with this technique. We have also a better appointment management because we know exactly the time we're going to start the treatment and finish. And of course, because we have a better management, we increase profitability thanks to time saving. Why in pediatric dentistry? According to the basic steps of behavior management, the most crucial step to establish cooperation is painless anesthesia. And this is a technique that we are painless. So we establish cooperation with the child from the beginning of treatment. And the second step is to deliver and perform painless dentistry, which is achieved if we are efficient at the first step, at the step of anesthesia. And this is a technique with no failures. That is why we are so efficient, because we are near the target, near the apex. Also, we have some special concerns like MIH molars, and we know from literature that intraosseous anesthesia profoundly anesthetizes 85.9% of MIH affected teeth, but local infiltration profoundly anesthetizes only 25.9% of MIH teeth. This means that this is an anesthesia, a technique which is suitable for these complicated cases. And of course, for endo treatment in pedo, the pulpotomy, pulpectomy, or open apex trauma cases. And you see in this example, with 1 point of injection between the two molars with quick slipper 5 device, I have quadrant treatment. I can perform quadrant treatment because I have quadrant anesthesia. I have diffusion to the whole quadrant from canine to the first permanent molar, and you can see the vasoconstriction, which is extended not only buccally, but also lingually or palatally, so we don't need complementary injections even when placing the clamp. Also, it is a technique with no lip or tongue biting, and for my experience, for special needs patients, it is a better tolerated anesthesia because we don't. These patients don't have the feeling of difference after the anesthesia, so there is no need to explain you are like this and now and after an hour you're going to be the same, because they don't understand such an explanation. Why in COVID era? You can understand that it is a very suitable technique for COVID era because we have a better treatment plan, better appointment management. We know exactly the time we will begin and the time we're going to end our treatment, and we can work also in different quadrants. And you can see this young lady here. She came in my office. She was living far away, and they asked me, she's 4 years old, if I can do the rest of the anterior teeth in one visit. And of course, it was possible with 1 point of injection between the two centrals. I have vasoconstriction extended to the 4 anterior teeth. You can see here the vasoconstriction, and of course, performed the 4 anterior restorations in one visit treatment. And again, another example, I had, my purpose was to do the resto of this canine, and the canine and first primary molar of the other side, and all this was possible with intraosseous anesthesia in 2 different quadrants. We are going to start with the problems. We face problems. The problems of our patients is fear, pain, and numbness, and our problems is postoperative side effects, inefficiency, leaks, multiple appointments, or stress. We experience stress as much as our patients, we know that. Why sometimes things don't work? Things don't work because we have aberrant anatomy compromising nerve blocks, we have leaks, inflamed tissues, or insufficient quantity, and of course, inadequate vasoconstrictor concentration. The facts about anesthesia, according to literature, is that we fail. This study says concludes that we fail from 5 to 15%, or up to 10%, or 15 up to 30% of patients. But we fail. In general, we fail. There are alternative methods which are indicated, however, they cost a little bit more. The preparation. Our target is always the spongy bone close to the apex. This is the target of the intraosseous technique. And if we imagine that we have a box with a periosteum and teeth and the cancellous or spongy bone inside that box, the target is always right here, the cancellous bone near the apex. The intraosseous technique includes three different techniques: the intraligamentary or PDL technique, the intraseptal technique, and the osteocentral technique. These three different techniques of the intraosseous anesthesia have a difference in the head. And as you can see here, with the intraligamentary and intraseptal, we are much higher, and only with the osteocentral technique we go deeper. That's why we have an immediate effect and we don't have failures. Why the PDL technique is included in intraosseous technique, included in intraosseous anesthesia? Because from research we found that our anesthetic solution is diffused through different routes, these bony perforations, and it is diffused into alveolar bone, into the cancellous space. That is why the PDL technique is included in intraosseous anesthesia. The osteocentral technique is the only technique which has the advantage that through the Volkmann canals or the Versian canals of periosteum, we have diffusion of our anesthetic solution. That is why we don't need complementary injections. And you can see here, with 1 point of injection, we have vasoconstriction to the whole quadrant. And the diffusion is up to 8 teeth, 4 teeth in the upper jaw and 3 in the lower jaw, without numbness and no supplementary injections. And let's go to the description of our technique. The basic steps is first, attached gingiva anesthesia, secondly, manual penetration or rotation, and third, the injection of our anesthetic solution. And the first step, we go parallel without touching the periosteum, and we release a few drops of our anesthetic solution. We remove our needle, we enter with a different angle, 45 degrees for posterior teeth or about 30 for anterior, and we proceed with manual penetration if we have less bone density in primary and mixed dentition, or with rotation when we have a more dense bond. And then the third step is the injection of the anesthetic solution. And because we are close to the apex, we need less volume. Let's see a small video of the technique. Parallel, a few drops of our anesthetic solution, the whitening around the needle. Then we remove the needle, we change the angle, we enter, touch the bone, and after we touch the bone, we start the rotation. And with the rotation, we enter, and then we go deeper, about 3/4 of the needle, and we inject the anesthetic solution. And we have, with 1 point of injection and no complementary injections, buccal and palatal or lingual anesthesia of a whole quadrant. 1 injection point. The utensils. The utensils are manual devices or the computer control local anesthetic delivery systems. And when comparing these two different kind of devices, we conclude that the computerized devices are more comfort for the patients. We have an ideal control of pressure, a direct control of the volume of the anesthetic solution, and stability of hand during injection because of pen grip design. The ingredients of this technique and the parameters according literature is that with manual devices, it is an efficient, effective, and preferred technique by most patients. And what I want you to see here is that with the intraflow device, it is concluded in this study that it can be used as a primary anesthesia method, even in teeth with irreversible pulpitis. And here we have another study, 2012. And it is very important to understand that the feeling of anesthesia with the intraosseous technique lasted only 2.5 minutes. And with a typical technique with the inferior alveolar nerve block, the patient has this feeling about 1 to 3 hours. And most patients, about 61%, prefer this kind of anesthesia. It is a very, very important number because you see that it is a consistent finding in the studies. And with computerized devices, the papers, the literature say again the same characterizations. An effective technique works more quickly and long enough anesthesia. And you see here that 61 of the patients who have experienced a conventional technique in the past prefer the intraosseous anesthesia. And here we have studies for children 2008, 2009, 2019. Quick sleeper device, a success rate 95 in primary teeth, and 58.9% of children with previous experience of conventional technique prefer the intraosseous anesthesia. Intraligamentary injection studies for children have some problems, conflicting results, and inadequate design, but we conclude that it is an effective anesthesia for restorative treatment and endodontic procedures for primary teeth, but we need more research in primary molars extraction. Many devices and many studies, and you can search the literature on your own for more results. I want to stay here and discuss about the pain perception, because we need more studies about the acceptance of the devices and the perception of pain, because it is difficult to evaluate. We have complicated results due to personal characteristics, gender, and more. Except prolonged aspiration time, we have other irritants of the technique with different devices, which are the bitter taste due to leakage, the pressure and sensitivity when biting after the procedure, and there is no study about acceptance of patients. The instructions. Which are the post-operative effects? Sometimes we can cause periodontal ligament injury if we are inexperienced and we use a lot of volume or a high concentration of vasoconstrictor. Is this a big deal, a big problem? No, because you can see after the recovery. And also we have light soft tissue numbness sometimes, and a feeling that teeth are longer, which you have to explain to your patients because they think that the problem is your resto and not the anesthesia. Never necrosis happened with these devices, computerized devices. Quick sleeper device is a specially device not to cause big changes of temperature. And the precautions with this technique is head and neck irradiated patients, intravenous bisphosphonates, an infected area, and very small interdental space. The recipe. And let's focus on example. 17 years old, teenager, 1 cycle of rotation, half of septanus cartilage. And you can see that I enter here between molars, and with 1 point of injection, the vasoconstriction extended up to the premolar. 18 year, 2 cycles of rotation between molar and premolar, half of a cartilage of septanus, and you can see the vasoconstriction, 1 point of injection right here, and you see exactly what we have already discussed, palatal anesthesia with no supplementary injection, so there is no need for any complementary procedure to place a clamp. Another case of extraction, premolar, 16-year old teenager, 1 cycle of rotation. I enter here between molar and premolar, and I proceed without any complementary injection, and you see the vasoconstriction extended palatally. A more complicated case, 7 years old child, I need extraction of the first primary molar and place a clamp to the second molar, and of course I use 2 different points of injection, and my advice is always to try to find the spongy bone, the cancellous bone, because if you have an efficient amount of cancellous bone, you are going to have diffusion, and then you are going to succeed. So I entered between canine and primary molar, and again with a second point of injection between permanent and second molar. Another case, 8 years old, there is a lesion right here at the second primary molar. I'm going to extract and proceed with a class 2 to the first primary molar. I enter away from the lesion, and I want you to notice that even in that case that I have a lesion and a fistula, if I choose a point of injection where there is an efficient amount of cancellous bone, I'm going to have diffusion. And you see that I have vasoconstriction from canine up to the permanent molar, and here is the fistula. I enter right here. One point of injection, even in this complicated case, I have vasoconstriction, even palatally, with no complementary injections. And let's have a look at this video. You can see here the whole procedure, the three steps of the technique. I'm going to enter the first step, attach gingiva anesthesia, almost parallel without touching the periosteum, a few drops, and now you're going to notice the widening around the needle. And then after a few drops of the anesthetic solution, I'm going to remove the needle and proceed to the second step. I changed my angle, and now I'm going to enter, touch the bone, and start the rotation. All the rotations are in slow motion in order to understand the details of that movement, and only for educational purposes. Now I insert the needle, I stop, and inject my anesthetic solution. Here we have another case, and in that case, I'm going to perform intraosseous anesthesia for the extraction of a premolar, one rotation, half of a syringe, and it is a real-time video. I'm going to enter almost parallel. You see that I am in the lower jaw, attach gingiva anesthesia, a few drops, I change my angle, I insert the needle, and I'm going to penetrate. I enter, touch the bone, and start the rotation. And you can see here the needle rotating in slow motion, and as I enter, I stop, and I start the injection of the anesthetic solution. I want you, and this is a very, very important part of the video, that immediately after injecting the anesthetic solution, I start and I proceed with the extraction without waiting for my anesthesia to be efficient, without any complementary injection, without anything. I start immediately with the extraction of the premolar. I proceed immediately. That's why I really love this technique. And after this, you see there is no reaction, and here is the premolar. And as I told you before, it is a very, very suitable anesthesia, and I can work in 2 different quadrants. And this is a teenager. She has exams for the university, and she came to the office and told me, I want to do the rest of the upper and lower jaw in the same appointment, please. I don't have much time. And you see here the perforation after attached gingiva anesthesia. I enter with slow motion in the video the vasoconstriction of the maxilla, and now I proceed with the other quadrant, attach gingiva anesthesia, a few drops, the widening around the needle, always the same 3 simple steps of this technique. I remove the needle, and now I change my angle. here I am, I enter, I touch the bone, and I start rotation. And after rotation, then I proceed with the injection of the anesthetic solution. And here is the lower jaw anesthesia at the same appointment. Here we have another case of a girl, 13 years old, first permanent molar, 2 cycles of rotation, as you are going to notice, attached gingiva anesthesia, the first step, the whitening. I remove the needle, and then I'm going to proceed with the second step. I touch the bone, and I start the penetration, and you can see the point of injection in the X-ray included in the video. And now you can see the rotation, 2 cycles of rotation. Now I am okay, and I start the injection of the anesthetic solution. Now we are going to have a video of the same, exactly the same quadrant, but a different age, a different age, a patient of different age. We have a girl, 9 years old, 16, the same device, quick slipper device, but here we have only manual penetration because we have a younger patient. And we start with the gingival anesthesia, and now I am going, I proceed with the second step, only manual penetration, no rotation at all. We don't need, we have less dense bone. So then I proceed with the injection of the anesthetic solution. And let's move to some conclusions about this technique: highly effective, fast onset, comfort, long enough, acceptance from patients, adults and children. The PDL injection needs more research for primary teeth, and also the intraseptal injection, especially in pediatric dentistry, because the intercrestal bone is thinner and the cancellous bone more sparse, is well accepted and works adequately. The osteocentral technique has the unique advantage to diffuse to more than one teeth without any need for complementary injection, just only with one point of injection. The success rate of osteocentral anesthesia in MIH cases or mandibular teeth with irreversible pulpitis need more research. But for preliminary studies, we conclude that the technique is reliable. And at the end, what I can say to you is bon appetit. And if you want more information about this technique, I am always available, and also you can download for free this ebook, the intraosseous, from the App Store, Intraosseous Anesthesia. A practical guide is like a cookbook again about this technique, especially for pediatric dentistry. Thank you very, very much for your attention.
Thank you, Dr. Marina, for this excellent presentation. And it was very self-explanatory. And we do not have any questions as such at this stage. So, you know, excellent. Being a surgeon, I found this, what you have been presenting has been extremely, you know, presentation was extremely good. And in children, yes, fantastic. Thank you very much for the lovely presentation. And
Thank you very much.
May I request the certificate presentation for Dr. Marina, please?
It is my pleasure, and it is a great honor to be here. Thank you so very much. Thank you.
Thank you, ma'am. May I now request our esteemed chairperson, Dr. Jagat Bhushan sir. Thank you, ma'am. May I now ask our esteemed chairperson, Dr. Jagat Bhushan sir, to kindly introduce our second guest speaker.
Good morning, everyone. We had a very useful first session, and the second session we have now is from Dr. Puneet Batra. Dr. Puneet Batra is an MDS in orthodontics from prestigious AIMS, New Delhi. He is professor and director PG Studies, Manav Rachna Dental College, Faridabad, Haryana. Presently, he is editor of the Journal of Indian Orthodontic Society, a recipient of prestigious PP Jacob and JG Kannappan Award by the Indian Orthodontic Society. He has been awarded the prestigious Commonwealth Scholarship at Great Ormond Street Hospital for 6 children, London. He has more than 100 publications in peer-reviewed national and international journals. He is past president of Indian Society of Cleft Lip and Palate and Craniofacial Anomalies 2019-20, and has been nominated to Dental Council of India by Government of India in July 2019. He has been awarded fellowship by 3 Royal Colleges, namely Royal College of Surgeon of Edinburgh, Glasgow, and England. Recently, he has been certified by DRDO in artificial intelligence and machine learning. And it's really a proud moment for me because he is a very dear friend to me for a very long time. And I have seen him evolve into a good professional and a very good human being through his graduation days. So really happy and a very warm welcome to Dr. Puneet Batra.
Thank you so much for the kind introduction, Dr. Jagat. And at the onset, I'd like to thank Dr. Sanjay Singh and the entire team of Jamia for giving me this opportunity. Dr. Sanjay has also been one of the mentors from my undergraduate days, like Dr. Jagat sir. And I'd also like to thank Dr. Vikas Dupar, who is one of the chairpersons for this session. It's entirely my, it's a proud moment for me to be able to speak on this podium. And the topic which I've been allotted is on sleep apnea, where we are talking about advances in holistic dental care. So I'd like to share my screen, please. So is my presentation visible?
Yes, sir.
So, I'd like to start off with a story. People call me a storyteller because I think that dentistry is evolving in a very big way. And what we need to understand is that dentistry is no longer only about teeth. Dentistry is about involving various branches together and working together in various specialties of medical care and systemic diseases. Well, the story is very simple. I grew up from a family where they wanted me to become a dentist and I wanted to be an engineer. So I cleared my, all exams except for IIT because that year IIT and the CBSE exams were together. So I got computer engineering in Delhi College of Engineering. But my parents wanted me to become a doctor. So, the story is when we were growing up, everybody used to talk about the rabbit and the tortoise story that, slow and steady always wins the race. But this story had a twist in this modern generation. The first twist happened when the hare decided that no, he was the smarter guy and he ran faster than the tortoise. So he requested a repeat race and they had a repeat race. And this time the hare did not sleep. The rabbit said, no, I'll not sleep on the way. I'll run and show my potential. And he did that and won with a miles distance. So, again, your generation or the generation next, as I call it, the future of India, is, very, has a very strong willpower and has a great future. So what happened is that the tortoise decided in part 2 of the story that no, let's have another race. But this time I will decide the route. So now the route was decided, and both of them ran the race. But the rabbit was overconfident this time. He knew that he was a faster runner. So what happened is that while they were running, there came a water body on the way. So the rabbit didn't know what to do. And the tortoise, slow and steady as usual, came, crossed the water body, and won the race. But both of them were hell bent on proving who was the better of the lot. So then came the final race. And in the final race, both decided that they would practice. The rabbit decided that he'd learn swimming, whereas the tortoise decided that he is going to actually, learn to run fast. But as you know, that evolution does not support this. It's not possible that biologically for them to do both the acts. So one day it rained very heavily, and both decided that they needed to go back to their village across the water body. And so the rabbit had the tortoise on his back while they were running on land, and the tortoise had the other way around while they went through the water. And they realized that they could win the race in a very, very short time. So the lesson is that dentistry per se is not about teeth. It's about systemic health, and there are multiple fields which are unfolding over a period of time. What we need to know is that we need to evolve as part of an interdisciplinary team. So let's grow together as professionals with other fields of medicine and show that dentistry is one of the key fields in our medical profession. So I begin with the concept of sleep. Sleep is supposed to refresh our soul and our body, and it's the day we don't sleep well, we are not comfortable. So as you all know that sleep has two cycles. One is the rapid eye movement sleep, and the other is the non-rapid eye movement sleep, which account of the ratio of 1 is to 4. And the non-rapid eye movement sleep has 4 stages, from the light sleep to deep sleep. So if the day you are deprived of sleep, what happens? You are not comfortable. But if this happens continuously over a long period of time, what's going to happen is irritability, cognitive impairment, memory loss, impaired judgment. You are yawning the entire day, hallucinations, your immune system is impaired. You might develop lifestyle disorders like diabetes, increased heart rate, variability, risk of heart disease, increased reaction time. So, many accidents happen because our judgment is not proper while we are so tired. Tremors, aches, even growth suppression in children, risk of obesity, and decreased temperature. So, the term which became popular in the 2000s and now is a specialist field itself, where even in Delhi and other parts of the major metropolitans, there are now sleep clinics wherein a pulmonologist is working in close association with the dental surgeons to provide relief to patients suffering from OSAHS, that is obstructive sleep apnea hypopnea syndrome, which is a disease characterized by snoring, disruption of sleep, repeated episodes of complete versus partial pharyngeal obstruction, and frequent arousal and excessive daytime sleepiness. So the key word is excessive daytime sleepiness. It's the first sign which you as an individual can recognize. So somebody who's having irregular breathing during sleep, excessive daytime drowsiness, chronic fatigue, you've slept but you've not slept well, you are fatigued, difficulty in concentrating, mood changes, snorers, and morning headaches. So there are nocturnal and daytime symptoms which are present and can give you an indication that the person might be suffering from sleep apnea. Well, the effects are immediate versus long term. Immediate effects include hypoxia, arousal during sleep, a negative upper airway pressure. The long term include hypertension, cardiac related sudden death while sleeping, abnormalities in glucose metabolism, excessive daytime sleepiness, impaired quality of life, cognitive dysfunction, memory and learning impairment. So, the comorbidities or long term consequences are life threatening, I would say. So one has to diagnose and treatment plan these cases. And there are quite a number of these cases. When you classify them, there are some central types of apnea, which are because of the message from the brain going to the muscles, which make them lax and cause this apnea over a period of time. Obstructive sleep apnea, which could have various reasons, which I'll be discussing, mixed or a complex type of sleep apnea. So the diagnosis is not as simple as the word sounds. So let's understand the difference between apnea and hypopnea. Apnea is cessation of airflow greater than 10 seconds. Hypopnea is decreased airflow greater than equal to 10 seconds. And in apnea, the end may be arousal from sleep, whereas in hypopnea, there might be arousal or there might not be. The oxygen saturation falls in both, whereas in hypopnea, the fall is greater than 4%. So, oxygen saturation has become now a key point of discussion over this COVID era. Now, the two words which are commonly used when you diagnose a patient with OSA are AHI index and RDI index. So, what are these? AHI is simple, apnea hypopnea index, that is the number of episodes of apnea and hypopnea over an hour of sleep. Whereas the RDI index is apnea, hypopnea, and the number of arousals, number of time you have been aroused from your sleep per hour of sleep. Now, when you classify apnea, somebody who has severe to mild apnea would have a different modality which would be required for treatment. Mild apnea hypopnea index is 5 to 15 events an hour. Moderate is 15 to 30, whereas severe is greater than 30 events. Again, the RDI index and the oxygen saturation levels can be associated with mild RDI 5 to 20, moderate 21 to 40, and severe greater than 40. So, the oxygen saturation levels falling as low as 65% during sleep may have a negative effect on the systemic well-being of the person. Sites for airway resistance. The upper airway can be split into the nasopharynx, the oropharynx, and the hypopharynx. Nasopharynx from the posterior portion of the nose to the soft palate, the oropharynx from the soft palate to the tip of the epiglottis, hypopharynx from the tip of the epiglottis to the cricoid bone, cartilage, sorry. So, what happens during normal breathing is that the airway is open, the air flows freely to the lungs. Whereas in sleep apnea, the airway collapses and there is a blocked airflow. Now, this collapse leads to desaturation, that is less oxygen. Our vital organs like the brain, the kidney, the heart, they require oxygen to actually have normal functions. So when oxygen saturation falls, there is an arousal from sleep because we need that oxygen to be quickly refurbished. So it's kind of a vicious cycle. If you look at this vicious cycle, what is happening from the right is that when the oxygen saturation falls, our body tries to increase the breathing effort. And while oxygen falls, the carbon dioxide saturation is increased. So there is arousal. Now this arousal increases our responsiveness and increases the upper airway dilator muscle activity. So there is rapid opening of the upper airway followed by hyperventilation, and then we return back to sleep because now the oxygen saturation has rapidly increased and the carbon dioxide saturation is decreased. This is followed by again a phase of hypoventilation and upper airway narrowing or collapse, and this cycle continues over the entire sleep of the patient. Now, you can see that a normal airflow while we breathe, while sleeping, is the passage of inward and outward going of air. So this passage is a smooth curve. But now see what happens on the right side of the upper flow, that there is a disturbance in this airflow. So what's happening is that there are cycles which are changing our breathing effort, our noise levels, brain wave activity, heart rate, and oxygen saturation. So, it's a serious concern for people who are suffering from this OSA disorder. What could be the etiological factors? Now, see, we say we are dentists. How would we be bothered for a systemic ailment and something related to breathing? Well, there could be anatomical factors which could result in narrowing of the pharynx. Skeletal factors like a small jaw, micrognathia, retrognathia, a small, maxilla mandible which is retruded, the soft tissues, macroglossia, big sized tongue, tonsillar hypertrophy, fatty infiltration into the pharyngeal spaces leading to, because could be because of obesity, neuromuscular factors like decreased activity of the pharyngeal dilator muscles, then active inhibition of muscle activity during the REM sleep, and there could be coupled factors like alcohol intake, sedatives, which we might be taking as prescribed by the doctor, or muscle relaxants. Now, when you look at a patient with OSA, while we were training in AIMS, we were told that a patient entering into your operatory, as a good clinician, you just look at him and you know what issues could be with the patient. So if you looked at a patient of OSA, what could be the factors you would look at? An enlarged uvula, a hyperplastic soft palate, nasal congestion, nasal polyps, enlarged tonsils, enlarged tongue, small lower jaw, receded chin, a neck size greater than 17 inches. So somebody having a broader neck is likely to be a candidate for OSA. Overweight and obese people are more likely candidates. So, literature shows that men are more likely to have OSA. Older age people are likely to have it. Then, like I told, medicines like opioids, narcotic painkillers, strokes, brain tumors, where the nerve contact with the muscles is reduced. Then, the neck size in women and in men, if it is greater than 15.5 inches in females, they are candidates who are likely to have OSA. Then the blood pressure is also one of the factors, but smoking seems to be a very, very important critical factor as well. So does the growth pattern risk OSA? Yes, it does. A patient with class 2 has the oropharyngeal volume, which is less than class 1 and class 3 subjects, and the nasal passage in class 2 is less than class 1. So mandibular retrognathism has an effect on the oropharyngeal volume. Now, how are we supposed to diagnose this medical condition? Well, an interview, just asking patient about his snoring, he would not be able to tell it. His wife or maybe the opposite sibling or anybody who is close to the patient, the choking episodes, cessation of breathing, daytime manifestation of inadequate sleep like poor concentration, fatigue. Then established risk factors and baseline for subjective improvement, and also something called ESS. What is this ESS? A very simple scale. I'm showing you a modified Epworth sleepiness scale where the scale ranges from 0 to 3. 0 is would never doze off. 1 is there is a slight chance of dozing off. 2 where there is a moderate chance of dozing off. And 3 where there is high probability of dozing off. So the maximum score is 24. A score of 10 suggests presence of excessive sleepiness. So you ask the patient these simple questions. Is there a chance of you sleeping off while you were sitting and reading? Well, as a joke, when I open my textbook, I often feel sleepy. Watching TV, sitting in a public place, sitting in a car, lying down to rest, sitting and talking to someone, sitting quietly after lunch without alcohol intake, in a car while stopped for a few minutes in traffic. So, this scale can tell you an indication, a very simple assessment that the patient could have OSA. Then, of course, there are tests like the thyroid function test, the arterial blood gas, blood counts, ECG, echocardiograph, radiological studies, and polysomnography. Now, we as people working in the oral cavity can easily assess for the size of the tonsils. The size ranging from 0 to 4, where there are patients who've surgically got them removed, to a patient where the tonsils are enlarged to the midline as a score of 4. So, you can look at this picture and clearly quantify how much the airway seems to be blocked. Also, there is the oral surgeons use this Mallampatti score for classifying patients for anesthesia risk, and these patients similarly in class 4 or class 3, which are greater risk for OSA, the soft and the hard palate and the base of the uvula are visible in class 3, whereas only hard palate is visible in class 4. So, looking at these scales, you can say that the airway might be compromised. Also, the nasal turbinate might be swollen. There would be a deviated nasal septum and turbinates which are restricting the flow of air. And like I mentioned, the BMI, patients who are obese are likely to be candidates for OSA. There are tests which are prescribed by the medical practitioners, and these include acoustic rhinometry or acoustic reflection, which involves a pharyngometer or a rhinometer. So you look at the airflow from the nose or from the pharynx. But as dentists, what can we see? We can look at the cephalometric images. We can look at potential sites of the upper airway obstruction, narrow areas in the airway, and the position of the hyoid bone. So, snoring per se is not OSA. Snoring, OSA patients will show signs of snoring, but snoring alone is not a sign that you're suffering from OSA. So, what are the cephalometric indicators which show that, snorers differ from OSA subjects because they have smaller hyoid to point B, hyoid to mandibular plane, oropharyngeal area, soft palate area, thickness, tongue area, and tongue proportion. Nowadays, with the advent of cone beam CT scans, MRIs, we are able to 3D evaluate the airway. Look at tidal volumes, look at nasopharyngeal narrowest areas, oropharyngeal narrowest areas, and quantify the volume of air which is going in each breathing cycle. So, we are able to know which are the areas where the possible obstruction might be and what kind of airway improvement can be done with subsequent appliances, as I'll discuss in the presentation further. Well, the gold standard is polysomnography, which includes an EEG, an ECG, an EOG, and EMG. So, earlier you needed to go to a sleep lab to get your polysomnography test done. Now there are small kits which, they come to your home, they will put the electrodes and record your sleep. So you can, if you look down in this image, look at blood oxygen levels throughout the entire range of your sleep, seeing where the decreased oxygen level happened at what event, correlate it with your REM sleep stage, look at the times when your ECG changed or there were changes happening in the EMG activity of your muscles. So now this test is the most critical one to actually diagnose the severity of your problem. So once you've known that the patient has a OSA, what are the modalities you can use to treat these patients? Surgical or non-surgical modalities are available, and these depend on the severity of the patient's symptoms, the results of a polysomnograph, and comorbid conditions. So, you need to strive for at least a 50% reduction in RDI. So, an RDI less than 20, which is considered mild, is the target for patients who are having severe OSA. So, what are the options available? There are some simple to complex options. Now, non-surgical options, the gold standard is positive airway pressure, as I'll just show you in a short video, which could be a continuous positive airway pressure, an automatic positive airway pressure, or a bi-level or a BiPAP. You would have heard these names when in the COVID second wave, people were struggling to look for a BiPAP machine or for a CPAP machine. Well, oral appliances are one candidates which, as dentists, we are we can prescribe or we can make for the patient. Diet control is a very critical factor, like weight reduction. There are medicines, if there is hypothyroidism, we need to correct that. There are some people who are postmenopausal women can be prescribed progesterone. Nasal decongestants, pharyngeal edema can be corrected giving decongestants, and also wearing your sleep position. Remember, in COVID, the second wave, we were prescribed how we needed to be in a particular position and breathe. So in the sleep position training, people have sewn, tennis balls at the in your night at the back of your nightshirt, so that you're not able to fully, recline, avoid the supine position and sleep in the lateral recumbent position. So these are non-surgical methods and are usually prescribed for, as an initial test. And I'll be showing you how to make a mind map of how to treat these patients. So the gold standard is CPAP, and consistent airway pressure is delivered through the mask, which the patient has to wear at night. So there are very handy CPAP machines now. Even nasal EPAP is now very easily available. They treat sleep apnea, but the disorder is not cured. So have a look.
Positive airway pressure
What it's
therapy
doing.
works by keeping your airway open while sleeping. It delivers pressurized air, which keeps the airway open.
So, pressurized airway is keeping your airway open. But there are a number of problems also with CPAP. It's, people having a machine on their face sometimes do not tolerate it so well. There might be, because of this continuous pressure, there would be, your mucosa trying, there might be other issues associated. So, every technique which is used for treatment may have their pluses and minuses. Now, but as if you assess the effects of CPAP, the randomized control trials looked at a number of patients. And what did they conclude? They concluded that if a patient responded to CPAP and oral appliances, oral appliances are preferred by the patient. So if you were to use a CPAP versus an oral appliance, and both were effective, patient's preference was an oral appliance. Now, what are the oral appliances which can be prescribed? Because see, we are working in a team. We should be aware of the terminologies, the systemic issues with sleep apnea. But what is our contribution in the treatment planning or treatment of these patients? This is where we come in. We come in when we need to choose which appliance to deliver to the patient if oral appliances work in those patients. So what are the different types of appliances available? Basically, there are three types. One is the equalizer or the soft palate lifters. So, these act on the soft palate and lift the soft palate muscles. Now, these lifters had become popular in 22q deletion, where the innervation to the soft palate was hindered. So it lifts the soft palate and creates an airway opening. Now, tongue retaining devices, which push the tongue forward with suction pressure so that, the airway, posterior airway is not blocked, and mandibular advancement appliances. These are the three types of appliances which are popular. So if you have a look, this is a palate lifting device. It's an acrylic which is lifting the palate up and is worn at night time to prevent to open the airway. Then tongue retaining devices, basically, the tongue is attached to the genial tubercle. So these appliances are intraoral or extraoral, but what they're doing is they are creating a suction pressure which is pushing the tongue out, which is holding the tongue out. But they are highly uncomfortable for the patient. So these have not gained too much popularity. The third group of appliances which we as dentists could work on is the mandibular positioning appliances. This protrudes the mandible and maintains a forward position. The appliance is mobile, and so compliance is essential. It advances and raises the hyoid bone, tightens the pharyngeal musculature, which reduces the airway collapsibility. So stretch of the masseter muscle stimulates the genioglottal muscle. Different appliances, more than 20 are available. If you Google it, there might be a PM positioner, a snore aid, a Clearway, an EMA appliance, or a Napa appliance. But, you can fabricate it yourself. Advancing the mandible forward can enlarge the airway and reduce the pharyngeal collapsibility in patients with sleep apnea. So if you look at this cephalogram on the left side, the mandible is in rest position. You look at the small airway. But when the mandible is protruded, what has happened? The posterior airway has expanded. So an ideal oral appliance should be custom made. It should protrude the mandible, keep the vertical opening to a minimum, and can be adjusted to achieve the optimal efficacy so that it's well tolerated by the patient. So randomized control trials have found that a monoblock appliance has greater acceptability compared to twin appliance, meaning that if you had two blocks or two appliances where the mandible is protruded forward, patients prefer a monoblock. Then randomized control trials have also said that patients where investigations have said that vertical opening does not have any marked effect on treatment efficacy. That is, it's important to bring the mandible forward, but it's not important to hold it vertically more. So patients prefer appliances where the vertical opening is reduced. Now, how do you fabricate it? Nothing big. You take upper and lower impressions. You gauge the range of motion of the mandible, try to ask the patient to protrude as forward as he can, and use a Georgian gauge to stabilize the construction bite. And every 2 millimeter of advancement, the golden rule is that 20% improvement in oxygen desaturation index happens. So you don't need to advance the mandible in one go. You can gradually titrate your appliance. So the critical word is titration. So you can titrate your appliance by a minimal advancement, then advance further every 2 millimeters and see how the polysomnography improves. But are these oral appliances, without any side effect? No. There is a reduction in overjet and overbite. So, our occlusal scheme is altered. There is labial movement of the lower incisors and lingual tipping of the upper incisors. Also, there is a tendency to develop a lateral open bite. So, occlusal changes, if they persist, these appliances need to be discontinued. So, oral appliances need to be dealt with caution. So if I would say what would be the take-home message in oral appliances, they are usually effective in non-obese patients with a retrognathia or a micrognathia, and they are better for mild to moderate cases. They are not the single solution for moderate to severe cases. And we need to be very careful as dental surgeons to consider TMJ dysfunction and occlusal changes. So what are the challenges, or maybe I would say a relative contraindication when there is insufficient tooth support, few teeth present or a knee dentulous patient, periodontal issues, poor oral hygiene, multiple carious teeth, and patients having bruxism or TMJ disorder. So these are patients where you need to treat with caution. Surgical options are also in the preview of maxillofacial surgeons, and we have an eminent maxillofacial surgeon on the panel today. So I would not be going into detail. This is just to educate you that if the oral appliances do not work well or are not tolerated by the patient, the other options are surgical options. So multiple surgeries have been prescribed. The popular ones are adenotonsillectomy, mandibular advancement, maxillomandibular advancement, and uvulopalatoplasty procedure. So, we could even prefer a RME in pediatric OSA, where the AHI, oxygen desaturation, and mean oxygen saturation improves just by expansion. Also, distraction osteogenesis. Now, this is a case published in the American Journal of Orthodontics, where a 59-year-old white man has been treated. So you look at the pre and post outcomes. You look at the pre-occlusion, you see a constricted maxillary arch. So, and you look at the final outcome. So how this has been achieved. And you look at the cephalogram on the right side, how the airway has improved. Now, first thing done was a surgically assisted rapid maxillary expansion. The surgical cuts were made and rapid maxillary expansion was done. This was followed by a mid-symphysial distraction. Cut was made in the symphysis and distracted. Therefore, the airway got opened because tongue got its space to rest. It was not being pushed back. Now, maxillomandibular advancement is also possible. So you could do a maxillomandibular distraction together. You could do a maxillomandibular advancement with advancement genioplasty, the genial tubercle advancement and hyoid suspension, and you could do just advancement genioplasty. So it depends on the reason for the cause for OSA. Adenotonsillectomy, when there's a hypertrophy, they can be removed and it has a positive effect on decreasing snoring, weight problems, enuresis, and behavioral problems in children. tongue procedures can be done, like laser midline glossectomy, lingual plasty, radiofrequency volumetric tissue reduction. So there are multiple procedures which can help in treating OSA patients. Then uvulopalato-pharyngoplasty, it can be done with laser. What the excess tissue from the free margin of the soft tissue is removed. Then what would be a mind map? So there are multiple options, surgical and non-surgical. Both involve the dental specialty, maxillofacial surgeons or orthodontists and the dental surgeons working together as a team. So what would be your mind map? A patient refuses CPAP and surgical evaluation, you go for an oral appliance. The patient tries CPAP and he is not able to cope with it, you go for an oral appliance. A patient refuses CPAP, ENT evaluation is done, and oral appliance is prescribed. But if a surgery is prescribed and surgery fails, the option is to fall back on an oral appliance. But many times surgery has a wonderful effect, and after this we might need an oral appliance as an adjunct to improve the airway slightly further. So again, we as dental surgeons can become good part of the team. So you would ask a question that why OSA is so important. If it's left untreated, how does it matter? Well, it strains the cardiovascular system. There is systemic inflammation with release of mediators like IL-6, TNF alpha, and fragmented sleep. There is a possibility of poor quality of life, drowsy driving, accidents, decreased work performance. In children, OSA may lead to failure to thrive in many cases, enuresis, ADD, behavioral disorders, and decreased academic performance. So if you wanted to, answer a patient's query that why I should get my OSA treated, you could just put this, mind map in front of the patient saying that there would be sleep fragmentation leading to sleepiness or neurocognitive effects. There could be hypoxemia, which could have a systematic surge and inflammation, endothelial dysfunction, hypercoagulability, negative intrathoracic pressure could lead to a number of cardiovascular issues and endocrinopathy. So I'd conclude saying that oral appliances are a treatment option in the management of sleep apnea. Presently, there is no single variable that can reliably predict treatment outcome with oral appliances and no sole determinant of treatment success. But a constellation of features exist that, if present or absent, can possibly give an indication of the treatment response. Thank you very much for a patient hearing.
Thank you, sir, for your engrossing lecture. May I kindly request our chairpersons to share their viewpoints.
Thank you so much, Dr. Puneet Batra, for enlightening us on this very wonderful topic. Actually, sleep apnea has been a topic of focus of interest in last few years, and you have given a wonderful insight into the topic. And the most important thing you have highlighted is the interdisciplinary part. Your storytelling was actually very, very motivating. So thank you so very much. It is always a privilege to hear to your talks. Thanks, Atan.
Thank you so much, sir.
Thank you, sir. May I kindly request you to felicitate our guest speaker with a token of our regard.
So Dr. Puneet, from whole of the organizing committee, please accept this.
Thank you so much, sir. Thank you all.
Thank you, sir. May I kindly request our esteemed chairperson, Dr. Vikas sir. Thank you, sir. May I kindly request our chairperson, Dr. Vikas sir, to introduce our third speaker.
Thank you, Dr. Puneet. It was a real privilege to listen to you and a wonderful oversight what you have given. We come to our next speaker, a very eminent personality, Dr. Mohammad Yusumidail Putera Mohammad Yusuf, an associate professor and clinical consultant in Forensic Odontology and Dentomaxillofacial Imaging Center, for Oral and Maxillofacial Diagnostics and Medicine Studies, Faculty of Dentistry, University Technologia MARA, Sungai Buloh campus. His area of expertise include forensic odontology, dental age assessments, advanced medical imaging. He specializes in medical legal age assessments, experience with all stages of age assessment procedures in refugee status determination and disaster victim identification process. He has a strong background in advanced applied statistics and dental imaging. He is a board of study member for postgraduate program study 1 + 3 years, Faculty of Dentistry, UITMI for Doctor and Oral Maxillofacial Surgery program. His research milestones include Innovation Awards, 3 International Special Awards, 5 golds, 2 silvers, and 1 bronze. Kero Gelmik Special Award for Republic of Croatia in 2021, as well as 11 copyrights and 1 patent filed. He is the associate member of Pertuban Academy Professor Malaysia under the Ministry of Higher Education Malaysia. Now I invite Dr. Mohammed to speak on artificial intelligence in dentistry. Over to you.
Hello, good morning, everyone. Well, first of all, I would like to thank the committee of the DENTOCON 2022 for inviting me to talk on this particular topic, artificial intelligence in dentistry, which is the very research niche of my area. And I hope that at the end of the day that we can have a fruitful discussion on these particular topics. Right, and for today's talk, I'm going to talk about the definition of artificial intelligence, as well as the clinical applications of AI in dentistry. And we are going to look as well on the promising realities of AI in dentistry, on other things, that may have been get into our practice nowadays. And at the end of the day, I'm going to share my own experience doing this AI, develop the machine learning system on the dental age estimation of something that what we call the FDentist lab, forensic dental age estimation lab. All right, so what is artificial intelligence? In computer science, artificial intelligence is also called machine intelligence, right? Which is something different from a natural intelligence that has been displayed in humans and animals. All right, so because in humans that we quantify the natural intelligence as IQ, and this is not something similar with machine learning or machine intelligence, whereby that all of these are actually quantified by the data. Right, so the terms artificial intelligence is used to describe machines that can mimic the cognitive function that humans associate with other human minds. All right, for example, like our learning experience, our learning capabilities, and our decision to solve certain problems. Right, so these are all the cognitive function that needs to be mimicked in the AI or machine learning. All right, so if you look into this particular diagram, you can see that, the more the sample size, the more that, the less the reliance of the certain decision on human being. All right, so for example, like what you can see here, product recommendation by Amazon, for example, they have like a very big sample size. And in terms of the reliance of the human decision on that is less as compared to, as compared to the system. Uploading certain photos on public domains on Facebook, basically that they will give suggestion that whether they want you want to tag a certain people based on their facial recognition on Facebook. All right, so this is actually one of the example of the machine learning and big data, because with Facebook that they actually acquired a lot of data, big data as well. So basically they can do something like that, on facial recognition. All right, so what we have done so far in clinical application of AI in dentistry, all right, so we have seen like quite a number of systems, that have been in place in dental practice. One of the clearest example of it is in radiology, whereby that we are seeing more and more system, AI system that has been developed to detect a certain pathology that you can see, you can view in radiograph, in digital radiographic image. All right, so this is actually, when you talk about AI, radiology is always the first department to come across it, right? So, and we can see that, from the other disciplines as well, for example, like the orthodontics, the periodontics, and the oral-pathology. So all of these field, they look into a certain prediction model, and they compare it with the conventional human expertise, and they look into the accuracy percentage of them. All right, so basically that when you see all of these accuracy percentage, they are almost similar with what have been performed by the conventional method, which is the decision by the expert themselves. All right, but the thing is, what is the most wonderful thing about AI is actually that although that the accuracy is not that difference, I mean, in terms of the statistical significance, but the thing is, when we are doing something with AI, it reduces the time to do certain things. All right, for example here, if we are going to take sometimes, for example, like 10 minutes to read and interpret panoramic radiograph, for example, or CBCT, in fact, for that fact, basically AI can reduce the time, maybe about 2 or 3 seconds, and then come out with a framework on, okay, this is actually the differential diagnosis and so on and so forth. All right, so basically that's actually one thing, that is beautiful about AI, is actually that it reduces the time to do certain things. All right, and this is actually another thing about the AI, whereby that there's a system out there that has been put forward, what they call it, fourth IR. All right, so this is actually pertinent to the virtual dental assistant, whereby they, in traditional way that we always have someone to man the front counter. I mean, that this particular person is actually the one who is going to call the patient for the appointment, for the follow up, and then settle the billing, and then take another patient, and then put on waiting list, something like that. All right, so basically that when we do have something like this, so basically that it's going to speed up the process, the whole process in the clinics. All right, so and the best thing is actually that everything is in your fingertip. I mean, you can just get the iPad and then put the patients in for waiting list, put the patients for the follow up, do some documentation, do the billing and everything. So everything will be in this particular system. And all right, so let's maybe that it's good to have a look at some other promising realities of AI in dentistry as well, because some of this particular system is already in place in our dental practice, and some of it may be good to have. All right, so for example here, the smart technology is what you can see from this particular photo. This is actually a smart toothbrush, whereby that is not only just to clean up the teeth, but it also gathers some data. Right, so there's a camera with this particular smart toothbrush, where on top of just clean up the tooth, they also take photos of the intraoral images, all right? And then they feed it into the AI system, whereby that this particular AI system is going to diagnose or predict whatever is going to is happening in that particular condition. For example, like, you know, they can see caries, or they can predict caries extension. They can actually look into some progressive pathology. All right, so these are actually the things that has been there, right? But I'm not sure that whether this particular smart toothbrush is already in the market or not, right? But it is actually one thing that yeah, we can do with AI. The next thing about the promising reality of AI in dentistry is about the voice recognition, right? So this is actually something that I suspect that it is not in our dental practice yet, but I think it is good to have, because you know what I'm thinking about this voice recognition is actually that when patients come to a dental clinics, you know, and they explain about, you know, the condition that they have, right? So the toothache that they have, you know, starting from the last week, for the past 2 weeks, all right? And basically that this voice recognition, it can gather certain information based on the description by the patient, and they can come up with certain framework to make a differential diagnosis, for example, right? So basically they can pick up all of these key keywords on what has been explained by the patient, and they can actually formulate it into a certain AI framework, right? So this is actually something that's I think it's going to be a very good addition to what we are doing at the moment, right? Because one thing is going to reduce the time, and another thing that you know, the dentist or the specialist do not have to, you know, put in information into the system, because you know, whatever information that they have from the patients actually managed to be captured by the voice recognition. All right, so another thing that we are looking at, you know, in the AI in dentistry is the imaging system integration, right? So I think for those of you who are working, you know, with this particular system we call PACS, all right? So this is actually for the radiology communication. Basically that, you know, we can do a lot of wonders with the PACS, all right? In this particular example, all right, so when the scans are sent to the PACS for storage, basically this particular scan can be fed into the AI platform, whereby that this particular AI platform is going to look for all the frameworks, you know, for example, like, you know, if they can look for certain pathologies, they can look for a certain variables, you know, and prediction, and after that they are going to send back, return it back to the PACS for storage. All right, so this is actually a good thing, right? Because we always know that PACS is just for communication, you know, when we want to transfer an image from one format to another, and then to store it, you know, in online. Basically, it can do a lot more than that, you know, with this particular integration of AI, right? So, and I think this is actually one of the best thing of AI in imaging system. And of course that, you know, when we are talking about the AI in dentistry, the surgery is always one of the discipline that's actually it's going to benefit a lot with AI, right? And nowadays that we have heard about, you know, the robots is performing surgeries on patients and so on and so forth, right? So in this particular case, that this particular robotic surgery assistant, of what they call them Yomi, helps dentists to do dental implants. All right, as what you can see here, although that I don't think that this particular Yomi is actually inserting the dental implant themselves, the dental implant to the patients, but rather it's actually help to you know, to assist the implantologist, All right, so basically that, the dental implantologist is going to be there to insert the dental implant, right? But as what you can see from the photo, actually, that this particular robot is the one that is the one to hold, the instruments and then and everything, so that when the clinician is going to perform the surgery or to perform the implant, basically they don't have to turn their body to to pick a certain to pick up certain instrument and everything. So basically, I think that this is actually one of the best thing to have nowadays, right? So that's something that's yeah, for me, that this is something that can be very, very beneficial. All right, so I think that we have talked about the AI in clinical practice and clinical setup. All right, so I just wonder that how about a little AI for our young students? If you watch Star Wars, then basically that there's a term Padawans there, right? So okay, so there's this thing that that's really actually, I think when I learned about this particular AI system, well, I do feel actually that I have a mixed feeling about it. And on one hand, that I do feel that this is going to be like yeah, beneficial, especially that if you have certain condition. But on the other hand, that it can lead to abuse as well, right? But of course, that whatever that I'm going to suggest afterwards, I think better not to bring your supervisors along, because if they know, then it's not going to be a secret anymore. All right, so that's one system. They use the AI text content generator. They call themselves a Shortly AI. All right, so using this particular system, you can just put in the topics there. All right, so just put in the topics, and then you can just click the start writing, and this particular system is going to write it for you. All right, so according to the topics that you have put in. Right. So for example, if you want to put dental implant, so basically that when you click on start writing, so there will be like several texts that will be written based on that particular topics. All right. So this is actually one of the thing that can help you in a way that, for example, like for many authors. Sometimes that when we write, sometimes that we are going to get this what we call a writer's block, right? So sometimes that although that we are well versed on that particular topic, but sometimes in a bad day, you can't really come up with anything, right? So that's actually a writer's block. And for me as well, that I've got into that kind of situation quite often as well. All right, and I think it is good to have this particular system to help me to write something, and I'm going to edit it later. All right. And there's another one that what we call a Jarvis AI. All right, so this is again another AI text content generator. And when you look into it, actually that from what they say here, they can help you to finish your first draft 2 or 5 times faster. And then if you are active in social media, basically that it can scale up your content fast. And of course, and writer's block with ideas from robot, and then it can also help you to if you're having a language barrier. So basically this AI system is a thing for you. All right, so I'm going to share a bit about my experience on the AI development, the system that we have developed using AI on the dental age estimation. Right, and these are actually our dental age estimation milestone. Okay, I've started this particular prediction modeling back in 2011 all the way until 2016. All right, so during this period, I used multiple linear regression for dental age estimation on Malay population. And after that, from 2018 to 2020, I work on machine learning with one of my PhD candidates. And up until now that we are working on the CNN framework for fully automated age estimation system, right? And eventually that we come out with this particular system, what we call the F-Dentist lab, the Forensic Dental Age Estimation Lab. And this particular system is fully automated, whereby that, if you have a digital panoramic imaging and you can just feed it into our system, the F-Dentist lab system, and our system can come up with the estimated age on that particular individual. All right, so how this system works, I'm going to tell later. Right, but if you want to collaborate on this particular project, you can always email my PhD student, Hasmira here. All right, so because actually that, when we want to develop a certain things based on AI, we need a lot of members on that. So if you are interested, please drop an email to her. All right, so this is actually the starting point, all right, because when we wanted to develop this particular system, I, as the end user, I just say that, okay, I want to have a system that is quick and it has to be at the end of the day that I want to have the dental age, the estimated dental age with a good accuracy. All right, so this is actually what I had in mind. So, and then this is what has been translated into the system. First of all, that we need to load the image. All right, so this is actually the panoramic imaging radiograph. And the machine learning is going to do the segmentation, the image segmentation, which is fully automated, and it's going to outline the morphology of the teeth and then the stage of it. And after that, it's going to be analyzed in terms of its shape, the shape analysis. And after that, after shape analysis, then the stage profiling will be done, and it's going to translate it into the estimated dental age. All right, so for the implementation of the deep convolutional neural network for dental stage classification, we use Python and deep learning libraries, as what you can see here. Right, so these are all the models that we use to implement the deep CNN for this dental age classification. And in terms of the proof of concept that we already proved it, all right, so this is actually an evidence from what you can see from our publication here. We published in 2020 based on this particular shape analysis on the first molar. All right, so this is something that you can see the segmentation from this particular tooth here. Of course, that when we talk about the CNN, convolutional neural network, well, this is actually the algorithm of it, because the algorithm is actually based on the brain-inspired learning. All right, because if you still remember that I mentioned about the cognitive function that we wanted to emulate. All right, so in this particular case, that we need to have a lot of data. All right, so we are very lucky, during this development, we managed to get more than 2,000 digital panoramic radiograph to develop this particular system. All right, so this is something that you can see the convolutional one, max pooling, and then so on and so forth, right? So I think, yeah, this is as far as I can describe it to you, because I am not an engineer and I am a forensic odontologist. So basically that, if you, ask me on how to estimate age conventionally, well, I can answer that. But the thing is, if you ask me convolution and max pooling and how to go about it, well, I need to maybe refer you to my PhD student. All right. So, but the thing is, in the end of the day, that this is actually what we do for F-Dentist Lab. All right, in terms of segmentation, we use this segmentation method that what we call the DPAC, Dynamic Programming Active Contour. All right, and all these are all the formula that we use to get all of these radial lines. Right, so these are all based on the three publications that we have got. And then you can see that these are the radial lines that we do for the segmentation to form a close contour on the schematic diagram of the tooth delineation. Right, so this is the photo that you see here. Right. So in terms of the segmentation themselves, all right. So this is actually what you see from a digital panoramic radiograph. All right. So first of all, that we assign of the bounding box of the original input image, and then we crop the region of interest, the ROI, with some special filter, Clahy filter. And then after that, we assign the initial point of the close contour. And after that, we delineate the region of interest. And after that, then we convert it of the RI from polygon to binary image. And at the end of the day, that you will get this kind of image here. So this is actually the basis of the staging profiling that we are doing before we get the estimated age. Right. So for those of you who are interested in this particular work, that you can check out this, the publication that we have on this particular project. All right. So and then yeah, you can have a look on this publication. All right. So this is actually how the system looks like. All right. So first of all, that you need to log in into the system. All right. So you have to put in your staff number, to log in, just to make sure that you are actually the operator of it, and then put in your the patient's name, the name, gender, address, and everything, and so on and so forth. And after that, then you need to actually check on which tooth that you are going to to assess. All right. So for example, like for those of people who only have first and second premolar, just check on first and a second premolar box. All right. If the patients have all the seven permanent teeth, then basically that you just check all the boxes. All right. So in this particular case, that we are not looking into third molars, but third molars is actually something that we have in mind, which is going to be an extension of this particular project, which we are going to complete by next year maybe. Right. And after that, we fill in the digital panoramic imaging and select the image based on the patients. All right. And after that, then we are going to begin the estimation. All right. And the analysis is going to take place. And after that, proceed to dental age estimation. Yeah. And then at the end of the day, that after the analysis, the estimated age will be here. All right. So in this particular case, that the estimated age of this particular individual is 10.5 years old. All right. Okay. With that particular prototype, that managed to secure a lot of special awards in international and national innovation competition, and one of the highlight was actually that we managed to get a Creso Glavach special award, the award that has been gifted by the Republic of Croatia. All right, and it was given by the ambassador. All right, and these are actually the team members, and I think all of us have a different background, and I think three of us is actually that came from electrical engineering, and basically that they are the one who actually propel this the formulation and so on and so forth. All right, so I think this is the last last slides that I want to share with all of you on tips on prototyping in AI, right? Because actually that when we wanted to come up with AI, basically that it's always something application based. All right, so something that we can use at the end of the day. Right, first of all, that you need to brainstorm. Of course, you need to identify the end user. You have to identify that who are going to use your system at the end of the day. All right, and then you need to have a good team members, although that this is actually easier said than done. But the thing is, you need to really be choosy on this. Right, so you need to have a very good team members to to progress together. Right, not someone who drag you behind. All right, and it has to be, this is important, it has to be interdisciplinary, because I personally, I don't believe in working in silo. All right, because we are not that anymore. I mean, that dentistry has been progressed so much that we as a dentist, we are not just a dentist. All right, so we are actually, you know, made up with some other discipline as well. So in this particular case, that, you know, if you want to perform an AI, basically that there's no way that for you to work alone. All right, so you need to get someone from electrical engineering, from the computer expert. All right, so basically to develop the system. And of course, go for innovation competition, get as many critics as possible, because this is actually going to improve the product itself. All right, and it's going to boost confidence. And of course, that you need to enhance the prototype from time to time. And the next thing that you need to have to do is actually you need to protect what is precious, right? So in this particular case, that you need to protect, you need to get the copyright, or you need to file for patent, right? So IPR, intellectual property right, all right? And you need to also look into the TRL, the technology readiness level. You need to know that, okay, which level are you in now? Are you still in the proof of concept level, or are you in bench testing? Right, so you need to understand this. And last but not least, that you need to commercialize it, right? So what's the point of develop an AI system, but you cannot commercialize it, you cannot sell it, you cannot license it, right? So basically, it's important to have this as well. But I do know that because this is based on my experience as well, because we in academic, that we are not actually quite well versed with commercialization, right? So in this particular case, that you need to have someone in your team member that is well versed in commercialization. So basically, their contribution is actually to get your products to further development and to the market. And basically, they have to market it. All right, so and they need to be someone who is good in commercialization. All right, so I guess I'm going to stop here. All right, so because I only have half an hour. All right, so I do want to actually display the our FDentist Lab a video, a promotional video. But the thing is, because of the time constraint, I cannot do that. But if you really want to have a look on that, just drop me an email here. All right, so I'm happy to send you the link, you know, for this particular promotional video. All right, and if you want to collaborate as well, you know, we are actually, you know, we are all, our hands are open to everyone if you want to collaborate with us. Well, with that, I thank you for your attention, and I again thank the committee for this opportunity. Thank you. Goodbye.
Thank you very much, Dr. Mohammed. It was an excellent presentation, keeping in with the present times. Yes, that is one scope which you have told, artificial intelligence in dentistry in age estimation. But I am sure there are many more applications to it. Time has come when we generally say, will artificial intelligence or robotics take over us as dentists? Yes and no. Yes, in the sense they will help us to make better decisions, but final decisions will definitely have to be made by the dentist or by the operating surgeons. We cannot leave everything to machines, but it will streamline us to make decisions. Great application on your part and innovation. I have seen this age estimation problems popping up almost everywhere, and to be, you know, different minds and different sets of minds, it may appear different, but when you have a huge database analyzing you would definitely get better results on that. I congratulate you for your innovation and your wonderful work you are doing. Thank you very much. And as your appreciation, we would like to present you the certificate of appreciation. And I think with this, we do come to an end of this session. And it's been very informative. And I congratulate also the organizing team, which has done such a wonderful work in hosting the session and trying to get the best speakers in. Thank you very much. And my co-chairman, Dr. Jagat, who was here with us. I cannot see him on the screen at present. Maybe
No. I am there, but I am driving right now. So
okay, Dr. Jagat, thank you.
Turn the screen on.
Yeah, thank you for being there.
I had to rush for some pre-committed
no issues. Absolutely no worries. Thank you. And on behalf of Dr. Jagat also, I'd like to thank everyone.
Thank you so very much, everyone.
Thank you, Dr. Vikas. And thank you very much, Dr. Jagat, for being with us and sparing your valuable time. Thank you once again.
Thank you, Dr. Sanjay, and all the organizing members. Thank you.
I request you all to put on your cameras for like a few seconds. We would like to take a group picture for this session.
Please excuse me. I am driving right now, so it is from my Bluetooth.
Right, sir.
I'm connected.
Right, sir. Thank you. Thank you so much.
Bye bye. Have a nice day. All.
Thank you, Ji. Please take care. Thank you.
Thank you.
Thank you, everyone. We would like to conclude this session. We will be beginning with the next session on UG paper presentation after a break of 2 minutes.
Good afternoon, everyone. It is my pleasure to welcome one and all to this undergraduate paper presentation in DENTOCON 2. We hope all of you are enjoying this feast of knowledge. So in continuation, now there is paper presentation by undergraduates. We appreciate enthusiastic participation by numerous delegates from different dental colleges. And it was really tough to screen these papers. But due to time constraint, only 15 papers were selected for the designated time in this session. I now welcome our judges for this session. Our first judge, Professor Shivani Mathur. We welcome you, ma'am. She is currently serving as a professor and head, Pediatric and Preventive Dentistry, ITS CDSR, Muradnagar, Ghaziabad. Dr. Shivani has many national and international publications to her credit. She won many awards at national and international platforms. Her field of interest includes nitrous oxide inhalation sedation. And our second judge is Professor Imran Khan. We welcome you, Professor Imran. He is currently serving as a
Thank you.
professor in the Department of Oral and Maxillofacial Surgery, Faculty of Dentistry, Jamia Millia Islamia, New Delhi. He is currently serving as he has authored many publications in various national and international journals to his credit. Dr. Imran has delivered many lectures in national and international conferences to his name. His field of interest includes maxillofacial trauma, maxillofacial pathology, TMJ disorders, and dental implantology. This session will include 6 minutes presentations followed by question and answer round. So I request all presenters to kindly stay connected with us to address questions put up by judges. So here we'll start with our first presentation. Our first presentation is by DENTOCON 004.
Thomas Edison says, the doctor of the future will give not medicine, but will instruct his patients in care of human frame, in diet, and in cause and prevention of the disease. Greetings, everyone. We are here to present to you From Treatment to Holistic Care, a paradigm shift in the journey of emerging dental surgeons. The purpose of our presentation is to bring in front of everyone how we have evolved in our journey, emerging with a wider horizon and a fresh approach. As WHO has rightly defined health as a state of complete physical, mental, and social well-being, we are here to showcase some rare cases whose social and psychological journey changed our way of thinking and working, and made the second-year student in us who practiced and perfected technique into a doctor with a fresh insight, a humane touch, and backed with scientific knowledge. The first case that we are presenting today is of a 4-year-old female patient with phocomelia associated with blindness since birth. Just to highlight, phocomelia is a rare congenital autosomal recessive anomaly in which proximal part of the limb is absent or markedly hypoplastic. The most recognized cause is thalidomide, a drug consumed during pregnancy to reduce nausea and vomiting, which was also consumed by our patient's mother. Looking at the case, we can see that the behavioral setbacks that the child and the parent must be suffering from are far greater, and our role is to not just provide dental treatment, but also counsel them for proper prosthetic rehabilitation. Behavior modification techniques require modification as per the associated comorbidity. In our case, due to the visual challenges, we took up the tell, touch, and perform technique instead of the classical tell, show, do technique that really made a difference.
Next case is of a 15-year-old boy experiencing pain in right mandibular posterior arch. He was a known case of Mobius syndrome with severe mental retardation. He had reduced vision, was physically dependent, and severely malnourished. On oral examination, reduced mouth opening with missing 2127, retained root stumps of 5455, multiple decayed teeth, and a draining sinus with 37 was found. Mobius syndrome, as we came to know in our practice, is a very rare congenital neurological disorder characterized by facial and abductor nerve paralysis, resulting in inability to close the mouth and eyes, make facial expression, sucking, and speech difficulties. The lack of facial expression may hinder parental attachment or others to believe that the child has no emotions and are often teased by other children. Our role as dentists comes into multiple fronts in this case. First, during dental treatment due to paralysis, we need to ensure proper mouth opening, saliva control, and isolation, while simultaneously counseling parents about this rare disease. Next, this is a 6-year-old boy with facial hemangioma reporting with chief complaint of food lodgement in right lower back tooth region. However, there was absence of any cognitive disorders or physical problems. In this, we provided only a simple restorative treatment. But as we know, 40 to 60% of hemangiomas are located in the head and neck region. From dental perspective, it becomes important. While giving anesthesia for extraction, we choose the farthest nerve block, and injecting the affected area should be avoided. In case for which there is difficulty cleaning the oral cavity due to fibrous perioral scars, the use of water jets and soft bristles with rounded tips should be used to avoid gingival trauma. Apart from treatment, psychological support should also be provided by us because of the associated social stigma and discrimination, improving self-confidence and quality of life of young patients and their parents. Next, we are discussing 2 cases of cleft lip and palate, and what we would like to focus on is the parental concerns that range from feeding difficulties to frequent ear infections, nasal voice, dental anomalies, to name a few. Extensive interdisciplinary approach is required for such cases where we have surgeons along with orthodontists, pediatricians, and pedodontics to manage nasoalveolar molding and subsequent steps in treatment so that the patient can resume normal growth. In our case, we work on educating parents regarding feeding habits, prevent nasal regurgitations and aspirations, like breastfeeding the child in upright position, small frequent feeds with burping, and use of feeding appliances. Lastly, we have a 2-year-old boy with Lesch-Nyhan syndrome, and he came because he had an ulcer on his tongue, for which we could only provide a palliative treatment. Examination revealed a large, ill-defined ulcer covering 2/3 of the tongue with a small ill-defined scar on the right forefinger. History revealed that the parents had got the child's lower interiors extracted due to this habit. Lesch-Nyhan syndrome is a rare heritable metabolic disorder of purine metabolism. Affected individuals show mental retardation, behavioral disturbances, and excessive habit of self-mutilation. However, the patient is often conscious about his behavior. As dentists, our concern also include hyperreflexia, excessive vomiting, and choking, resulting in mutilation of the oral tissues. Such cases require sensitization of both child and parents. Other than the palliative treatment, the counseling ranges from dietary modifications, giving small, frequent, high-caloric diet, to restraining the child to chairs which permit them to use their muscles and participate in the environment. Use of intraoral appliances to prevent self-inflicting injuries to oral and other parts of the body, and use of drugs like benzodiazepines, antidepressants, anticonvulsants have also been useful in controlling self-mutilating habits.
So what we have observed through our journey is that the dental concerns which the patient has is just the tip of the iceberg, and the underlying social stigmas, financial burden, and its psychological impact are often overlooked. We cater to the various dental needs of the patient and the parents, but what we don't address to is the psychological repercussions of the disability, like anxiety, low self-esteem, inability to accept dental treatment, financial burden of the treatment, social stigmas, and discrimination associated with mental disorders. Government schemes and NGOs are still lacking, leading to poor rehabilitation of these complex problems. The use of interdisciplinary models like general health, preventive dentistry, and counseling is fundamental to improve the quality of life of such patients, enabling them to live their life with ease and with less difficulties. The conditions that we have discussed are agonizing and incapacitating for the patient and the parents, but we need to guide them to a healthier future. So we would like to conclude by saying that in our journey, we have realized that dental surgeons play an integral role towards providing not just basic, but holistic care to the patients. And in future, from our side, we would like to provide the best comprehensive care to our patients. Thank you.
I request judges for their comments.
Yeah, both the presenters presented very well, and I must congratulate you that you have come across such kind of cases so early in your UG curriculum and have got exposed to such kind of cases. And definitely at the same time, you have developed a sense of empathy and care, and to deal with such kind of conditions in day-to-day basis. So good presentation. All the best.
Thank you, ma'am. Thank you, ma'am.
Yeah, dear students, I have a few questions for you.
Yes, sir.
In the second case where you presented the child with the Mobius syndrome, he was having a cellulitis of he was probably having a cellulitis of one of the spaces. Because of that, he was not able to open the mouth wide, right?
Yes, sir.
So I could see in the clinical photograph that, this area was all red. Okay?
Yes.
So what treatment did he get?
So intraorally, we saw that there was a draining sinus. So we put the patient in the first visit, sir, when the child came, he was in a lot of pain and he was definitely not comfortable with our OPD setup because it was his first visit to a dental specialty clinic. So in that visit, we prescribed him with antibiotics, started him on antibiotics and analgesics, and sir told the parents about the dietary modifications that we could do, start him on soft diet. And sir, subsequently we did an incision and drainage, and then sir, the tooth that was associated, sir, it was already exposed. So with the help of a spoon excavator, we performed initial excess opening, and sir, that helped to alleviate the pain of the patient.
Okay, one last question.
Yes.
Just for the sake that how much are you prepared for this paper? Can you tell me the difference between hemangioma and an AV malformation? Because one of your cases featured patient of hemangioma.
Sir, difference between hemangioma and AV malformation.
Yes.
Sir, in our case, like we saw that the hemangioma could be again, sir, intraoral or extraoral. And sir, in case of an AV malformation, we
So anyways, it was a good presentation. I would like to congratulate your teachers as well. Such rare cases we generally don't encounter. I remember my internship days, I did not see any of these cases. Congratulations and well done.
Thank you, sir. Thank you.
Now we move on to our next presentation. Next presentation is by registration number 0189.
Good morning to all the respected dignitaries. Today, the topic for my paper presentation is systemic lycopene as an holistic approach to non-surgical periodontal therapy in generalized chronic periodontitis. So, what do I mean by holistic approach? Holistic approach means to visualize the oral health as an integrated part of the body. So, we are administrating systemic lycopene as an adjunct or as an holistic approach to non-surgical periodontal therapy in the patients with generalized chronic periodontitis. So let's begin with the presentation. So periodontitis is an inflammatory process which is initiated by plaque biofilm that results in destruction of the tooth supporting periodontal tissue and ultimately leading to the tooth loss. Now, lycopene is an antioxidant. It associated itself to chemical species that reacts to oxygen, and this unique property of the lycopene makes it the most effective oxidizing agent. C-reactive protein levels, we know that C-reactive protein is an inflammatory marker which is released by the liver, and its levels are elevated whenever there is inflammation. So periodontitis is an inflammatory disease. So CRP levels are elevated in severe chronic periodontitis patients. Now, this short-term investigative study was done to ascertain whether or not daily systemic supplementation of antioxidant adjunctly used after scaling or root planing would improve the clinical conditions of the periodontitis patients or not. So, our aim of the study, the aim of this short-term study was to evaluate the potency of the systemic antioxidant like we have given lycopene in the form of soft gel in the non-surgical treatment of the chronic generalized periodontitis. So materials and methods, we have taken 20 systemically healthy patients between the age group of 35 to 50 years of age, both male and females, they were included for the study. And these patients that we have taken, we have chosen it from the outpatient department from our college only. So there are some inclusion and exclusion criteria for our study. We have included the patient who are systemically healthy in the age group of 35 to 50 years of age, and the patients who have not taken any antibiotic therapy within 6 months of the duration, the patient who are not taking antioxidant minimal, they should be having minimal 20 natural teeth, the patients with chronic periodontitis with raised CRP levels 3 milligram to 6 milligram per liter. Only those patients they are included in the study who agree to sign a informed consent. So we have taken consent from the patient also. Now, exclusion criteria, the patients who are not included are the patient who have systemic disease, they are excluded. Patients on antibiotic therapy, they are excluded. Who are already taking antioxidants, they are excluded. The patients with less than 20 natural teeth are excluded, and patients who had undergone periodontal therapy, they are excluded from the study. Now we have chosen two groups, one control group and one test group of 10 patients each. Now control group is treated, the control group patients, they are treated with full mouth scaling and root planing, and in the test group, 10 patients were treated with full mouth scaling and root planing, and then they were advised to take systemic lycopene 20 milligram with 24-hour completion of the scaling and root planing. So what was our result for the study? The study was done among two groups of 10 participants each. As I discussed, one group was provided with scaling, root planing and lycopene, while the other group was treated with only scaling and root planing. And the objective symptoms that was assessed with the help of C-reactive protein and community periodontal index of the treatment needs, that is CPITN levels. The symptoms of the patients were assessed at baseline and after 1 month for any improvement with the management that we have provided. So we have one control group and we have one test group. The levels of CRP, when we see the control group, the CRP value at baseline range from 3 to 5.9 with a mean value of 4.58 plus minus 1.08, and after 1 month of treatment with scaling and root planing, the CRP value declined to 2.5 to 5.4 with a mean value of 3.96 to 1.08. Plus minus 1.08. This clearly indicates a significant decrease in CRP value. Now, when we see the control group CPITN index, there was a significant reduction in periodontal disease as measured by CPITN index. CPITN values, they were measured with the help of Pearson chi-square test. The values of Pearson chi-square test was 23.60 and p-value 0.02, which proved definite reduction in the disease. So this graph showing a definite reduction of the disease. The baseline individuals, they are marked with blue, and the treated individuals after 1 month, they are marked with the red in this graph. Test group, when we talk about test group, the CRP value at baseline range from 3 to 6.2 with a mean value of 4.87 plus minus 1.09, and after 1 month of treatment, the CRP value ranges to 1.1 to 4.8 with a mean value of 3.1 to 3.1 plus minus 1.05. So this clearly indicates significant decrease in the CRP value with a T value 10.83 and 0.00 P value. So this test group has shown significant reduction in CRP with a value of 0.62, and control group a significant reduction of 1.77 in CRP value. So concluding our study, we know that lycopene, it was used as an adjuvant. It is an antioxidant. It is occurring. It is a naturally occurring red pigment that is responsible in red to pink colors seen in tomatoes, pink grapefruits, and other foods. Systemic lycopene administration, 20 milligram administration of systemic lycopene for 1 month was used as an adjuvant. Serum CRP levels was done to evaluate the oxidative stress, and significantly there was significant reduction of the CRP levels, and clinical parameters, they were improved between our two groups, that is control group and the test group, which proves that lycopene as an antioxidant adjuvant to the non-surgical periodontal therapy, it was effective in reducing inflammation and oxidative stress among the chronic periodontitis patient. So to summarize this study, lycopene as an antioxidant is a promising treatment modality as an adjunct to full mouth scaling and root planing. It helps to modulate the oxidative stress in periodontium during periodontitis, and it also leads to maintenance of the periodontal health. Thank you.
I request judges for their questions.
Ladies first, Shivani madam, you please.
Okay, so very nice study. Just have one question. I just want to ask, how did you standardize the post-operative phase, that is post-scaling phase of or the root planning phase of the patient? That is, you obtain the CRP levels after 1 month of starting with the scaling and the root planning and starting with the lycopene therapy. So how did you standardize that the post-operative patient care was the same in the both the test group as well as the control group?
I didn't understand the question, ma'am. Post-operative care.
So basically, if it's a periodontal disease, periodontally compromised patients, definitely there must be certain factors which may be leading on to periodontitis, maybe improper brushing hygiene, improper oral hygiene, etc. So did you advise the same things, that is 2 times brushing, or maybe the use of chlorhexidine or some other post-operative instructions which you gave in both the group? Because there must be certain additive factors which may be true to one group but not the other group.
Yes, ma'am.
You understand what I'm saying? So
yes,
there must be some other confounding factors which may lead on to your difference in results after 1 month of lycopene therapy?
Yes, ma'am, there are other factors also. As I said, two groups are taken, one test group and one control group we have taken. And we have differentiate both the groups on the basis of CRP and CPITN index. We have taken CRP as an inflammatory marker because we know that periodontitis is an inflammatory disease. So it levels will automatically got elevated whenever there is periodontitis. So in the patient, in the control group, we have already done scaling and root planing, and we have analyzed the symptoms. Like in the periodontitis, the bleeding will also there, the tooth mobility we have analyzed. And then in the test group, we have given, we have already done scaling and root planing, and along with that, we have advised systemic lycopene 20 milligram to the patient, and then we have analyzed the symptoms on the basis of CRP and CPITN levels, ma'am. And CPITN levels, we know that it is an epidemiological index, which is basically for the periodontitis, and which are basically for the symptoms of the periodontitis. So we analyze that also in the test group, ma'am.
Okay, thank you.
It was a short study,
I
ma'am.
understand. It
in-
was a good study.
It was
Good.
conducted in our college.
Good.
Thank you, ma'am.
Yeah. Can I have your presentation number, please? Because I don't see the presentation number.
0189, sir.
0189. Yeah.
Yes.
Ma'am, you did a good presentation. Few questions from my side. Can you tell me what lycopenemia means?
Lycopenemia.
Yes.
Sir,
because you are dealing with lycopene, so you should be knowing about lycopenemia.
So lycopene, I only study lycopene is an
Okay.
antioxidant.
Okay. So you should study about that also. Okay. The second thing is as madam was asking, Shivani madam was also asking about standardization, like whether you were using, I'm not very much happy with the answer you did to Dr. Shivani. I'm not 100% satisfied. Whether you were using some aids such as Proxa brushes or flosses or hexidine mouthwashes. So you need to be clear with that also, specifically in the test groups.
So we have given that. I didn't understand. We have advised patient for proper brushing and flossing also, and then we have first we have done scaling.
In the both groups.
Yes, sir, in both the control group and test group. The difference between control group and test group is that we have administered lycopene in the test group.
The dosage you said 20 milligram lycopene daily for every individual, be it a 40 kg individual or 80 kg individual. What is the dosage of lycopene? Can you tell me?
Sir, it is 20 milligrams. We have some inclusion.
For a 100 kg individual also, or for a 50 kg individual also?
Sir, it is for 70 kg individual.
So if my patient is say a thin female or a thin male who's like 45-50 kilograms, what would be the dosage?
So 40 to 50 mil.
Like you'll give 40 mg, 20 mg to them also, and for a obese patient weighing 100 kg, you'll give 20 mg to them also, huh?
No, sir. Dose will be calculated.
Dose has to be calculated, na, per kg
yes, sir,
body.
Dose
so probably that aspect I think was not done in your study.
Yes, sir.
Okay, madam. Thank you so much for your presentation.
I'll shortly include. Thank you, sir. Thank you.
Next in line presentation is by registration number 0267.
It's 267, na, madam? 267?
Yes, sir. 267.
Yeah, thank you.
Greetings to the honorable judges and the audience. The topic of my paper presentation is the impact and influence of smoking on RBCs, that is, the red blood cells. As we all know that smoking is one of the leading origin of lifestyle elite mortality and morbidity, such as cancers of oral cavity, lungs, as well as the cardiovascular diseases. In concordance with several health problems, smoking can also lead to oral ulcers and oral cancer in case of chronic smoking. Tobacco smoking may also lead to unhinged morphologies of the RBCs, which affects in reduced oxygen carrying capacity of the blood. Did you know that cigarette smoke contains around 5,000 chemicals, including the carbon monoxide and tars, which are considered toxic for human body? Tobacco smokers may have increased level of hemoglobin and hematocrit, and it may also show harmful effects in the WBCs of the smokers in both genders. Morphological changes in the CBC, that is the complete blood count, shows changes in the mean corpuscular volume because of the effects of carbon monoxide on erythrocytes. This occurs because of the carbon monoxide hypoxia, which produces a demand for more erythrocytes. Because of the cyanide-induced diversion of the vitamin B12, the demand cannot be met, which leads to the change in RBC morphology. So the present study aims to highlight the relationship between smoking and the morphological changes of RBCs. As RBCs are the oxygen-carrying cells and are essential for normal body working, especially under stress where more oxygen is required, any change in the morphologies of these RBCs can significantly compromise the body functions. The aims and objectives of this study is to explore and equate the changes in the morphology of RBCs among smokers and non-smokers, and to evaluate the morphometric characteristics of RBCs under light microscopy using image analyzing software. The material used were glass lights, pricking apparatus, fixing agents, Leishman's stain, and macroscope. Coming on to the methodology used, our study group was divided into two groups, Group 1 for the smokers and Group 2 for the non-smokers, and 20 subjects were taken in each category. Blood samples were collected from each one of them, and within informed consent and ethical approval to conduct the study was obtained from the Institutional Ethical Committee. Peripheral blood smears were prepared, fixed, and stained with the Leishman's stain. Coming on to the morphometric analysis, each slide was assessed by light microscopy. 5 suitable areas from the blood film in which there was no Rolex formation and the red cells that were touching but with a little overlap were selected, and images were captured under 400x magnification. 100 randomly selected cells from the 5 different fields, 20 cells from each field, in each blood smear was measured in a stepwise pattern in which the erythrocyte circumference was obtained by drawing the cell boundaries using the Magnus Prone image analyzing software, which is a software for doing the morphometric studies. These were the results obtained. This was the image in the non-smokers, and this was the image of RBCs in the smokers. I'll elaborate them in the next slide. So this was the data obtained for the non-smokers, and the mean area and standard deviation was 198.13 plus minus 5.753, and in the smokers this value was 201.57 plus minus 9.835. So we can clearly see that the value is more in smokers, which shows that the smokers have macrocytic RBCs. So in our study population, the smokers showed macrocytic RBCs, as I mentioned earlier, as compared to the non-smokers, and this reflects that smoking has an underlying linkage which affects the morphology of the RBCs. Coming on to the conclusion, our study results showed an increase in the percentage of macrocytic RBCs among the smokers in comparison to the non-smokers. Any change in the morphology of RBCs may lead to the reduced oxygen carrying capacity, and as I said in the beginning, this can significantly compromise the body functions, ultimately causing difficulties in the daily life activities. And despite the fact that smoking is injurious to health, the trend of smoking is higher throughout the globe. A large population starts smoking as a recreational activity, and it turns into an addiction. So the significance of this study is to spread awareness among the smokers and a small message that quit smoking before it forces the life to quit your body. Thank you for your attention.
A nice study. Just a few questions. My first question is, you didn't mention the age group which you considered for your study. Did you?
Ma'am, we took the subjects from different age groups. which were from second to third decade, and from mostly they were from fourth to fifth decade.
Okay. And you never also mentioned that for how long were they were having the habit of smoking, and secondly, how often and how vigorously, I mean, what is the intensity of their smoking?
And we recorded the information. The average was around 8 to 8.5 years, and they were chronic smokers. Mostly they were chronic smokers.
Okay, fine. Thank you.
No questions. Thank you. It was a nice presentation.
Thank you.
Next in line presentation is by registration number 405 and 0330.
Student of BTS third year is here to present a paper on the topic ozone therapy, a holistic approach in dental practice during COVID era. Many dental procedures produce droplets and aerosols that are contaminated with blood and microorganisms. This can spread easily throughout the dental operatory, which can contaminate the atmosphere and cause a great threat to the patient as well as to the dentist. In the progressing novel coronavirus, the main concern is the potential to spread infection from these aerosols. Hence, an alternative approach can be the use of ozone therapy to reduce the production of aerosol in dental practice. Ozone is an allotropic form of oxygen called as triatomic molecule, a higher energetic form of atmospheric oxygen, which is the third most potent oxidant. It protects us from radiations and has the capacity to stimulate blood circulation and immune response. How is ozone produced? The atmosphere is made up of various layers, and one of which is the stratosphere, which is rich in ozone. When a high energy ultraviolet radiation in the stratosphere hits an oxygen molecule, it splits into two oxygen free atoms. These free oxygen atoms collide with the other oxygen molecules, leading to the ozone production. Owing to the properties of analgesic, antimicrobial, antihypnotic actions being atraumatic, non-invasive, it has excelled its application in a wider range in almost every field in dentistry. There are three forms of ozone available in dental application, namely gaseous form, which could be administered topically either by an open system or by a sealing suction system to avoid inhalation and adverse effect. Second is ozonated water, which has been shown to be efficacious against gram-positive and gram-negative oral microorganisms as well as bacteria in plaque biofilm. Last being the ozonized oil, which is the competitive antimicrobial agent. Ozone generating system used in dentistry are helozone, which is an air-based system known to deliver higher ozone concentration, prozone, which is easier to use and safe to apply directly to destroy bacteria and viruses through oxidation. Ozotope is the compact and free-flow ozone delivering system, which utilizes corona discharge. Ozonitron, which is used on the principle of high frequency and voltage, can be applied to the areas that are inaccessible, such as gingival pockets. Areas where ozone treatment can replace aerosol. In conservative and endodontics, in the article by S. Tiwari et al., much reported effectiveness of ozone is seen in the elimination of carious lesions, including root caries. Ozonated water can be used as intracanal irrigant. In periodontics, in the study by Nayaoshi et al., dental plaque samples were treated with 4 ml of ozonated water for 10 seconds and observed the effectiveness against gram-positive and gram-negative microorganisms and oral Candida albicans. In oral surgery, ozone therapy has a vast range of application in oral surgery, from a simple extraction to osteotomy procedures. Ozone enhances wound healing by causing vasodilation and improving blood supply to ischemic zones. Ahmedi et al. Evaluated the effectiveness of ozone gas in the reduction of dry socket. In prosthodontics, Arita et al. Said that the Exposure of denture to flowing ozonated water for 1 minute can reduce a number of Candida albicans, which causes denture stomatitis. In periodontics, attaining a positive report with a child patient is the key of successful pediatric treatment, accompanied by using ozone therapy. Denharan et al. Treated open carious lesion with ozone in anxious children and observed the reduction of 93% of dental anxiety. In orthodontics, ozonized oil can reduce enamel demineralization around orthodontic bracket during orthodontic treatment. This was evaluated by Kobashi et al. In oral medicine, several soft tissue lesions like ulcer, herpetic lesions have been reported to be effectively treated using ozone therapy. In sterilization, ozone gas is a highly effective surface disinfectant for instruments, implants, and prostheses. Some contraindications of ozone therapy are recent myocardial infarction, pregnancy, hyperthyroidism, severe anemia, and active hemorrhage. As we know, everything has an advantage and disadvantage. The disadvantage of ozone therapy is ozone toxicity. A maximum concentration of ozone in oral cavity amounts to 0.01 parts per million during ozone therapy. Above this can lead to certain side effects like cough, nausea, headache, shortness of breath, etc. Hence, this toxicity can be intoxicated by vitamin E, ascorbic acid, and acetylcysteine. Thus, I would like to conclude by saying dental treatment has stepped into a new phase of treatment during COVID-19. Reducing aerosol by the use of ozone therapy can be widely delivered even in developing and even in poor countries. This will be beneficial to the pediatric practitioners, pediatrics, as well as patients. Thank you.
Okay, nice presentations. Sir, you may ask. I don't have any questions. Thank you.
Yeah, hi. I have one small question. In fact, in addition, presentation number is 267, right?
No, sir, it's 405.
It's 405. Okay. Yeah. I have a one. Can you tell me any other application of ozone therapy in oral surgery except for dry socket?
Sir, osteotomy procedures?
No, not osteotomy procedures. Osteotomy is cutting of bone. So we don't cut bone via ozone therapy, bache. I understand you introduced yourself as a third year BDS student, but you should know, since you are presenting a paper on this, and one of your judges is fortunately or unfortunately is an oral surgeon, so you should know it. See, there is a condition called as osteonecrosis of the jaws, and that can be due to many, biphosphonate related medicines. Many of the elderly patients are taking these biphosphonates for metabolic disorders. So in those patients also, ozone therapy, it has been reported to benefit a lot, okay, to prevent osteonecrosis of the jaw, secondary to biphosphonate therapy. So this is another indication of ozone therapy in oral surgery. Okay, bache? Chalo, thank you.
Yes. Thank you so much.
Next in line is 0477 and 0496. 0477, 0496.
We're fascinated with technology because it's a reflection of ourselves. A very good morning, everyone. Today I'm going to talk about the role of artificial intelligence in revolutionizing oral medicine and oral pathology. Talking of artificial intelligence, it is a branch of computer science that aims to understand and build intelligent entities, often instantiated as software programs, and a system capable of mimicking the functioning of the human brain. There are basically three components of artificial intelligence: machine learning, deep learning, and neural networks. Machine learning basically uses algorithms to identify patterns in data sets and predict such patterns in other data, whereas deep learning is nothing but an aspect of machine learning that mimics the human brain with its neural networks. Now, what is the role of AI in healthcare? AI in healthcare has been a huge talking point in the recent times, and it is one such breakthrough whose potential has been tapped into the world of dentistry. It can deliver improved quality and safety of care. It democratizes expertise through use of mobile devices, which can be deployed with algorithms and potentially be accessible universally, delivering vital diagnostic care. Basically, there are two key features of AI in healthcare: clinical decision support and information management, both by the physician and the patient. In clinical decision support, it helps the doctors make better decisions faster with pattern recognition of health complications that are registered far more accurately than by the human brain. And valuable time and money are saved, taking the strain off of the healthcare professionals and increasing comfort of the patients. Therefore, the future of healthcare and the future of machine learning and artificial intelligence are deeply interconnected. Now, talking about artificial intelligence in oral medicine and oral pathology, the need of artificial intelligence in oral medicine. Artificial intelligence can be used in diagnosis and treatment of lesions of the oral cavity and can be employed in screening and classifying suspicious altered mucosa undergoing pre-malignant and malignant changes. Genetic predisposition for oral cancer for large population can be detected by AI in the near future. Studies have suggested that artificial neural networks may act as an proven diagnostic tool for dentists. AI can learn from a large volume of healthcare data and train itself to be a competent and it practically reduces the observational error and at the same time reduces the observational fatigue. It also opens up doors of choices ranging from developing precision medicines and formulating new drug patterns to analyze medical records and assisting physicians with their cognitive learning capabilities. It can further approximate gaps to clarify the interrelationship of general disease pattern and their mutual influence on the oral health. Need of artificial intelligence in oral pathology. Artificial intelligence is the future of pathology that would help in assisting health professionals to cover a variety of human diseases in different organ systems and cope up with the enormous amount of data that digitally pathology creates. The doctors can make a precise clinical diagnosis with the help of machine learning, and the pathologist can spot subtle patterns and provide detailed information to the clinician about the disease. It also plays a handy role like the one augmenting the clinical decision capabilities of pathologists and helping them perform better and faster. Artificial intelligence has the potential to improve the efficacy of workflows and the quality of results. For pathologists, the effectiveness of cancer diagnosis is time-consuming, subjective, and inconsistent due to inter- and intra-observer variations. This further necessitates for the need of computer-aided image classification system with the quantitative analysis of histological features of the rapid, consistent, and quantitative cancer diagnosis. The use of artificial intelligence in pathology helps to analyze digital images and aids in diagnosing the disease, particularly in oncology. Now, there are various merits and demerits of artificial intelligence as well. The merits include identification of normal and abnormal structures, diagnosis of diseases, and prediction of treatment outcomes, improving diagnosis accuracy and revolutionizing care, reduces intra and inter-observer variability, and improve objectivity and reproducibility. Whereas the demerits include unemployment, security issues, artificial stupidity, and racist robots, as well as evil genies. Now, various challenges faced with AI include management and sharing of the clinical data, safety issues, transparency of AI algorithms and data, the price factor, ethical and legal challenges. I would thereby like to say that predicting the future isn't magic, it's artificial intelligence. I would thereby like to conclude by saying artificial intelligence has already had a profound impact on the world of medicine and is expected to continue to play a major role, particularly as the pressure on healthcare institutions to provide high quality, cost-effective care increases. By no means there exists a doubt in ascendancy of integrating AI into practice. It can never replace the role of a dentist, since clinical practice is not only about diagnosing, but also correlating with the clinical findings and providing personalized patient care. These are few references that helped me write this review paper. Thank you so much.
Nice presentation. You talked about that artificial intelligence is cost effective. How AI is cost effective?
Thank you for the question, ma'am. Ma'am, basically, setting up an artificial intelligence module requires a lot of, is actually not cost effective because it requires a lot of setup, a lot of team has required. But over a period of time, once the module and once the setup has been, effectively produced, then I think it gives, productive results as well. So I think overall, if we look at on it for a longer period of time, I think it is cost effective because it helps in streamlining better decisions faster.
Okay, nice. So everybody has their own favorites. So what do you have your oral medicine and radiology and oral pathology as your favorite subjects? That is why you just focused upon these two areas of AI and not the others?
Ma'am, basically, when we talk about oral pathology, it is oral medicine and oral pathology are the first two main branches where we basically diagnose a particular disease and then only further we act on it. Like the treatment is given based on the diagnosis. So I think it's very important to, first be able to diagnose, first be able to give a, accurate diagnosis to it. Then only we can act and give the treatment planning.
Okay, thank you so much and all the best.
Thank you, ma'am.
Thanks, dear, for the presentation. Though I would like to disagree with you here that there is only oral pathology and oral medicine. I'm sure Shivani madam was smiling, but she was humble and kind enough not to stop you there. So it's all the departments, all the 9 departments which you go through in your final BDS, which are important for. So it's not like that only 2 departments are only important for making a diagnosis. Okay. Yes. So it was a good presentation. Thank you so much. We can have the next paper. Yeah.
He's made us very happy though, Dr. Imran. Me and Dr. Vrinder are all smiling all the way.
Me too. Yes.
She actually probably knew that the moderators are from the oral medicine and oral pathology department. Maybe, madam. Maybe that.
Okay, next presentation is for registration number 492 and 467.
Good morning, everyone. My topic of the study is evaluation of biological behavior of odontogenic cysts through epithelial and stromal characterization, a special stain study. Coming to the introduction, odontogenic cysts are the most common form of cysts which occur in the oral maxillofacial region. Kramer defined a cyst as a pathological cavity having fluid, semi-fluid, or gaseous contents and which cannot be created by accumulation of pus. It is frequently, but not always, lined by epithelium. The cysts were classified traditionally into 2 groups, developmental and inflammatory. The developmental cysts included odontogenic keratocysts and dentigerous cysts, while inflammatory included radicular cysts. These are the 3 cysts that we are going to study in our special stain study. The components of the cyst, as we can clearly see, is wall, lumen, and epithelial lining. These are the various locations on these commonly occurring cysts are found. Etiologically based on origin, radicular cysts arise from rest of molasses. Odontogenic keratocysts arise from cell rest of seres and basal cell hamartias, while dentigerous cysts arise from reduced enamel epithelium. Here we can clearly see that the radicular cyst is the most commonly occurring cyst, followed by dentigerous cyst, and the least commonly occurring cyst was odontogenic keratocyst. Coming to the aims and objectives, our study was taken up to evaluate and compare the nature of epithelium and stroma in odontogenic cysts, and to elucidate the biological behavior of the cyst based on the nature of collagen using different stains. In methodology, we used 30 archival specimens from our oral pathology department, among which 10 cases were of odontogenic keratocyst, 10 cases were of dentigerous cyst, and while 10 cases were of radicular cyst. In these cyst specimens, we used different stains, such as our routine stain, which is hematoxylin and eosinophil, which helped us to identify the parts of the cyst. In special stains, we used Papanicolaou stain, which highlighted the epithelium and helped us to study the keratin metaplasia. While when we use toluidine blue stain, it helps us to identify the nature of mast cells, and picroceros red stain in conjunction with polarizing microscope helped us to identify the collagen fibers. Coming to the results, out of 30 cases, we had 12 which were of age group 18 to 35, while 18 cases were of the age group 35 to 50, among which 14 were males and 16 were females. Here we can clearly see in H&E stain, our routine stain, we can clearly identify the parts of the cyst, while in PAP stain, it highlighted the epithelial lining, which helps us to study the keratin metaplasia. In toluidine blue stain, we can see the small purple spots, which are the mast cells, while in picroceros red stain, under the polarizing microscope, we could see greenish yellow birefringence which marked immature collagen, and orangish red birefringence which marked mature collagen. Coming on to the discussion, the term keratin metaplasia was used for the presence of keratinized epithelial cells in the lining of radicular and dentigerous cells. Interestingly, when compared to the cases of mild inflammation, there was greater amount of keratinization in cases of moderate inflammation, while there is total absence in cases of severe inflammation. In our study, this helped us to explain that mild to moderate inflammation may be responsible for increase in epithelial thickness, which is mild hyperplasia, leading to active event of keratinization as a differentiation process. Our study also helped us to identify the mast cells and their nature, which showed that it released heparin proteoglycan on degranulation. Mast cells also liberated ECF, which is eosinophil chemoattractant factor, and histamine, which attract eosinophils in tissues. The mast cells were also found responsible for the cystic enlargement and inflammation, and this could have been possible due to the following reasons: by direct release of heparin into the luminal fluid, by release of hydrolytic enzymes which could degrade capsular extracellular matrix components, thereby facilitating their passage into the fluids, or by the action of histamine on smooth muscle contraction and vascular permeability. Then we used the picroceros red stain and anionic dye, which helped us to differentiate the different types of collagen fibers. The inflammatory cyst in our study, which is radicular cyst, exhibited predominantly greenish yellow birefringence. The predominant yellowish orange birefringence in the developmental cyst, which were dentigerous and odontogenic keratocysts, in comparison to the inflammatory cyst, suggested that developmental cysts exhibited well-organized and tightly packed collagen fibers, which are mature collagen. This could be the reason of the poorer prognosis of developmental cysts. Jumping on to the conclusion, the observation in our present study with respect to panel of special stains of various components of 3 commonly occurring odontogenic cysts possibly explain the biological behavior of the lesion. It is also suggested that though the epithelium plays an important role in the pathogenesis of these lesions, even stroma plays an equally important role in the pathogenesis and biological behavior. Thank you.
Okay, nice presentation, Doctor. I think, sir, Dr. Imran sir is a better person to ask questions on this topic.
Yeah,
yeah,
ma'am. Thank you, ma'am. Actually, I'm a little lucky that I don't have to look into these slides, because I always see the slides as rangoli for me. I always ask my colleague, Dr. Deepika, to do the difficult job for me. But I have one question. It's a macroscopic question, doctor. See, you spoke about the intraluminal fluid and the hydrostatic pressure. Can you tell me the protein content of the fluid which is present in the cyst? Suppose if it is an OKC.
Sir, if it is an OKC, we see we can see the material inside the lumen as it is similar to the transudate of the serum, or it can be cheesy white or clear. It could have a cheesy white or clear appearance, which is because of keratinous debris.
Yeah, it can be cheesy white, I agree, but there is a specific number for that. You know, it was given by a classic article by Toller, US, quoting many oral pathology slides. So it was given by a, like, less than this should be this, less than that number should be the diagnostic of this cyst. So can you tell me, can you answer me that? So if it is less than 4 grams, if it is less than 4 grams, then the cyst can be differentially diagnosed as a odontogenic keratocyst. Thank you.
Thank you, sir.
Thank you, sir.
Next presentation is by registration number 621.
Greetings to one and all present here. The topic of my presentation is diagnosing obstructive sleep apnea in 2022, the strategies ahead. So what is obstructive sleep apnea? As the name says, it is a sleep-related breathing disorder in which an individual encounters difficulty in breathing despite an ongoing effort to do so. And if this happens 15 times in a row, he or she is said to be under the high risk of OSA. A recent article published in Lancet estimated that worldwide 936 million adults are under the prowl of OSA, and our very own country ranks fourth in the list. Serious comorbidities include cardiovascular and metabolic disorders, behavioral and cognitive impairment, and it has a proven correlation with COVID-19 as well. To add to this, air pollution worsens the situation. Although OSA was identified first in 1965, it is very unfortunate to say that there is no cost-effective diagnostic modality present in the current times. Polysomnography amounts 10,000 to 20,000 per test and is highly technique sensitive and unavailable. Alternatives include screening questionnaires, which are calculation sensitive and time consuming. So what do we do? To bridge down this gap and to aid in the diagnosis of OSA, here is my innovation, a solution, a customized mobile application to aid in the diagnosis of OSA. OSA risk assessment tool accomplishes diagnosis of OSA in 3 steps. Primarily, quantitative analysis, the standard questionnaire, analysis of extraoral features of facial phenotyping, and analysis of cephalometric parameters. Currently, OSA risk assessment tool is in its evolution stage. We have conducted its development in 2 stages. First is the prototype development and second is validity and feasibility testing. Firstly, we began with the needs analysis where a pilot project was done to identify the gaps in diagnostic procedures, to study awareness and to identify its association with skeletal parameters. Second was interface designing, where patient interface and doctor's login was designed with exclusive features that recorded demographic information, anthropometric measurements, preliminary questionnaire to study the sleep characteristics, and last but not the least, age-specific automated questionnaire, the stop band and the PSQ. This was followed by usability inspection, validation, and testing on pilot sample of 200 patients, where patients used this mobile application, recorded the information, entered the information in stop bank and PSQ, and received results as per the information entered. This was followed by preventive and interceptive recommendation. Here is a snapshot of the first interface of the mobile application, which has some informational guidance tools such as this one. Here is one of the video which is used for educational purpose.
Hello everyone. Today we will learn about obstructive sleep apnea, disease which is linked to serious cognitive, cardiovascular and behavioral comorbidities. Do you also feel tired during work? Are you thinking about having a nap all the time? Drowsiness and loss of...
So after recording these symptoms and their analysis, we come to the second step, which is facial phenotyping. Facial phenotyping has been directly related with upper airway morphology due to the existing common embryological origin with its craniofacial components. That brings us to the conclusion that facial phenotyping is a composite study about the regional adiposity, skeletal dimensions, and enlarged upper airway soft tissue. So this gives us a very important opportunity to study the changes in the extraoral features that occur due to the obstructive sleep apnea. Various studies were done in relation to this, and certain landmarks were identified. Cutting down short, these 4 landmarks have been proven to be associated with obstructive sleep apnea: face width, cervicomental contour area, tragus ramus tomion angle, neck circumference, and mandibular width length angle. To inculcate this in our mobile application, we incorporated simple steps where a patient can simply take lateral and frontal photographs, upload them onto the mobile application, where Special analytical software will be incorporated in OSA risk assessment tool to accomplish the process of feature extraction, or I should simply say identification of landmarks which have been of our interest. This will be compared to the normal parameters to study the deviation, increase and decrease in the dimensions, and will lead to diagnostic results which will be based on cutoff limits found after validation. Some of the commercial softwares which are doing great in the market for this particular system are the image analysis software, automatic landmarking method, and the face-to gene, which has a sensitivity of 91%. After facial phenotyping, we come to the analysis of cephalometric parameters, whose importance was understood by us in the PIRATE study itself, where we found out that the ANB, mandibular plane angle, cranial base angle, and the parapharyngeal space is highly correlated with obstructive sleep apnea. PNS 81 had a sensitivity of 70%, and PNS 82 had a sensitivity of 73.3%. We thought that this is an opportunity where we should utilize these findings and materialize them in the most easy method that is possible. So what we could do is that the patient can get his lateral cephalogram done, click a picture of the lateral cephalogram and upload it on the OSA risk assessment tool, which again follows the same sequence where a special software incorporated in the tool will execute the task of automated tracing, which will further extract the landmarks of study, compare them to the normal values, and identify the deviation, and followed by diagnostic results based on cutoff limits found after validation. There are many tools to accomplish this process, example MCEPH, Ceph Ninja, and CephX. So these three particular steps, when ameliorated together, pave way towards easy diagnosis with early screening and non-invasive nature. These are as simple as possible and can be executed by the patient himself and herself. Talking about the competitive advantages, OSA risk assessment tool is highly user-friendly, cost-effective, provides 360-degree analysis of all aspects that can assess diagnostic features of OSA. It is automated, precise, accurate, and the most important, it features digital data storage, which will help in generation of data sets that can be further used for validation of several better technologies for aiding in the diagnosis of OSA. However, polysomnography is very cumbersome, time-consuming, conducts unidimensional analysis, and is largely unavailable. Talking about the scope of OSA risk assessment tool, since it is cost-effective, it can be implemented in low-income countries at a very, very simple and easy method. It is also a self-screening tool usable in pandemic times, and since it does not involve a heavy equipment or a setup, it can be easily installed in ortho clinics, PHCs, and most importantly, driving license authorities. As I have said, it is an independent risk factor for road traffic accident, increasing the risk by 2.5 times. Concluding my presentation with few snapshots of the articles that give me hope that all of this is possible, all of this is implementable, and all of this will help OSA risk assessment tool in lowering down the graph of undiagnosed obstructive sleep apnea. Thank you.
Before I ask any questions, can I please ask which year student are you?
Ma'am, I'm an intern. I'm about to join internship on 1st of February.
Okay, so I must compliment you on the topic you have chosen, because OSA is a very, very common thing nowadays, and it's very definitely, as you told, it's a very, very difficult thing to diagnose as well. And if you're coming up with such a kind of application, mobile application, you must at least share it with me, because I am in a lock when it comes to diagnosis of OSA, definitive diagnosis of OSA. Definitely, it's a very, very important tool, which if it comes up in the market, I think it will be of much help to the, all aspects of dentistry. Very good. And is it your own idea?
Yes, ma'am.
Is it your own idea? Very good.
Ma'am, I have mentors from a faculty.
Definitely.
So we collaborated, have guided me, and we have come up with this.
I must compliment your mentors too. And I think you should at least try, you should definitely try to materialize this.
Ma'am, we are currently in the first stage. We have materialized the automated questionnaire thing. We have done a study on it on 200 patients. results were very significant. We are about to execute the second and the third part. So we are currently in the process.
Good. Thank you. Thank you so much and all the best.
Thank you, ma'am. Yes, sir.
Yeah, it's a highly impressive presentation, as Madam told, complimented you. I'm also awfully impressed, and keep it up. The only one thing which I want to add is, apart from the facial phenotyping, in fact, 2 points I want to add here regarding your app development. One, it should be in the local language. Okay, that instruction should be. So what you showed in a 20-second video, that was in English. So it should be in Hindi or it should be in Urdu. Okay, where the patient can understand. Number two, the size of the tongue. The size of the tongue would also dictate the intensity of OSA. If the patient is having macroglossia or a hyperplastic maxilla. So facial phenotyping is okay, but you should also include these parameters once you are into your app. Huh? Thank you so much.
Yes, so thank you for the recommendation. We'll surely take up for this.
Next presentation is by registration number 715 and 630.
Hello everyone. Today I'm going to present a knowledge, attitude and practice study on bidirectional relationship between oral health and diabetes mellitus. So as we all know, diabetes mellitus is a chronic debilitating disease that affects millions of people across the globe. And talking about India, the prevalence and the incidence of diabetes in India is such that it has been labeled as the diabetes capital of the world. And because of this, it poses a huge financial burden in India. So if diabetes is left untreated, it can lead to certain systemic complications. Some of the known systemic complications are nephropathy, retinopathy, neuropathy, etc. Apart from the systemic complications, diabetes can also affect the oral cavity in a drastic manner. Some of the known oral manifestations of diabetes are chronic periodontitis, which is also the 6th most common complication of diabetes, gingivitis, burning mouth syndrome, etc. So there is very limited evidence about the knowledge of this bidirectional relationship that exists between oral health and diabetes. And therefore, this CAP study was planned to assess the knowledge, attitude, and practices of people relating to diabetes and its oral complications, so that primary control of diabetes can be done at the community level. So this was a cross-sectional study carried out in our own institute, and the sample size was taken to be 150. This calculation was reached using a standard formula used in a previous study. And the value of P, that is 0.078, was based on WHO data of prevalence of diabetes in India in 2016. And the results were predicted with a confidence level of 95% and with a margin of error of plus or minus 4.2%. Ethical approval and informed consent were obtained before the study, and the responses of people visiting the institute were collected personally by the investigators on their own mobile phones and tablets, following strict COVID-19 protocols and ensuring no physical contact. The responses were collected in a Google form. The questionnaire that was used was a validated one and adapted from a previous study conducted by Gupta et al. It was modified as per requirement, and due permission was obtained before using the questionnaire. So in this 4-part questionnaire, the first part dealt with demographics, the second part dealt with the questions regarding knowledge, the third part contained questions regarding attitude, and the fourth part contained questions regarding the practices. So according to the result, the majority of the participants were under the age group of 40 to 59. Most of them were males and most of them were graduate and above. So talking about knowledge, people were aware about the systemic complications of diabetes, and among that, delay in wound healing was the most recognized systemic complication of diabetes. The least recognized was a stroke or cerebrovascular attack. So talking about the oral manifestations of diabetes, a significant amount of people did not know that diabetes can also result in into some oral complications, and however, some of them did, and delayed healing of wounds here too was the most recognized complication of diabetes. The least recognized were recurrent infections in the oral cavity and inflammation and recession of gingiva. So when we assess the knowledge of people regarding the association between diabetes and oral health, most of them did not know the bidirectional relationship Only few of them said that controlling your blood glucose can help improve your oral health, but they did not understand that maintaining a good oral hygiene and oral health can also help control your blood glucose level, which we are demonstrating through the study. Regarding attitude, most people were aware that they should go for a regular dental checkup, and a few people, that is 30.7%, felt the need to visit only when the symptoms were found compelling. When asked about the reason for a visit, 52.7% of them said that they should go for a regular 6-month dental checkup, and 37.3% of them felt that they should go only for dental problems like pain, bleeding, etc. 82% believed that better oral hygiene practices should be followed by diabetics. So regarding practice, people, 27.3% of people had seen a dentist in a duration of around 6 months to 1 year or more than 1 year. And it was astonishing to observe that even in metropolitan cities like Delhi, few people had never visited a dentist before. The frequency of brushing was found to be once daily or twice daily. Frequency of changing toothbrush was 3 to 5 months. And it was found that a significant number of people didn't practice flossing and didn't have the knowledge about flossing or what interdental cleaning was. So when asked how to keep their blood sugar under control, the individuals identified dietary modifications and exercise and physical activity as primary measures to control diabetes. However, the role of medicine and oral hygiene measures was not completely understood, and very small group of people responded to this option. So talking about the dual adverse relationship in detail, diabetes mellitus can lead to formation of certain advanced glycation end products or AGEs, which affects the migration and phagocytic activity of the mononuclear and the polymorphonuclear leukocytes, and which in turn leads to a pathogenic flora, plaque accumulation, and subsequent connective tissue and alveolar bone degradation, which can lead to periodontal diseases. Periodontal diseases really can lead to release of certain cytokines, inflammatory products, toxins, and bacteremia, which can further increase insulin resistance and hyperglycemia, thus aggravating diabetes mellitus. So results have shown that people need to be aware to decrease the incidence and prevalence of diabetes, not only because it causes financial burden, that is around 10,000 rupees in urban areas per annum and rupees 6,260 per annum in rural areas, but also because of the systemic and oral complications of diabetes. So for the primary prevention at community level, the role of robust oral hygiene practices, diet modification, physical activity, and medication compliance need to be understood. ADA has also stressed for the relationship between oral health and diabetes, and it has said that for the standard of care of oral health in a diabetic patient, the primary measure should be to control your blood glucose level. So this is the review of the studies of that has been conducted in the same area before. In conclusion, this study demonstrates the lack in prevailing knowledge, attitude, and practices of people with and without diabetes. The data obtained from this study can be used for future studies and interventions to increase awareness among people for this bidirectional relationship and as a method to control diabetes and prevention of diabetes at a community level. So these were the references that were used for making the presentation. Thank you for listening. Have a great day.
Good presentation, doctor. And your questionnaire was covered almost all the relevant aspects of oral hygiene and diabetes at the same time. All the best. Thank you.
Thank you, ma'am.
Yeah, I have one question. See, if you go back to your presentation, you said that delayed wound healing was the most common response put by the patient who were with diabetes, right? But in the chart, if you see your data, kidney failure patients featured 64.7%, whereas delayed wound healing were 63.3% only. So how would you explain that?
Sir, actually, both the delayed wound healing and nephropathy was the most recognized systemic complication of diabetes. I may have missed out on the.
In fact, kidney failure was more by 1%, right?
Yes, sir.
So you emphasized on delayed wound healing,
yes,
actually. So that is why I picked up that point.
Yes,
okay.
Thank you so
much. Did anybody in the group knew about halitosis, diabetes and halitosis, or sulfur breath? I would like to know for my knowledge sake.
So we actually did not find many studies on halitosis, so we did not include that part in our questionnaire. We include only the most common recognized complication.
My perception about diabetes and oral health,
Yes.
halitosis or a sulfur breath is one of the most commonest features of the patient with high diabetes, specifically in
yes,
increased blood sugar levels.
Ketoacidosis also.
Yeah, exactly. Thank you.
Yes. Thank you, sir.
Our next presentation is by registration number 717 and 716.
Good evening. The title of my presentation is Age Estimation Based on Third Molar in Establishment of Juvenile Status. Age estimation is an important factor in biological identification and forensic field, be it forensic odontology, forensic medicine, or forensic anthropology. There are varied ways of age estimation methods, out of which the dental estimation methods stand out owing to its advantages over others, which are third molar tooth development continues until the early 20s, whereas the development of hand bones gets completed at about 18 years of age. Skeletal indicators can be influenced by many factors such as nutritional and environmental, which is not in the case of tooth development. It is of utmost importance in differentiating the juveniles from the adults. It is done to assess whether the child has attained the age of criminal liability and its subsequent penalty. It's for availing social benefits, employment in government sectors, and for ascertaining the marriageable age. Objective is to establish the juvenile and adult status, which is less than 18 or more than 18 years, in the North Indian population using Belgian's regression formula. This study was approved by the Institutional Ethical Clearance Committee. It's a retrospective analysis for which OPG of 60 individuals, out of which 30 were males and 30 females. Age range between 14 to 23 years. The OPGs were coded with a unique number so that the person who was investigating the sample was free from any bias. The study was carried out in two folds. Firstly, third molars were graded following the method of Kohler et al., referring to the chart reproduced in Gunst et al., and the description of the 10 developmental stages in Mesotn et al. And then the statistical work was carried out, in which the regression formula published by Gunst et al. Were applied to determine the estimated age of an individual. To gauge the accuracy of the formula, the difference, that is the error between the actual and estimated age, was tabulated in Google spreadsheet. Mean, standard deviation, and accuracy for both males and females were calculated. These are the Belgian formula. The acronyms here are upper right, upper left, lower right. For every combinations, there are two set of formula, both for males and females. The inclusion criteria are optimal image quality of the OPG with the presence of at least 3 third molars. Exclusion criteria are absence of third molars and any pathology like cyst, fracture, tumor, periapical lesions. This is the chart that we referred while grading of third molars. The first 3 stages are for crown formation, where in third stage, we can see the crown is completely calcified. This is the 4th stage with the root initiation stage, root formation stage. This is the 5th stage where 1/4 of the root is completed alongside the calcification of the furcation area. The 5th stage is where the half of the root is completed. This is the 6th stage where half of the root is completed. This is the 7th stage where 3/4 of the root is completed. Now 8th, 9th, 10th. These are the tricky ones. At the terminal end, we can see the divergence of the root apices. At the 8th stage, we can see the nearly completed root formation and the root canals are terminally divergent. In the 9th stage, the root canals are, the apex are closed and the root canals are terminally parallel. You can see the parallel terminally root canals. And the 10th stage, the root canals are terminally convergent. In the first OPG, in the lower right region, we can see the initiation of the crown formation. So stage 1 is ascribed to it. In the lower left region, stage 3. In the second OPG, both lower right and lower left are in stage 6. In third OPG, in lower left region, we can see the root completion is done, and it is in stage 10. This is the format in which we collected our data. Two formula A and B are applied, and we got two results of estimated age. These are the differences, that is the difference between actual age and the estimated age, for which we calculated mean absolute error, which is the mean of these differences, and the standard deviation, both by applying A and B formula. Similarly, the data were calculated in males. Outcomes, standard deviation in females came out to be 1.16 with the accuracy of 86.44. And standard deviation of males came out to be 1.85 with an accuracy of 82.6%. Conclusion we can draw is that the Belgian formula are applicable in establishment of juvenile status in North Indian population. The sample size, however, is very small, but we are currently pursuing the study with a larger sample size for better results. The challenges that we faced are tilacerated roots, buccal-verted tooth, which impeded the visibility of roots, and the superimposition of adjacent anatomical structures, especially in maxilla, which was more challenging. These are the references. Thank you.
Good study. Can you please tell, I probably missed it, what was the age group of your study population?
Ma'am, it was 14 to 23 groups.
14 to 23 years.
Age group, yes.
Okay. Fine. Sir, you please ask a question pertaining to this topic. Thank you.
Good morning, sir. Yeah, good morning. It was a good presentation. I don't have any questions as such. In the end, did you compare that age, what you got, deriving from the Belgian formula, and to what the actual age was? Did you actually compare it and check for the accuracy?
Yes, sir. The accuracy for individually for males and females, that came out to be nearly 84%.
84%.
Yes,
and what was the profile of the researchers? Like, you were doing it, or some students were doing it, some senior professors were doing it, the calculation?
No, sir, we are doing it.
The radiographic estimation that the canals are, convergent, the canals
Yes,
are.
sir.
We
are under professors of our faculty.
So, okay, so the faculty people were doing it.
Yes.
Okay, thank you.
Thank you, sir.
Next in line presentation is by 0718.
What a nightmare. Bodies blackened, heads carbonized, shrunk, and reduced to nothing, but only the teeth remained. Physical evidence cannot be intimidated. It does not forget. It sits there and waits to be detected, preserved, evaluated, and explained. Where traditional ways of visual recognition or fingerprint analysis fail, forensic odontology comes to the rescue in establishing the identity of an individual. The concept behind it is, no two mouths are alike. In modern society, the crime graph is high, and mass casualties and large-scale disasters have caused a loss of human resources. Hence, the establishment of a person's individuality becomes important, and gender determination is a crucial step in the identification of an individual. This led me to choose the topic, determination of sex from human dental pulp and its reliability as a tool in forensic dentistry, a fluorescent microscopic study. This study uses tooth pulp tissue from extracted human teeth as a substratum for sex determination. The primary reason being its sequestered location. The second reason for the selection of the tooth pulp is its easy availability. Moreover, it is the preferred location for DNA extraction because of its greater quantity of DNA compared with that of other dental structure. The present study is intended to expand current knowledge on the use of human dental pulp tissue as a significant tool of sex determination in forensic odontology. The primary objective of this study is to evaluate the presence of bar body in the histologically processed human dental pulp tissue taken from the freshly extracted teeth using stains like hematoxylin and eosin and acridine orange. The second reason is to understand the reliability of tooth pulp in determining the sex of an individual. And lastly, it can help in identification of an individual in forensic investigation. 48 patients, 24 males and 24 females were chosen. 3 groups were made on the basis of age, 15 to 30 years, 31 to 45 years, and 46 to 60 years. And the remaining armamentarium has been displayed. Only teeth extracted due to periodontal diseases, orthodontic purposes, and prophylactically extracted impacted third molars were included. Carious teeth involving the pulp were excluded. In order to extirpate the pulp tissue, the tooth was longitudinally sectioned and was then split. The pulp tissue was separated out of the pulp cavity with the help of needle and forceps. Serial sections with a thickness of 5 microns were taken and 2 different slides were prepared. One slide was stained with H&E and the other was stained with freshly prepared acridine orange dye. In the tissue stained with acridine orange stain, the cells with a bright fluorescent spot lying against the nuclear membrane were counted as bar body positive cells. In the tissue stained with H&E cells, the cells with a purple spot lying against the nuclear membrane were counted as bar body positive cells, but these weren't very clearly appreciated. When the comparison of the number of bar bodies among different age groups and different stain was done for females, it was seen that bar bodies were visible better in acridine orange stain than in H&E stain. And between the groups, Group 1, that is 15 to 30 years, showed a statistically highly significant difference. When the comparison of number of bar bodies among different age groups and different stains was done for males, it was seen that bar bodies were visible better in acridine orange stain than in H&E stain. And between the groups, Group 1 showed a statistically significant difference. The fluorescent stain acridine orange has the advantage of being highly specific and accurate, as reported by Khanna et al. They compared stains like hematoxylin and eosin, fluorine, and acridine orange stain for observing bar bodies. The results showed that acridine orange proved to be a better stain than H&E in terms of inter-observer agreement. Reddy et al. In 2012 examined mucosal samples stained with acridine orange using confocal microscopy for the detection of bar body positive cells. The authors found out that female samples showed 18 to 72% cells showing bar body positive cells, whereas male samples showed just 1 to 3%. Sahu et al. In their study of determination of age and development of bar body in root sheath cells of human females showed that variation in hair root sheath cells was seen increasing with age up to 30 years, and with increase in age above 30 years, the percentage of bar bodies started to decline. The present study showed a similar correlation to the above-mentioned studies. Conclusion: the present study re-established the significance of dental pulp as an important tool of sex identification. The results showed that bar bodies are predominantly found in females and their occurrence decreases as the age increases. Thus, a conclusion was made that the observation of bar body using fluorescent stains such as acridine orange could be a reliable, cost-effective, and a simple technique for sex determination from dental pulp of the teeth. These are my references. Thank you.
Sorry, it was a good study. And in your inclusion-exclusion criteria, you excluded those teeth which were cariously involved, right?
Yes, I excluded cariously involved teeth because the caries can affect the pulp, and because of that we could get false positive results. That's the reason I excluded carious tooth.
But would the caries be affecting the bar bodies?
Yes, it can affect the pulp. If the caries has progressed and it's affecting the pulp, then the bar bodies can be affected, or we may get false positive results which are there.
Okay, and what was the age group?
I had
Predominant.
chosen
Yeah.
3 age groups, that is 15 to
You had chosen?
Sorry?
Hello?
Yeah, I had chosen 3 age groups.
Hmm.
15 to 30 years, 31 to 45 years, and 46 to 60. The reason for that was that I wanted to compare that how the bar bodies are seen in the different age groups. And it was seen that when the age increases, the bar bodies are not very clearly visible.
Okay, good. All the best. Thank you.
Thank you, ma'am. Sir, I cannot, you're not audible.
Please unmute yourself.
Yeah. Sorry. So, are you really sure that presence of caries would affect the DNA of the pulp, so that the bar bodies are not detectable? Because I'm not sure about it. I don't know actually. Or do you have any scientific evidence? Have you gone through some evidence regarding this?
Well, some studies were showing that caries can affect the pulp, and it may give the results which are not.
See, affecting the pulp is something different, and affecting the DNA of the pulp is something different.
So, I mean that it can affect that the bar bodies won't be very clearly visible. There were some studies which showed that.
Which showed that. Okay.
Yes.
Thank you. Good luck.
Thank you, sir.
Our next in line presentation is by registration number 732.
Good morning, everyone. My topic is immunohistochemical expression of OCT4 in oral submucous fibrosis. What is oral submucous fibrosis? It is a potentially malignant disease predominantly seen in people of Asian descent. It is a chronic progressive disorder, and its clinical presentation depends on the stage of disease and detection. Majority of the patients are present with an intolerance to spicy food, rigidity of the lip, tongue, and palate, with leading to varying degrees of limitations of mouth and tongue movement. Oral cavity, pharynx, and upper third of the esophagus are the normally affected areas. OCT4, that is, octamer binding transcriptase factor 4, also known as POU5F1. It is critically involved in the self-renewal of undifferentiated embryonic stem cells. It is frequently used as a marker for undifferentiated cells. It can even show an uptake on various stages of OSMF, which are very early, moderately advanced, and advanced. My aim is to evaluate the immunohistochemical expression of OCT4 in oral submucous fibrosis. It is a double-blinded study based upon the evaluation of distribution of OCT4 positive cells in oral submucous fibrosis. Total 40 specimens were subjected to immunohistochemistry using OCT4, out of which 30 specimens were of oral submucous fibrosis, while 10 specimens were of normal buccal mucosa as a control group. Inclusion criteria: histopathologically diagnosed cases of oral submucous fibrosis. Exclusion criteria: oral lichen planus, other oral submucous lesion like tobacco pouch keratosis, patients suffering from acquired immunodeficiency syndrome, frictional keratosis, patients suffering from leukemia or other hematological or systemic disorder. The results obtained from this study show a significant relationship between OCT4 and OSMF with respect to histopathological grading. The OCT4 uptake in the above cases were decided upon the varying degrees of OSMF through histopathological grading as given by Pindberg and Hansen in 1963. These slides they show an uptake in epithelium due to OCT4 in OSMF. Lazarevich et al. Showed that the surgical margins of oral cancer express stem cell markers such as OCT4, which have the ability to form spheroids to become resistant to chemotherapy. The crucial role of OCT4 in potentiating stem cell behavior in OSMF has been discussed in beta-1 integrin, P63, CMYC, BMI1, keratin 5/14, keratin 19. OCT4 expression is inversely related to MIR145 expression in the tissues of individuals with Erica-Quit-induced OSCC. I would like to conclude my topic by saying that OCT4 helps us in diagnosis and prediction of transformation from pre-malignant to malignant lesion of oral submucous fibrosis. It is a very good marker and has the potential of detecting oral submucous fibrosis. These are my references. Thank you.
Nice presentation. Just one thing, whenever you are going in for a presentation, like the way you presented your results, you must specify what is your y-axis and what is your x-axis. That is more easy to understand. Okay, thank you so much.
No questions for you. Thank you.
So our next presentation is by question number 697.
Diabetes mellitus is a group of common metabolic disorders that share the same phenotype for hyperglycemia. According to the International Diabetes Federation, India reported up to 68.1 million cases in 2013, which is more than double of the 2000 statistics. By 2030, it is likely to afflict up to 80 million cases in India. Magnesium, being the fourth most abundant cation and an established central electrolyte in the human body, is instrumental in many fundamental biological processes. It is claimed that there is an inverse relationship between magnesium intake and glycemic control. Hypomagnesemia is associated with poor control of type 2 diabetes mellitus, and its deficiency occurs exponentially along the course of the disease. It is now entrenched that diabetes can procure hypomagnesemia, which in turn worsens diabetes mellitus. In order to understand this better, I conducted a study titled Correlation Between Serum Magnesium Level and Type 2 Diabetes Mellitus, an institutional study. The objective of the study was aimed at estimating serum magnesium concentration and glycated hemoglobin levels in patients with type 2 diabetes mellitus. Methodology of the study. Materials. The study consisted of 50 consenting patients who came for routine blood investigation. The patients having high random blood sugar were selected and divided into two groups based on their age. That is from 25 to 50 and 51 to 75. Inclusion criteria. Type 2 diabetes mellitus patients of either sex with age more than 18 years were included. Exclusion criteria. Critically ill patients, patients with age less than 18 years of age, patients on drugs known to affect magnesium levels, and patients taking supplement containing magnesium were excluded. Method. After an overnight fasting, 5 ml of peripheral venous blood of the consenting patient was collected from the ancubital fossa using an 18-gauge needle. 2.5 ml of the sample was placed in a lithium heparin tube, and the serum was obtained by low-speed centrifugation and stored at 2 to 8 degrees Celsius. Magnesium was measured by using Cobas 600 calorie meter endpoint method. The other 2.5 ml was transferred into an EDTA tube, which was then used to estimate the HbA1c level. This was measured by the ELISA test. Coming to the results, demographic characteristics of the study participants, 52% of them represented as female and 48% of them as male. The mean age was 52.24. Coming to the comparison of HbA1c levels in terms of different age group using unpaired t-test. For the first age group, it was 7.6, and for the second age group, it was 8.3. People with diabetes with poor glucose control usually have HbA1c levels above 7%. Comparison of serum magnesium levels among different age group using unpaired t-test. It was 1.4 mg per dl in the first age group and 1.3 mg per dl in the second age group. The average serum magnesium levels lies between 1.7 to 2.2 mg per dl. Coming to the correlation between HbA1c level and serum magnesium level using the Pearson's correlation coefficient showed a negative correlation. Discussion. Hypomagnesemia associated with raised HbA1c level were present in 80% of the participants in the current study. Similar results were obtained in 75.5% of the participants with type 2 diabetes mellitus in a study conducted by NH Rekha et al. These results were also consistent with other studies done by Sheikh and Victorinova et al. Now, this could be due to poor dietary consumption, poor intestinal absorption, autonomic dysfunction, high in urine magnesium loss coupled with glucose, or reduced magnesium intake by cells in contrast to non-diabetic healthy individuals. As per the finding of this study, an inverse correlation was found between serum magnesium level and HbA1c level. Studies conducted by Siddiqui et al. And El Asali et al. Also demonstrated a negative correlation between the same. Hypomagnesemia disrupts glycemic control through altering cellular glucose transfer, lowering pancreatic insulin release, disrupting post-receptor signaling, and changing the insulin to insulin receptor contact. Although a large number of potential cohort research and meta-analysis have indicated that magnesium consumption lowers the incidence of diabetes, the findings are still mixed and additional research is needed to confirm the same. Prevalence of hypomagnesemia associated with gender was not found in the present study. This is in contrast to a study conducted by Gaffour et al., in which prevalence of hypomagnesemia was reported more in males than in females. Conclusion: type 2 diabetes mellitus is a chronic condition which is caused by complicated genetic environmental interplay, as well as additional risk factors like obesity and an inactive lifestyle. Despite the use of cutting-edge diabetes management techniques, morbidity and mortality ratios still remain high. Patients must be monitored using a multidimensional technique that includes full investigation and plan of care. To avoid and eliminate the consequences of type 2 diabetes mellitus, dietary recommendation for increased intake of magnesium-rich food should be made at the time of diagnosis. According to the findings of our study, serum magnesium should be integrated as a routine electrolyte test for improved diabetes mellitus treatment and to avoid complications such as diabetic retinopathy. Despite the fact that this is a multifactorial disease, the findings suggest that improved magnesium consumption along with changes with other diabetes risk factors could be a novel way to avoid this condition. Early detection with oral magnesium supplementation and therapeutic approach can avoid this. Nonetheless, the prospective effect of magnesium therapy in avoiding the emergence of diabetic complication deserves further research. Thank you. These are my references.
Nice presentation. Just one question. Which year student are you?
Ma'am, I'm in third year.
You're in third year of PDS. Okay,
Yes.
so what made you undertake this study?
Actually, I came across one of these studies while I was researching, and it caught my interest. And I thought this should get even more recognition because this could help us. This could be one step forward towards battling diabetes, especially in a country like India.
Okay, that is okay. But what is the clinical implication of this study as far as dentistry is concerned?
Usually we do deal with patients who have diabetes. I think we can, come up with magnesium supplements, recommend them to take magnesium supplements and include magnesium test as a routine part as well.
Okay, thank you.
Yeah.
Yeah, it was a good presentation. It's a good
Thank
take-home
you.
message. It's a good take-home message for all of us here, I believe. Are you aware of few highly rich magnesium supplements from the regular diet, dear student?
Apart from the diet?
No, from the regular diet. Apart from the regular
We have green vegetables such as spinach, dry fruits, bananas or avocados.
Yeah. So why do you want to give your patient magnesium supplements? Just ask them to have good leafy vegetables and and grains, multigrains, and that should be it. Okay.
That should be it. But if they are on certain drugs which are known to affect their magnesium levels, such as diuretics or warfarins, I think magnesium supplement can help them in that case.
Yeah. Agreed.
Yeah.
Agreed.
Yes.
Thank you. All
Thank
the
you.
best.
Thank you.
Now we proceed to our next presentation, which is for registration number 0495.
As it is rightly said, health is a state of physical, mental, and social well-being, not merely the absence of disease and infirmity, which runs parallel to the oral health, sharing equal importances. One of the focuses of WHO-led oral health programs in the target countries includes the development of methods and tools to analyze the process and outcomes of oral health promotion interventions as part of national oral health programs. India, with 18% of the world's population, still lacks the basic knowledge of primary oral health care. Not even 20% of rural primary health centers in the countries have general dentists. This demands a mandate of imparting oral health knowledge to all the public services providers especially the educators. The primary purpose of the survey is to identify the knowledge gaps about oral health and helping in determining the need for awareness of educational programs. Our survey was done by two of the senior co-authors among various universities during conferences, meetings, and visits. A total of 206 questionnaires were distributed. As you can see, the participant distribution from different states were majorly from northern India. Our questionnaire was close-ended and included 20 questions designed to assess the knowledge with 9 questions, their attitude towards the importance of oral health with 5 questions, and their daily practices with 6 questions. With a dropout rate of 6.7%, 192 university teachers replied positively. The data was segregated based on the demographics, and 3 major study groups were formed based on the number of experience years. Group 1 with 0 to 5 years of experience, Group 2 with 5 to 10 years of experience, and Group 3 with 10 to 15 years of teaching experience. The data was compiled, descriptive statistic analysis were obtained, the frequency distribution within the groups and comparison between the groups was done using Pearson's chi-square test. For the questions relating to the knowledge of oral health issues, all the 3 groups were well aware of oral health measures with no statistical difference between the groups for most of the questions. But the knowledge about general dental procedures was better compared to studies done by Tangre, P.S. and others in 2011 and Shekhar and others in 2014 among primary school teachers in India. This can be accounted to the increasing awareness through social media and interactions. Regarding their attitude towards oral health needs, slightly more than 50% have had some sort of dental disease and 72% have been to a dentist. Primary reason was dental pain, but the differences were not consistent. The younger population of teachers had slightly better oral hygiene practices than their senior counterparts. The use of mouthwash and floss was more in Group 3 teachers, which may be age-related care for oral hygiene. There may be an associated recall bias, overestimating the positive practices and underestimating negative ones, as this was a questionnaire-based survey and no live examination was done. This study is just a pilot survey done on small population, but the first of its kind, focusing on teachers at a university level. The overall goal of this pilot survey is to provide veritable information for the implementation, monitoring, and evaluation of the existing national oral health policy with more emphasis at the university levels. Concluding the topic, the level of knowledge and awareness among university teachers towards their oral health did increase with experience and age. However, the younger teachers were better skilled in oral hygiene practices than their senior compeers. Teachers are considered role models to transmit their values of life. Therefore, it is vital that their oral health knowledge, behavior, and practices comply with the expectations of the oral health practitioners to reduce the oral health burden of the society. A little knowledge can go a long way.
Okay, good presentation. There's a lot of data which you collected. That is from 206 teachers, I suppose. Am I right?
Yes, ma'am. Ma'am, with a dropout of 6%, 192 forms were returned.
Okay. Okay. So how did you go about collection of the data?
Ma'am, my senior co-authors, Dr. Haneet and Dr. Amina, ma'am, collected the data from meetings and conferences attended among different cities in the country. So, ma'am, maybe about in 2 years almost, 2016 to 2018.
That's good. And how did you validate it? Did you validate the questionnaire?
Yes, ma'am. My senior co-authors did.
Do you know anything about validation?
Yes, ma'am.
It's okay. It's okay. Thank you. All the best.
Thank you.
Yeah, thank you for the interesting presentation. All the best.
Thank you, sir.
Our next presentation is for registration number 0443.
everyone. Today, I'm going to present my paper on the topic Twitter microblogging, a viable tool for holistic dental care. So what actually is microblogging? It is basically posting short status update about 280 characters long, in which we can also post images and hyperlinks to other sites. Basically, to know where one is or what actually is doing. What is hashtagging? The latest trend. Hashtagging is basically putting a hash symbol before whatever you're posting. It basically links whatever you're posting to all other similar tweets and gives context and a better reach. So we can easily follow our topics of interest. So what is the application of tweeting in healthcare? Currently, it is used in terms of general health in fields of oncology, surgery, psychiatry, breast cancer prevention. It can also be used in terms of oral healthcare context, in terms of patient care, advancement of conferences and research. Now I'm going to show a small video on how to do tweeting. We click on the feather icon and we go to the What's Happening section. Then we can add images and hyperlinks to the icons below and post whatever we want to post. My aim was to analyze the role of Twitter microblogging in oral healthcare, research, and academics. My methodology included collecting and compiling all the current evidence regarding the use of Twitter in the context of oral and general healthcare. Results. It has a pivotal role to play in oral healthcare conferences in terms of rapid science dissemination and encouraging global participation by the concept of tweeting the meeting and giving real-time updates of the conference. According to a questionnaire survey study conducted in a US dental school, which checked the perception of students towards Twitter use in teaching and learning in an oral radiology course, it was found that students found improved instructor accessibility and an enhanced learning environment with Twitter. It has also a role to play in research and academics and advancement of academic footprint by project collaboration, finding all the trending and the latest topics, and in terms of data collection, in terms of survey polls, and sharing resources in terms of URL or DOIs. Early error detection in scientific papers, and also the added advantage of good networking between researchers and students. Students can follow their mentors working in the same field. According to a systematic review conducted by Erskine et al., 4 key strategies were used by medical journals. These included tweeting the title and the link of the article, infographics, podcasts, and hosting monthly internet-based journal clubs. And each strategy was found to be successful in promoting their publications. Now, due to lack of standardization and the limited reliability of the tweets, a concept called evidence-based tweeting or EBT was introduced, in which links to evidence and referencing of peer-reviewed publications was done through Twitter. This was accomplished by including URL links to PubMed articles in tweets. It has also a role to play in patient care and public health surveillance of dental pain. According to a cross-sectional study conducted by Havlin et al., in which tweets regarding dental pain were analyzed, it was found that people sought help from Twitter in managing the pain of toothache. The low-income group preferred self-management strategies before going to a dentist. It thus served as a means of communication in which evidence-based websites for toothache were given, and they could determine the need for professional treatment or evaluation. Now, it has also a role to play in holistic dental care, which basically treats oral problems taking into account all aspects of health, systemic, emotional, and spiritual. Thus, awareness about the etiology and the pathogenesis of the disease can be increased through evidence-based studies. Example, many people are not aware of the bidirectional relationship between diabetes and periodontitis or its link with nutritional deficiencies. Thus, we can treat the problem at the root cause at an early stage. Another example can be in case of bruxism. Apart from traditional treatment advice of night guards, we can do stress management education through social media. It has also a pivotal role to play in the current pandemic era, where it was used in circulation of crucial information regarding oral health care, national and international guidelines, vaccination and diagnostics, in forms of tweets and retweets among the patients and the oral healthcare workers. According to a recent study conducted by Tao et al. On nature and diffusion of COVID-19 oral health-related information on Chinese social media, it was found that there was better facilitation among government organizations and dental professionals, and they could also address public concern through the social media at a time when routine dental services were unavailable. Summarizing, it was found, according to a study by Bogman et al., that the greatest perceived benefits of Twitter was in networking and disseminating of information, followed by research and career development. Now, like a coin has two sides, we cannot ignore the disadvantages associated with it, like lack of standardization, reliability, and authenticity, limited content uploading without peer review, or its misuse for promoting dental products for their own profit. It's targeting only limited part of population, mostly the educated and the urban class, missing out on the rural and the underprivileged part of population. But we cannot also ignore its advantages like real-time data provision, no recall bias or observer expectancy effect, thus increasing the accuracy. Its global community, users from across the world, good networking and easy access on smartphones and tablets. It's increasing awareness in general public, thus subsequently decreasing the oral disease burden and studying patient perceptions in terms of positive or negative reviews for treatment. The power of social media is that it forces necessary change, and social media, especially Twitter, could prove to be a powerful tool in dissemination of health-related information if its full potential is tapped. I would like to thank Dr. Priyanka Kapoor ma'am and Dr. Aman Chaudhary sir for their constant support and guidance throughout their conference. These were the references I used for my study. Thank you.
Very nice study. Very, very nice study, because I am not very tech savvy as far as Twitter is concerned. I don't really know how to use Twitter personally. But just one question. You mentioned about the use of Twitter in sufficing to the need, catering to the needs of the underprivileged, that is the low socioeconomic group, handling their day-to-day problems, the preliminary problems before they reach the dentist. But in the last slide, you did mention that it is from out of reach of the underprivileged and the lower income group population. So don't you think the two things are almost contradictory to each other?
Yes, ma'am. But actually, most of us in this era possess a smartphone, and there is easy access to Twitter or other apps like these. And we have a habit of first going to Google or maybe referring to something on the internet when we have a problem. So our first option is that, and before even going to a doctor. So I think it can help people.
Okay, nice thought. Nice thought, because till date, I was only aware that Facebook can spread out information. I am not very aware how Twitter is used. I think sir can ask a few questions regarding the same. Thank you.
Yeah.
Good presentation.
Yeah, ma'am. Luckily, I've been using Twitter the last 2-3 years, and I know how useful it is. I myself disseminate many of my articles and researches on, and we can be in contact with other people at real time. So my question to you is, dear student, that are you also aware of Twitter Spaces?
Twitter Spaces.
Yes. So it's a new thing. It's a new thing that it's like a Zoom platform, or it's like a YouTube platform where you can actually chat live with more than 100, 200, 300 researchers, academicians, or doctors at a time. So maybe you could, in your future perspectives, you can add that as well. Okay, Twitter Spaces. Okay.
Yes.
Thank you. It was an excellent presentation.
Thank you, sir.
So now we proceed to our last presentation, which is for registration number 0503.
And my dear colleagues, hope you all are doing well in these tough times. Today I, 00503, presenting a really nice and interesting topic, that is dental pulse stem cells, regenerative dentistry. What are dental pulse stem cells? These are heterogeneous population of stem cell isolated from human dental pulp. DLK1 isolated from dental pulse stem cells of rodent. In China, what they did with rodent, they created a whole new tooth by stimulating this gene. Now let's come to some amazing features of dental pulse stem cells. Mesenchymal, pluripotent. They have tendency to form multiple cells. They are regenerative. As I told you, gene DLK1 from dental pulse stem higher proliferation rate from any other stem cell. Now let's come to 5 potential types of dental pulse stem cells from where we can isolate them. Human adult dental pulse stem cells of apical papilla, that is right below apex apical papilla, and periodontal ligament stem cells from which we can develop the whole periodontium. Stem cells from human exfoliated deciduous teeth, dental follicle precursor cell, which will provide it a precursor to generate further. I focused more on clinical significance and clinical trial. Let's jump on that. Tooth and tooth regeneration, as I here showed you, transplantation of bioengineered tooth germ, repair of craniofacial bone. Can you imagine your pulp can literally develop your whole craniofacial structure? TMJ reconstruction, mandible reconstruction. This is the hot point. Forensic dental profiling. What they did, they found a skeleton with a living pulp, and from that pulp they recovered the DNA, and after that DNA they got the whole profiling of that person. There are some successful clinical trials. We will discuss it one by one. Cleft palate. We know what is cleft palate, condition when child is born without fully developed palate. There are some health issues regarding to it. What was the conventional method? We used to bone graft, and then we used to add placebo to generate that bone within the structure. But now, through dental pulse stem cells, what we did, we recovered dental pulse stem cells, then we cultured them in lab, and then through differential and loading into individual scaffolds, we implanted those scaffolds into their structure, and through 6 to 12 month follow-ups, we generated the whole palate. And this is actually clinically successful clinical trial from Scenario Libis Hospital in Brazil. We already have a cure for cleft palate, but why do we need dental pulse stem cells? Let's discuss it. It will avoid the adverse effect, it will decrease it, it will alter the healing also, and there will be no trauma through grafting. Another clinical trial, that is chronic periodontitis. We know what is chronic periodontitis. There is a health issue regarding to it. There are double chances of serious diseases because of inflammation in body. Now I'll jump to the technique. What we did, we used the property of dental pulse stem cells, that is regenerative and anti-inflammatory property. We gave that person a periodontal therapy, scaling and cleaning. Then we divided people in 5 different groups in which they gave them different doses of placebo. And this is also a clinical trial from a Japanese company, that is a Japanese medical society. Phase 1 is clinically trial, and after that, through these 5 different groups, we can monitor their heart rate, their blood pressure, white and red blood cell count, and further. Yes, osteoarthritis. We cured osteoarthritis from our pulp. We know what is osteoarthritis. Let's jump to the technique. Yes, again we use the property of dental pulse stem cells to generate cartilage tissues. What we gave that patient 2 different doses of at first we gave placebo, and then 2 different doses of placebo and dental pulse stem cells. Now after we gave them that placebo and the dental pulse stem cells, to monitor that, what we did, we monitored MRI and got x-rays to check if the bone is more efficient or not, if the structure is more stable or not. First phase is clinically trial through a Japanese medical institute. Yes, shock. We cured shock from our pulp. I'll come to the technique. We again use the properties of dental pulse stem cells. The neuroregeneration, we gave them an IV dosage of dental pulse stem cells and placebo. And through monitoring and follow-ups, we developed, we cured shock. Teijin, a Japanese medical society, and a Nippon medical school, they both collaborated, and they found a successful clinical trial. Diabetes too. I'm a dentist, but I can cure a diabetes. How amazing is that? This is actually for diabetes 1 and this is for diabetes 2. What we did, we gave that patient infusion for 6 weeks, and then we kept them into observation for 1 year for diabetes 1, and for diabetes 2, what we had a series of infusions, that is 2 weeks, then after 2 weeks, then 6 weeks. Now, although I told you that these are some clinical trials, some successful clinical trial, now I'll show you how we can actually culture these dental pulse stem cells. We extracted the tooth, we got them, and then we isolated them in labs. Then we made a single cell suspension. Then we expanded that dental pulse stem cells. Now let's see. There are so many dental pulse stem cells can differentiate into so many different cells. I'll show you here: cementoblast, odontoblast, then endodermal, hepatocytes also, mesodermal, osteoblast, chondroblast, we cartilage, we did it, myoblast also. Now, recovery of dental pulse stem cells, from where we can recover it? From baby teeth. Best source, I would say, because they're developing. Wisdom teeth, they're also a good source because there's some extra content in it. Permanent teeth, we can use permanent teeth, but as we know, pulp hardens with age. Yes, banking. There are a few steps of banking: cryopreservation, expansion, therapeutic return, then tooth extraction and evaluation. It all goes around. There are some dental pulse stem cell banks in India. That is Mother Cell Biosciences in Hyderabad, Ekdantam in Jaipur, and in Chandigarh 20 sector, I guess, there is a Mother Cell branch. Now, I would like to end my topic with this conclusion. Leading edge of potential dental pulse stem cells therapies. We can go lab to clinical trials, as I showed you, and according to me, future of regenerative dentistry is now. I'm a dentist, but I can cure your osteoarthritis, I can cure your shock, I can cure your diabetes. How amazing is that if we follow up all this? Thank you so much. Hope you all liked it and hope you learned something from it. Thank you so much.
Okay, good accumulation of data, doctor. Can you please answer a simple question? What are the 3 components of stem cell therapy? Major 3 components.
Ma'am, stem cell therapy.
Yes.
Ma'am, we can extract stem cell, then we can go for scaffolds.
Yes.
And then we can implant that stem cell into that particular structure which we want to regenerate. And then for further follow-ups, it will regenerate.
Are you aware of the growth factors?
Ma'am, growth factors.
Okay, it's
Ma'am,
okay.
I will look upon that. I read it. I will look upon.
Okay. Do you know what is SHED? Shed.
Ma'am, shed, ma'am, shed, ma'am, that's a type of stem. That's a type of dental pulse stem cell. Ma'am, stem cell from human exfoliated aciduous teeth.
Okay, good, nice presentation. Thank you.
Yeah, dear student, I would just like to know that in which year are you currently?
Sir, I'm in 3rd year.
Okay, in 3rd year, considering the fact you did well. Only thing which I want to just a suggestion: whenever you quote a study, just don't say that we did it.
Yes,
you
sir.
need to quote the author's name or the institute name. I was thinking that once you are at Peking University, then you have gone to Japan also, and then you have gone to so it's like you have to quote the author's name.
Yes, sir.
Quote
Sir,
the
actually,
author's
that
name.
was the way of presentation yesterday when my teacher said, don't quote that you did it, because it is your
But
review.
you did it, huh? But you did it. So good luck. Good luck. I just hope and wish you actually could do it in future also. Thank you.
Thank you, sir.
Thank you. Bye.
Thank you, sir.
So herewith we are coming to the end of this session. And on behalf of organizing committee of DENTOCON 2, I thank you everyone for taking out your valuable time, especially in this chilly Sunday afternoon in Delhi and NCR. And I pay my special thanks to Dr. Shivani and Dr. for their valuable contribution in judging this session. Thank you, Dr. Shivani and Dr. Imran.
Thank you.
Here is, we are extending our certificate of appreciation towards you. Dr. Shivani, thank you very much.
Thank you so much.
And
thank you.
Dr. Imran, thank you. So results of this session will be declared in valedictory function. And we conclude this session here.
I would just like to thank the entire organizing committee members to have us here. It was actually enlightening to listen to all the students, and I was just thinking of my 3rd year and final year times, and I was just comparing myself, like how dumb we were I was actually. At our
Same,
time,
same, sir.
these
Absolutely.
students are just good.
These
All
students are very enthusiastic.
very enthusiastic. Thank you, Team DENTOCON too. Thank you so much.
Thank you, Dr. Imran and Dr. Shivani for sparing the time and being so
Thank you,
patient.
ma'am.
And thank you so
Thank you so much, ma'am.
Okay, thank you very much, everyone. We will just take a 5-minute break, and then we will be starting with our next session, which is the panel discussion. Thank you all.
वाला भी बंदा चाहिए ना, पंडित जी बैठ के जो मजे लगा सकते हैं। वीडियो
Dr. Mosami, good afternoon. Dr. Sanjay Singh, good afternoon. Dr. Shambat here.
Yeah, good afternoon, sir.
Good afternoon, Dr. Shambat. Good afternoon, Dr. Moshmi. You're welcome to this session.
Good afternoon.
Yeah. Thank you, sir. Most welcome, most welcome. After a long time, I'm seeing you. After a very, very long time, yeah. I was just telling them maybe more than 10 years.
Yeah, more than 10 years, sir. You are right.
Yeah. How are you doing, sir?
All good, sir. All good.
Yeah, great.
Thank you. At this junction, that question is correct. The sessions are running in time, huh?
Yeah, on time.
A very good afternoon, everyone. After an enriching scientific experience through the 2 days of our conference, DENTOCON 2, we would now be moving on to the last session, a panel discussion on special care in dentistry. May I invite Dr. Anuradha Sharma ma'am, Professor, Department of Microbiology, Faculty of Dentistry, to introduce our chairperson, Dr. Mosmi Goswami ma'am.
Respected Chairperson ma'am, esteemed panelists and delegates, a very good afternoon to you all. It is my privilege to introduce the chairperson of this panel discussion on special care in dentistry, Professor Mosmi Goswami. Professor Mosmi is a graduate and postgraduate from the prestigious King George's Medical College, Lucknow. Having more than 25 years of teaching experience, she is rendering her dedicated services as Professor and Head, Department of Pedodontics at ITS Dental College, Greater Noida. The 41st Conference of the Indian Society of Pedodontics and Preventive Dentistry was organized under her leadership in the year 2019. A recipient of the Fellowship of Indian Society of Pedodontics and Preventive Dentistry, she has been bestowed with the Award of Excellence by King George's Medical College, Lucknow. Presently, she is the President of the Indian Society of Pedodontics and Preventive Dentistry. Respected ma'am, I now invite to chair this session and start this session. Thank you, ma'am.
Thank you very much, Dr. Anuradha, for the kind introduction. A very good afternoon to one and all present. It's a great honor to be part of this conference, DENTOCON 2, and I'm very thankful at the outset to the team for having given me this opportunity to chair a session which is very close to my heart, that is the special care dentistry. And it's my proud privilege to introduce the speakers of the day and moderate the session too. So the first speaker of the day is Professor Dr. Shyam S. Bhatt. Dr. Shyam Bhatt currently is the Vice Principal at Yenapoya Dental College, Mangalore, and he has more than 31 years of dedicated academic experience. He completed his graduation and post-graduation from the prestigious Bapuji Dental College, Mysore University, and has served as president of Indian Dental Association, DK branch, and is also a member of different board of studies. He is the chairman of Autism Board Federation of Special Care Dentistry and has done a lot of researches on autistic children. With huge number of publications in both national and international journals, he is a co-author for periodontic textbooks also. He has been awarded with many prestigious awards and is also known for being the best in the practice since the year 1990. Dr. Shyam Bhatt is a dear friend and he is known to us, and we all honor him for his dedicated services towards pediatric dentistry and especially the special healthcare. Now, I would just like to say that we have divided this into 3 sections. So the first section will be taken up by Dr. Shyam Bhatt. He will be talking about the pediatric dentistry part especially, and then we have another speaker who would talk about the geriatric, and then we would have the psychological aspects of this. So it has been divided into 3 different aspects, and I hope all of you will get enriching experience after these deliberations. Over to you, Shyam Bhatt. Thank you, sir.
Very good afternoon, everyone. 75th Independence Celebration of India, Azadi Ka Amrit Mahotsav. Proud to be a part of that. I'm proud to be a part of NAPA deemed to be university. Greeting from NAPA deemed to be university. We are spread over 140 acres of land in Mangalore, coastal city of Karnataka. We have 3 campuses. We provide education from school to college and all health educations in our campus. Special care dentistry, periodontic perception. I have divided 4 topics in this, that is terminologies, some part of prevention and treatment of special care dentistry, and some schemes available in India to cater service for special care, and drawbacks and challenges we are facing in special care. Coming to some of the terminologies: impairment, any loss or abnormalities of physiological or anatomical structure or function. Disability, any restriction or lack of ability resulting from impairment to perform any activity within the range of considered as normal for human being. Handicap is seen as a disadvantages for a given individual resulting from impairment or a disability which limits or prevents the fulfillment of a role that is normal for that individual, it depending upon age, sex, social, cultural factors. As per census 2011 in India, out of 121 crores population, about 2.68 crores persons are disabled. That is 2.21% of total populations. We need inclusive development and focused initiatives for the welfare of disabled persons. This is categorized in special needs as elderly people, physical, intellectual disability, complex medical problems, psychiatric illness, psychological problems, behavior problems. And disability may be in speech or locomotor or physical, or impairment may be hearing or visual, and some of the things may be overlapping. The people with disabilities need higher and special healthcare compared to the general populations. Some disabled may have multiple health conditions or may involve multiple body functions. Indian national policy for the persons with disabilities recognizes that persons with disabilities are valuable human resources for the country and seeks to create an environment that provides equal opportunities, protection of their rights. Our Prime Minister, Mr. Narendra Modi, suggested the term Divyang in Accessible Indian Campaign in 2015, which means divine body for the persons with the disability instead of visual Vikalang or handicapped. He said the persons with the disabilities are divinely blessed with extra gifts. The National Trust is for the welfare of persons with autisms, cerebral palsy, mental retardations, and multiple disabilities. There are other schemes available in this, that is on the daycare, or maybe for the supportive system, or maybe training schemes. There are 2 government supported schemes, that is Nirmaya Health Insurance Scheme, which caters for a mental retardations, cerebral palsy, autism, multiple disabilities are covered. under this insurance scheme. Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, which covers even mental illness. Special care dentistry cares dentistry in delivery of dental care tailored to individual needs for the patients who have disabling medical conditions or mental or psychological limitations that requires consideration beyond routine approaches. The special needs issues in children, it may be in medical, development, learning, mental, health, or a behavior. ADA definitions that part of a dental practice which deals with patients where intellectual disabilities, medical, physical, or psychiatric conditions require special methods or techniques to prevent or treat oral health problems, or where such condition necessitate the special dental treatment plans. The special needs is increase in number of elderly population and people with disabilities with multiple medical conditions leading to impairment. It needs absence of follow-up and maintenance care, reduce awareness and access to healthcare. Some of the barriers that may be individual or a dental professional. Under individual, lack of perceived needs, anxiety or fear, financial considerations, lack of access. Under dental professionals, inappropriate manpower resources, uneven geographical distributions, training inappropriate to changing needs and demands, insufficient sensitivity to patient attitudes and needs. Under society barriers or societal barriers, the insufficient public support of attitude conducive to health, inadequate oral health care facilities, inadequate oral health manpower planning, insufficient support for research. Under government, lack of political will, inadequate resources, low priority. These are the infrastructure supporters systems. In the infrastructure modifications, hearing and visual impairment, wheelchair users, managing with the challenging behavior, ensuring airway patency, referral for treatment and consultation by specialists, intercollaboration with other health care providers, physical interventions. Special care dentistry is necessary for the persons with severe movement disorders, chronic mental health, illness, the persons who are adults in age but who functions at a child's level, the medical conditions at risk for the adverse outcome of the dental settings unless treated by a knowledgeable practitioners, the communications with all members of the healthcare team, family, caregivers, physicians, social services, and the dental team is essential. It's a multidisciplinary approach. The children with special healthcare needs are best managed initially by the multidisciplinary team, in which a dentist is available to evaluate the child's extraoral and intraoral findings. The team helps and prepare the family for the child's future treatment need. The main objectives of care are to motivate the patient and caregivers to maintain oral health, the prevent infections and tooth loss, the prevent the need for extensive treatment that patients may not be able to tolerate due to their physical or mental conditions, and make appointments pleasant and comfortable. General oral health status in impaired patients, the poor cooperations, less importance to oral health, resistance to mouth cleaning, challenging behavior, sensory impairments, limited access to dental services. Then dental care is in special needs patients. Prevalences in patients with impairment is higher. The more untreated decay, the more missing teeth, fewer restorations, malformed and hyperflush teeth, and higher incidence of malocclusions. Preventive dental caries in special needs patients by topical fluorides. High doses of topical fluorides can be used in some cases. High fluoride toothpaste alternatives or fluoride mouthwashes. Dietary constitution and forms. Liquid oral medicine may be avoided or maybe under the precautions we can reduce, depends on the dosages, or you can take the proper precautions once you use the oral medicines. Chlorhexidines, either gel form or varnishes. A traumatic restorative treatment can be used or maybe help for the treatment of dental caries. Tooth wear in special needs patients due to the neurological impairment, clinching or grinding causes attritions, cerebral palsy due to gastroesophageal diseases like vomiting or maybe cause erosions. Bizarre of oral habits may cause abrasions. Gingivitis in special needs patients leads to poor oral hygiene, resulting in plaque accumulations and gingivitis. Down syndromes more prevalent causes of periodontal diseases or early tooth loss. Epilepsy medications can cause gingival hypertrophy. Mouth cleaning missions required for the caregivers or relatives. Due to the drug-induced hyperplasia of gingiva, the preventing gingivitis in special needs by modified manual toothbrushes, change medication or modified doses by the help of physician. Mouth cleaning resistant patients can use power brushes, toothbrushes. Preventing the tooth wear in special needs patients. If no toleration for the extensive treatment, remove badly worn teeth. With the tolerance under sedations or maybe under GA for full coverage of affected teeth and molars. Cleaning aids not to be erosion. Inflicted trauma in special needs patients. Self-mutilations involving oral tissues in certain syndromes. Teething sometimes triggers it. Lip and tongue bite can cause pain and swellings. Mouth is too sore to drink or eat. Dehydration or maybe the hospitalized patients can live of self-traumatic in special needs. Preventing self-inflicted trauma in special needs patients. If offending teeth are primary, you can extract. Use soft pins to prevent soft tissue traumas. If malocclusion, teeth adjustment or orthodontic treatment depending on the case. Preventing hypersalivation in special needs patients. Excessive drooling, especially in poor neuromuscular control, in case of cerebral palsy or cerebrovascular accidents. The prevention and management can be under surgical, pharmacological, radiotherapy, maybe palatal training aids, and behavior modifications. Xerostomia in special needs patients associated with some syndromes. Medications in elderly patients. Patients on radiotherapy results in increased rate of dental caries and ill-fitting dentures. Preventing xerostomia in special needs patients. Radiotherapy, preoperative dental care to be avoid extractions, high dose of fluorides or varnishes, chlorhexidine mouthwash or gel, saliva stimulations or saliva substitutions. Coming to the drawbacks, both government and patients are burdened by the cost factors of the treating dental problems for these populations. Information describing the special needs are providers. Training and curriculum needed for this specialty are limited. Dental graduates are increasingly being challenged in treating patients with special care due to lack of emphasis and even absence of special care dentistry, the curriculum in BDS educations. Overcoming challenges in managing patients with school special care dentistry may be an issue for the dental professions. The most dental students were reluctant to treat special care dentistry patient, particularly those with sensory or intellectual, psychiatric disabilities and infection diseases. The reason for not providing care to these patients was due to lack of training and clinical experience managing them. World scenario: United States, no trained dentists were available to provide treatment for adults with special needs. However, for the children with special needs, trained dentists and staffs are available. UK, patients with profound disabilities are treated at the community dental services by the professionals who are trained to treat such patients and who are considered as a specialist in special care dentistry. Australia, services for the patients with the special needs are well established with their respective regional approach. Malaysia, the authorities are working towards setting up centers to attend to people with the disabilities. Special need dentistry or special care dentistry as a specialty. The term special care was introduced in 1981 by the Journal of Special Care Dentistry with the American Association of Hospital Dentists and Academy of Dentistry for the persons with disabilities. In 2003, New Zealand and Australia, that is special need of dentistry under the hospital dentistry and under the pediatric dentistry. In 2008, United Kingdom has special care dentistry with the help of dentists with special interest in special care dentistry. In 2016, Malaysia is started about special care dentistry. These are supportive articles on that. The International Association for Disability and Oral Health, IADH, which gives the guidelines for the UG curriculum in school in special care dentistry. Learning outcome with many of the school skill being transferable across the undergraduate courses, teaching and assessment to assess the critical teaching in relations to special care dentistry and to provide and promote positive attitude towards the disability and diversity. The learning outcome designed to readily adapted to confirm the generic profiles and competency. The students should have diverse patients, case mixed during their undergraduate studies to achieve the required level of confidence and competency by the time they graduate. Clinical care, competency in special care dentistry, emphasis the need for learners to broaden their theoretical knowledge and understand thorough critical experiences in providing care for the people with special needs. Challenges in special care dentistry. Inadequate educational plan of special care dental curriculum, lack of training in education materials, lack of trainers, that's experts and teachers, lack of infrastructure in terms of dental equipment and facilities, disabled friendly facilities, clinical sites, and patients. Challenges: the absence of structured learning objective, teaching methodologies, and assessment. Special care dentistry incorporated in pediatric dentistry, oral surgery, prosthodontics, and community dentistry. Teaching the behavior management, disability equality training workshops, experiences in the dental clinic, attitude and skill in geriatric and medical rehabilitation wards, nursing homes, special needs and other rehabilitation centers are needed. Futures. Dental professionals of the future need to be able to meet the challenges posed by the healthcare needs. Dental education is the key to improve the field of special needs dentistry through comprehensive development of standardized special care dental curriculum. The policymakers, the stakeholders, and the educators must work hand in hand where education for a special care dentistry is concerned. The collaborative exercise between dental school and medical schools and external organizations such as Special Olympics, government agencies, NGOs, and special schools. Knowledgeable transfers, sharing expertise and resources for special care dentistry teaching, clinical experiences for dental students and research development. The Ministry of Health and Family Welfare Government of India, under the National Health Mission, launched an innovative and ambitious initiative which envisages child health screening and early intervention services, a systematic approach of early identification and link to care, support, and treatment. The program to improve the overall quality of a life of a children, enabling all children achieve their full potential, and also provides comprehensive care to all the children in the community. That is Rashtriya Bala Swasth Karyakram. A pilot project. This program involves screening of children from birth to 18 years of age for 4 defects, that is defects at birth, disease, deficiency, and development of delay, spanning of 32 common health conditions for children, detection and free treatment and management, including surgeries at tertiary levels. DEIC, that is District Early Intervention Center at District Hospital, that we have set up this clinic in Mangalore city, that is with the help of government of Karnataka, Wenlock Hospital. We are catering the public of the special care children and special needs. Thanking you with the support from the FSCD, ISPPD, IAPD. We work together and we can achieve for a special care dentistry. Thank you.
Thank you very much, Dr. Shambhat, for the
Thank you, madam. Thank you.
enlightening presentation. Really, the way you now this the special care industry has also come a long way. Yeah, since the last 10 years, and now the parents as well as the society expects that we take good care of their oral health. We have come to the term differently abled, and as Dr. Shambhat put it, we really come a long way. Okay. Somehow my video has got stopped. It's okay. So So yeah, now even the dental setups which are coming up, they should be more disabled friendly. Like we should really have ramps and things in place where the doors to people can really enter the dental clinics and seek dental care. And as you put it, that disability equality training, that's also very, very important. And those things were very nicely put in. And I'm sure in the end we will have, when we have a panel discussion, that time we will ask specific questions to Dr. Shambhat also. And as I have been asked to move forward, somehow my video is not playing. I don't know why.
Host has blocked it. Host has stopped it.
Yeah, seems to be some problem. So introducing the second speaker of the day, Dr. Manu Rathi. Dr. Manu Rathi is presently working as Senior Professor and Institute of Dental Sciences, Rohtak, Haryana. Currently, she is President-elect for Indian Prosthodontic Society and is Chairperson for Board of Postgraduate Studies, Health University, Haryana. She is a member of National Academy of Medical Sciences, Fellow of International College of Dentists, and Pierre Fauchard Academy. She is a diplomate of World Congress for Oral Implantology and recognized postgraduate teacher guiding students for more than 16 years. She is the associate editor for the Journal of Indian Prosthodontic Society. She is on the panel of examiners for various universities, a reputed academician. She has been invited as guest speaker and keynote speaker at various national scientific events. She has participated in over 200 conferences and has over 180 publications in various esteemed peer-reviewed national and international journals, and a very dynamic person.
Greetings, everyone who all have joined virtually DENTOCON 2. At the onset, I would like to extend my thanks to the whole team of Jamia Millia Islamia University and Innovative Education and Scientific Research Foundation for giving me this opportunity to be a part of this panel discussion on the theme Special Care in Dentistry. My special thanks to Dr. Sanjay Singh sir for this opportunity. And with the permission of the chairperson of the panel discussion, Dr. Maushmi Singh Goswami ma'am, I go ahead start my presentation. This part of the panel discussion primarily focus on the care of the elderly, the geriatric population. So geriatric means the old population, but we should know first of all, who is an old patient? The one who has aged. Aging that simply refers to the sum of all morphologic and functional alterations that occur in an organism and they lead to functional impairment that decreases the ability to survive the stress. Various theories have been proposed for the aging, but who is an old patient? Nobody would like to be labeled as an old patient, but earlier WHO defined any person who is 60 plus age is considered to be a geriatric patient. And this guideline by the WHO was later modified that currently any person who is 65 plus years of age is considered to be among the geriatric population. And this wide group of the population has been further subdivided into the subgroups, with the youngest one being the young old, the patients who are between 65 to 74 years of age. Though the term seems to be quite contradictory to each other, young, old in the same. However, the geriatric population has been subgrouped accordingly. The old is the person who is between the age group of 75 to 84, and anyone who is above 85 years of age is considered to be the oldest old. And this classification has been made according to the main features observed in this age group. Like young old, only the impairment of function are observed, whereas in old age group, the disability starts setting in. And old age group, generally handicap also precipitates in this age group. So from a oral care provider, healthcare provider, how do we see this population? The young old patients are generally observed to be functionally independent, which is a major proportion of 75% of the geriatric population, and they are able to generally get to the dentists. Whereas the old patients, which comprise approximately 14% of this age group, are frail elderly, and they are usually affected by the chronic conditions and impaired mobility. Whereas the oldest old, which make around 5% of the geriatric population, are generally functionally dependent. They are usually observed to be homebound and institutionalized. So we need to know what are their requirements, and accordingly we treat. So first, let's have a look how much is the load of the geriatric population. On a world level, generally there are it is estimated to be, there are 80 million geriatric people. And in Indian scenario, approximately 8% of our population is counts towards the geriatric population. And a very unique feature of this segment of the population is that there is a steep rise in the elderly population. Also, there is a gender variation. There are more of the elderly females as compared to the males. And the projection is that in developing country, including India, by 2030, there would be 86 elderly men for every 100 women. And if we see specifically in Indian scenario, post-independent era, earlier the rise in the geriatric population was slow, but at the turn of the century around 2000, then this rise in the geriatric population has been very steep, and it is projected till 2050, this steep rise will continue. Not only within 65 plus years of age, but the adjoining age group of 60 plus population is also showing the very steep rise in the 60 plus years of populations. Also, another characteristic feature of the demographics of the geriatric population is that the 80 plus years persons are the fastest growing segment among the geriatrics. So all these demographics, what they indicated, that there is a large proportion of the geriatric population, which is a special care group. And it is expected that this proportion of the special care group is going to increase in the recent future in the coming decades. So these are a vulnerable group. Vulnerability simply means that the state or condition of the being weak and poorly defended. Though there can be very young and the very old are likely to be medically vulnerable, but elderly are the vulnerable group. Why do we put these elderly or the geriatric population among the vulnerable group? Because of their susceptibility to dysfunction, impairments, and losses. Because the physiological and physical functioning usually declines, rendering them more sensitive to frailty, crisis, and detrimental environmental conditions. Also, they are exposed to psychological stress and social isolation due to declining health and personal losses. So, in addition, it is generally observed that with advancing age, the multi-systems are affected by disease and disability. And all these factors put this population group in a special care group or the vulnerable group. And we have seen the very similar trend in the recent crisis of the COVID. The fatality rate was highest among this group. This chart clearly depicts that 60 plus years, 65 plus year, there is a marked increase in the death rate of this age group. All these factors establish the fact this is a special care age group and more vulnerable. What can we do about it as oral healthcare provider? We have to start up developing our infrastructure, which is specifically designed for this age group. Our operatory has to be senior friendly, right from its access, starting from the parking, and even the stairs should be avoided. We may neglect even one or two steps, but those two steps may appear as a mountain for a orthopedically compromised geriatric patient. Then patient next enters into the reception. We can't make the patient, such a patient, sit onto a stool because it might invite a sentinel event of falling. So we have to take care of the seating arrangement which is suitable for this category of the population. Also, we have to minimize the falls, which is observed to be one of the commonly observed sentinel event. Avoid any slippery surfaces. Provide support through railings as and when required. Also, the lighting in the area has to be appropriate. It is significant because most of the time, certain instructions to the patients are not verbally conveyed and they are displayed in the reception areas, believing that patient would be reading while he is spending his time in the reception area. However, this display of important information in the dental operatory has to be in a size that is easily readable by the geriatric population, because generally the visual component is also compromised in this age group. Another factor which we have to pay attention is to the hearing, because communication makes a lot of part during the oral healthcare delivery. And if the appropriate things are not communicated to the patient, patient won't be able to participate in the treatment planning. Generally, a hearing is also compromised. So we have to be considerate about this aspect of the elderly population. And we should use measures to enhance the communication. Go closer to the patient, minimize the background noise, but at times we may not be able to communicate appropriately with the patients. And in that situation, patient might not be in a position to participate in the discussion for the treatment planning. That time we take care of the caretaker of the patient. However, even if the treatment planning and the instructions are discussed with the caretaker, patient should not be ignored at this time. So as a healthcare provider, oral healthcare provider, what are the challenges among us in front of us? First thing is there is more of a chronic systemic diseases load in this special care group. So making it as a vulnerable group. Also, a cognitive decline is observed with the advancing age. That is why the patient compliance might decrease and patient's compliance for following the instructions might decrease and his inputs for the treatment planning may not be there. Also, whatever studies are there currently in the dental literature, they have been conducted in the relatively younger age group. So extrapolating the results of the studies regarding the dental treatments done on the younger age group onto an older age group might not be absolutely appropriate. And currently there is a lack of the literature regarding the studies conducted on the geriatric age group. 85 plus years of the age groups represents a new challenge, as the frail and the geriatric patients are not as resilient as the younger patients. Their lives is dominated by dependency, multimorbidity, and frailty. And the priority of the very old patient is usually the restoration of the chewing function, as it compromises their social component of eating and quality, oral health related quality of the life. So the demands, needs, financial means, and physical abilities are different from the younger patients. In treatment planning for the oral health care, certain other factors do pop up, like physical, psychological, social, and emotional factors associated with this geriatric group cannot be excluded while planning a treatment for the oral rehabilitation. So what we can do as a dentist or an oral healthcare provider, though we cannot do away with the systemic disease and disability, however, we try to achieve the compressed morbidity, which is to maintain the quality of the life for as long as possible by shortening and postponing the periods of the seriously compromised health. Same applies to the dental care as well. We might not be going for the extensive and ideal treatment. Rather, we try to focus to achieve the compressed morbidity. How do we assess a geriatric dental patient for oral care? Definitely, we pay attention to the oral condition, systemic condition. In addition, for this age group, we do assess the capability. What is the patient's functional and mobility levels, which is never a concern in a younger patient. Also, autonomy. Is the patient capable of making decision in view of his financial condition and in view of his cognitive abilities? And also, we have to take care of the reality. How important is the oral health in the big picture, and what are the limitations? In these patients, we are never trying to give the ideal and the best treatment. I share my personal experience. Like once I was called to attend a edentulous patient in my medical facility, and the patient was 101-year-old female patient, bedridden, and bedside I observed that the patient's cognitive ability has markedly declined. She is not in a position even to communicate. Hearing is almost lost, and the caretaker informed me that the chief complaint is impinging complete danger. So at this time, I cannot think of giving her a very extensive treatment of implant supported full mouth rehabilitation or remaking it, because the patient's compliance is minimal. So at this stage, only a relining of the denture was the suitable and the best treatment for this patient. So we cannot ignore the reality in view of all the factors collectively associated with these special group patients. So there are 4 domains of the dental needs. Function that relates to the ability to chew and eat an adequate diet. Here we don't, because patient might have to skip a certain foods, but if he can or she can have an adequate diet, that should be our goal. Symptomatology, we aim at relieving the symptoms. Pathology, we relate to not having any oral discomfort or lesions in the mouth. Aesthetics, it relates to perceived needs to improve their appearance. Here the needs changes to perceived need for these particular patients. So what is the treatment for this special care group? Definitely the best treatment is the no treatment at all. However, there are different levels of the dental care which we can extend to the special care groups. They may be very extensive care, which are utilizing very full mouth rehabilitation and extensive fixed restorations, or it may be an extensive care, which is a combination of some fixed restorations, some removal restorations, or it may be an immediate care, which requires some alternatives to the traditional therapy, slight modifications. Whereas a limited care is for those patients, those cannot tolerate the extensive time in the dental chair, and they need shorter appointments and the simplified treatment plan. And a very limited care may be indicated where the patient should be treated for pain relief and infection control only. Sometimes doing no treatment is in the best interest of the patient. So depending upon the age and the whatever treatment needs, the different levels of the dental care are extended to the special care group. So there are, but how can we extend these different levels of dental care? 4 types of the dental delivery systems are available for the homebound and the institutionalized elderly. Because the patients who cannot come to the dental operatory, they have to be treated in their relative locations. So one model is the private dental practice model, which is the ideal delivery system from dentist point of view. And however, this is expensive and time consuming. Another one option is the on-site dental programs. These are appropriate options in the large nursing homes where the economy of the scale renders them very cost effective. However, even the on-site facilities, they cannot be moved to treat the bedridden residents of that facility. Another dental delivery system available for the special care group is the portable dental programs, and these are the self-contained dental units and instrument kits that can be transported by the provider into the facility or the person's homes. And this system is ideal for homebound and the bedridden or institutionalized individuals. Another option is having a mobile van programs where a van is modified and to accommodate the built-in dental equipment, supplies, and the dental team. And this mobile dental office has all the advantages of a private office, in addition to the ability to the visiting nursing facilities and the private homes. So we have, dear friends, we have all these options, but still the special care group has not have not received the care. So what are the limitations to this system? Why there has been a reluctance? The apparent reluctance of the dentist to treat the elderly patient outside the conventional practice has primarily been attributed because of the low reimbursement levels, inadequate treatment facilities in the nursing homes, and inadequate training in the geriatric dentistry. So that is a few points to ponder upon regarding the geriatric population. I would touch upon a little bit about the palliative care. Palliative care is given to the terminally ill patients. But what exactly is the palliative care? The WHO defines palliative care as an approach that improves the quality of the life of the patients and their families facing the problem associated with the life-threatening illness, through the prevention and relief of suffering by means of an early identification and impeccable assessment, and the treatment of pain and other problems, physical, psychological, and spiritual. Here, as dentist, our part as a member of the palliative care team giver is more elaborate than simply oral rehabilitation. It not only involves the patient, but the families are to be attended, and it goes beyond the medical treatment as well. Though because these are the terminally ill patients, so this palliative care focuses, it affirms life and regards dying as a normal process. It intends neither to hasten nor to postpone the death, but uses a team approach to address the need of the patients and their families, including their counseling. Regarding specifically the palliative care from the oral healthcare provider point of view, there are the prevalence of the common problems among the terminally ill patient includes xerostomia, normal fungal infections, and other issues. So how can we manage? For the most common oral symptoms observed in these terminal ill patient is the xerostomia, the dryness of the mouth. For this, we give some instructions to the patient regarding frequent sipping of the water, or if required, the salivary substitute may be advised. And oral mucositis is one of the commonest feature, which can be quite painful at times. So for this, a simple instruction of maintaining oral hygiene, not only to the patient but also to the caregiver, can avoid this situation. And if it is more painful, even the topical anesthetics may be suggested. Another most commonly used opportunistic infection is the candidal infection, and that can be treated with the antifungal drugs. However, because there might be multiple symptoms and plethora of symptoms in the terminally ill patient, but the best perspective from oral healthcare provider would be to adopt a preventive approach. So simple instructions given to the patient and the caretaker can avoid many of the problems, like keeping the lips moist and keeping the oral cavity moist. That will minimize a lot of problem, and simple instruction can manage that. Brushing the teeth. Either the patient himself or herself is capable of maintaining the oral hygiene, or caregiver is given demonstration to maintain the oral hygiene, not only of the teeth, but the interproximal areas in the soft tissue, and not to neglect the tongue. So the patient can be demonstrated, and if the oral hygiene issue is addressed, many of the subsequent problems in these terminally ill patients can be managed. Also, if the patient is a prosthesis wearer and it's a removable one, patient and the caregiver should be advised according to the hygiene for the hygiene of that as well. So as oral healthcare providers, what are the challenges in managing the patients, special care groups, maybe geriatrics or the palliative cares? We observe that there are no standard operating procedures specified for this population group. A very simple thing, not even a toothbrush has been customized for this age group. We have a pediatric special group, and we have a pediatric brush, but there's nothing geriatric, the toothbrush which is customized for the maintaining the oral hygiene. We understand that most of the time this age group is affected by the orthopedic inabilities, the joints of the hands are affected, that compromises the maneuverability. So if a routine conventional toothbrush is modified to suit the maneuverability of that particular patient, that will assist greatly to the patient in maintaining his oral hygiene, which he is not able to do with the conventional toothbrush. Also, it is observed that for institutionalized, homebound, and bedridden patients, treatment needs and challenges have not been clearly identified. Unless until we pinpoint them, only then those issues can be addressed. Also, a lack of the training of the healthcare staff is observed. I would be sharing few of the special care patients they were to handle, specifically in the current COVID era. These are the geriatric patients who were affected by the COVID, and regarding their oral infestation, they had the mucormycosis. And these patients were admitted into the medical facility associated with our institute, and they were managed bedside. For this is a pre-operative view. In this, the palatal tissue was affected, teeth were extracted, and soft tissue debridement was done. After that conventional procedure of rehabilitation was followed, diagnostic impression made, and the diagnostic cast was observed. This was the pre-surgical debridement photograph, and for this patient, the bedside impression was made, and the master cast for fabrication of prosthesis was obtained. Lab procedures was followed, blockout was done, and immediate surgical obturator was planned. This is another patient who was referred not before the surgery, but immediately after the debridement. Preoperative view on the right side, the sutures in position. Immediately after surgery, the patient, a call was sent for the oral healthcare provider to attend to the patient bedside. And then the routine procedure, the blockout was done for the safety, and impression was made, and the master cast for fabrication of the prosthesis was planned. In this patient, because the size was bigger, and so to reduce the weight, a hollow obturator was planned. And this was immediately, it was given on sixth day after the surgical debridement. And the patient was followed up, and later when the defect was healed, the same hollow obturator was incorporated, and patient's oral rehabilitation was continued, impression made, master cast was obtained, and prosthesis was planned, trine was done, an artificial denture was planned, teeth arrangement done, and trine was done in the patient. Since there were not much of the teeth to provide the retention was drawn from the anatomic undercuts, and magnets were utilized to retain this denture with the obturator part, and the patient was rehabilitated. This all was done when the patient was admitted indoors. So in these patients, what was observed at that during conducting the clinical procedure, the bedside facilities to modify the bed was not available. So it was very inconvenient to carry out the clinical procedure. Another observation was that the paramedical staff was not well trained to maintain the oral hygiene and to take care of the patient. The paramedical staff had to be briefed elaborately, as such training is not the part of their training curriculum. Also, another significant aspect for special care group is that because many of the geriatric patients who are affected by the orthopedics and their mobility is compromised are the wheelchair bound patients, and the simple step of shifting the patient from the wheelchair, the dental chair, might be quite troublesome. So there should be a provision of modification of the dental chair. So this is one of the primitive models where the seating area can be removed and the wheelchair can be moved in place, so that patient doesn't have to go through the discomfort of shifting from the wheelchair to the dental chair. So there is, however, there are not much of such options available, and there's still a scope of improvement in the infrastructure regarding care of the wheelchair bound patients. So these are the few points that we as a oral healthcare providers can ponder upon, can contribute towards taking care of this special care groups. And I would like to conclude by saying that the challenge for the dental profession is to develop oral health promotion and disease prevention programs and treatment and financing strategies that will meet the unique needs of individuals in special care group, especially those in the long-term care settings. Also, there's a need for the expanded courses in geriatrics and dental training. There's a need for an increase in the interdisciplinary communication among dental health and allied health professionals to optimize treatment outcomes. As for special care patient, generally it is more of a dental surgeon works as a part of the team of an interdisciplinary team. I thank you all for your patient listening.
Thank you very much, Dr. Manu, for the wonderful presentation. And Dr. Manu really took us through the geriatric problems and also through the palliative care and especially mucormycosis during the COVID era, wherein the role of oral surgeons and prosthodontists have really rehabilitated a lot of patients. And we have seen that the various challenges that are there, these are mainly that the standard operating procedures are not in place. There is not enough training which is available to the dentists so that they can really work upon such patients. But the expectations, as I said earlier, also of the society and of the patients is increasing. So we definitely need to harness ourselves. We need to really come up with something wherein we can train more and more people who can cater to the needs of such disabled or such special community, I would say. And also she's talked about the not even a customized toothbrush is available for these geriatric patients. Yes, for the pediatric patients, Dr. Shambhat, he showed how we have designed perhaps something like that even you could incorporate. For the homebound, these special people or the geriatric population, they are not even, the accessibility to the dental care is not even available to them. Like they are not even identified as to where they are, and the condition is also not identified. So if you look at the remedies that we can really provide to them, first thing would be training and coming up with courses that the dentist can avail and they can really work upon. And we really have to think that in the long term. Yes, so we're moving on to the third speaker of the day. Thank you, Manu. That was a wonderful, wonderful presentation, I would say. Moving on to the third speaker of the day, Dr. Anisha Juneja. She is a clinical psychologist and an academician. Her areas of interest include mental health, parent-adolescent relationships, and career decision-making processes. She has conducted workshops on self-confidence, suicide awareness, and emerging adolescent issues in colleges and NGOs. She has been a co-editor of an annual academic journal and also has run a peer support program in Lady Shri Ram College for 5 years that trains students in facilitating college adjustments. Currently, she is working as an assistant professor in the Department of Psychology at Aryabhat College, University of Delhi. Her published work includes books, chapters, review papers, case studies, qualitative and quantitative work in reputed national and international journals. I welcome you, Dr. Anisha Juneja, for your presentation.
Thank you, ma'am. Good evening, everybody. So as a clinician, I believe it applies to all of us that one size fits all doesn't really work in the clinical setting. So neither would it apply to you, nor would it apply to me. Sometimes we think about why is the progress that our clients are making is not up to our expectations. So the thoughts that come to our mind include, have I made the correct diagnosis? Have I followed the correct treatment procedure? In this process, we try to identify if there is something that has been amiss that needs to be considered more closely. So that brings us to the topic for the day, with which we are going to end as well. The panel discussion, the psychological basis of different behaviors observed in dental setting. While I would also want to put this across to all of you, I am not intending to say that when we discuss these points, the dentist should become a psychologist or a clinical psychologist or a mental health expert. But at the same time, I do understand that dentists can be the first line of defense for a lot of psychological problems and the identification of those problems in the settings in which you're working, because you're the most credible and the reliable people, the people on whom your patients actually trust as well. So as Manu ma'am was also talking about this oral health, as much as we know about dental anxiety, dental phobia, quality of life has an important component of oral health. When we talk about quality of life, it's about physical, psychological, social well-being. But at the same time, it also incorporates an important component of oral health, which is not just being in a state that is free from mouth and facial pain, but it is also an individual's capacity to smile, to speak, and which also affects their psychosocial well-being. So While in the clinical practice, we as clinical psychologists look at a biopsychosocial model of mental health where we try to identify the biological, psychological, and social factors that contribute to mental well-being, psychological well-being. It becomes important here to add an aspect which is the reciprocal relationship between the mental health and the oral health. Why is there a need to understand this link? I'm sure you people must be knowing much more than me on this area, that there are enough research papers and empirical evidence to talk about how stress can be associated with poor oral health, how psychological disturbances and psychological illnesses are associated with poor oral hygiene, tooth decay. So for instance, eating disorders like bulimia and anorexia nervosa are associated with purging behavior. And that purging behavior in which the client would tend to vomit would also affect the tooth enamel and cause dental erosion. And similarly, we can see it in different kinds of disorders, the psychotropic medications that have an effect on the mouth, on the teeth, and on the gums. Now, I'm just flipping this a bit. While in this slide, if you see, the arrows are in one direction. In the second slide, in this slide, you can see the arrows are now pointing to another direction here. So when we talk about poor oral health, we can trace it back not just to the apparent physical problems in the mouth or with the teeth. We can trace it back to other factors as well, like the psychological and the social factors. So poor oral health could be associated with consumption of caffeine, which you would definitely be able to identify. But why is there an increased caffeine consumption? It is to deal with the stresses of life. It is to stay awake for students, to maybe study a little bit more, to write, to finish off their assignments and all of those things. And similarly, in the same manner, you can look at the same point, the same clinical complaint that comes to you, the chief complaint that comes to you from a psychological angle as well. So how do you know that your patient has psychological issues? What you see or what is manifest to you might have many roots underlying it beneath the surface. And that is what can be identified by your interactions with your patients. So the fact that your patients are missing appointments or avoiding or delaying dental treatment, are becoming irritable or aggressive, are showing poor compliance to treatment, or are showing deterioration in your oral health, in their oral health, despite the fact that you're putting in the best efforts and you're providing the best treatment possible. So there is something that is going wrong and something that needs to be worked upon or identified further. So I'll take this from a very developmental lifespan perspective point of view, where from the children to the adolescents and adults, and then I'll move on to the geriatric population. So when we talk about psychological issues in children, what you'll see in your clinics would be the temper tantrums that these children would throw, like crying, head banging, shouting, arching their backs when they're sitting on the dental chair, stiffening their limbs, and similarly behavioral problems like being violent and being very aggressive, or maybe even stealing and destroying property in the clinic or in the dental settings that you have. Now, where do we trace these problems to? Like, where do we trace the causes of temper tantrums and behavioral problems to? That is something that can be looked on from a psychosocial perspective proposed by Erik Erikson, a theorist in the field of psychology. Erik Erikson talks about the first stage of a child from the infancy to the toddler age. He says that across the lifespan, individuals go through different kinds of conflicts, and different kinds of qualities and strengths emerge through the resolution of these conflicts. So the fact that the first stage is characterized by a trust versus mistrust conflict, which goes into the direction of trust only if there is a caregiver who's providing consistent care and consistent and putting in consistent efforts in the bringing up of the child. So while if a caregiver, the primary caregiver, irrespective of it being a mother or a father. If the primary caregiver is not really able to provide that consistency and that certainty in care, a child may develop a sense of mistrust on people around him or her. A child may not be able to develop the sense of hope that things would get resolved, problems would get solved. And this is something that you would also tend to see in your dental settings when the child is not able to trust the dentist in their actions, and that is why they will not comply to your treatment, or they will not adhere to the instructions that you are giving to them. Similarly, we can look at it from the parenting patterns point of view given by Ainsworth. So just the way we teach our children, we model behaviors for our children, there are parenting patterns that can be associated with poor oral hygiene and poor behavioral patterns or maladaptive behavior patterns in their day-to-day life. So for instance, laissez-faire parenting, helicopter parenting, and authoritarian parenting are associated with behavioral problems. A parent who is neglectful, a parent who is not paying attention to the child, or who does not care about what are the kind of problems the child is having, or what are the kind of lifestyle patterns the child is engaging in, would result in a failed dental treatment as well, because they are not attentive to what the dentist is saying, they are not attentive to whether the child is actually adhering to the instructions of the dentist. Similarly, on the other hand, there might be an authoritarian parent who's very critical, or who is very observant more than required, and is not providing a sense of freedom to the child to express himself or herself. And similarly, a helicopter parenting, which is a recent type of parenting that we've been seeing, where the parent is over involved in the children's activities and in the children's behavior. So this could also result in they not being completely honest about what is going wrong, because it reflects something that is wrong within the psyche of the parents as well, with regards to they needing approval, they looking for perfection, and their desire to have the perfect and the most successful child amongst all. So this could be associated with problems that you tend to see even in the dental issues that the children come up with. At the same time, when I talk about parenting patterns and the primary caregiver relationship, I would want to say that we cannot put all the blame on the parents for their upbringing. There are also individual factors that a child is born with, and that is what is temperament, or the psyche, the personality of the individual. So if a child is generally an impulsive child, or who has a labile mood, or who's not very tolerant towards stress, then that can additionally contribute to the issues that you see in the dental behavior of the child, or in the oral health of the child. At the same time, there could be situational factors like the smell and the physical environment, the dental setting, the behavior of the dentist. All of that could play a role, and the previous dental experiences that the child has had, if they have been painful, if they've been scary, if they've been disturbing, if they've not been dealt with in a sensitive manner, then that can also contribute to the poor results of the treatment that you are offering to the child and the family. At the same time, there are certain childhood experiences that I would want to talk about, like physical abuse and sexual abuse. Physical abuse, I'm sure, is manifested and is very visible to you in terms of there being bruises on the child. But there might be situations where the child is undergoing sexual abuse, which is resulting in a fixation that a child could go into, which is thumb sucking. So I'll just briefly talk about a case that I had seen in my clinical practice. A 5-year-old girl was brought with complaints of thumb sucking, and this was referred from a medical personnel only to the mental health setting. And where we traced it back to, while I was interacting, while I was trying to break the ice with the child for at least 3 sessions did not speak anything. And gradually, through various psychodiagnostic projective techniques that we used, I realized that there was an incidence of repeated sexual abuse that the child was going through. And thumb sucking became a way, which is like an oral fixation that you might be aware of, which became a way to cope with the stress for the child. And I'm sure we understand that thumb sucking is related to a lot of other oral health issues. So as a clinician, you might want to try your treatment and might want to get a breakthrough, but there could be underlying issues which might not be very, very apparent to you that you need to bring forth and maybe refer the child accordingly to a psychologist. Now, children with developmental disorders, as Sir had also previously talked about, that children with developmental disorders like autism, attention deficit hyperactivity disorder, intellectual disability, manifest their difficulties in their poor eye contact, poor social communication, restlessness and fidgetiness, and the poor self-confidence that they show. So it becomes all the more important for these children to be handled in a very sensitive manner, where it might require you to put in an extra effort in providing that sense of comfort and familiarity to the child, to the new environment in which this child has come into. And then you can work upon your dental procedures that are suitable for the child. Now, when we come to the psychological issues in adolescents and adults, a lot of issues emerge from the dental issues that emerge are from the lifestyle patterns that adolescents and adults have these days, with the work from home environment and in general a very competitive environment in which we are living. A lot of academic, vocational or work life stress leads to consumption of junk food, alcohol and substance abuse that leads to the kind of issues that you see even in the dental sphere. Body image could be body image concerns that some adolescents and adults might have, might lead to unhealthy patterns as well. And an excessive drive for accomplishment could result in not taking care of one's own self, which leads to the issues that we tend to see subsequently or encounter in the dental setting. While we are talking about these psychosocial factors, we also need to identify that these adolescents and adults could be engaging in poor coping styles. Like Lazarus has talked about how an emotional and an avoidant coping style might be the coping style that is being used, whereas a problem solving or a problem focused coping style is not the style that is being used by these adolescents, and that could result in the maladaptive behaviors that they show. At the same time, there could be cognitive distortions, where these are basically problems and patterns of thinking which are extremes in terms of being, in terms of looking at things from an all or none point of view and catastrophizing things कि सब कुछ जो है मैंने अगर इतना ट्रीटमेंट नहीं लिया तो बहुत ही खराब हो जाएगा, या फिर what is the big deal if I do not what is the big deal if I do not go in for a treatment of what I am going through with respect to my teeth. Also, there could be a basic anxiety which results in the kind of orientation that adults and adolescents might have, which again stems from their parenting patterns. While there might be some people who move towards people who are looking for who are looking for love, affection, and approval, there might be many people who are wanting to move away and against people, and that is what you will tend to see in their behaviors, which are very rebellious in nature, which are very dominating in nature, or which are very controlling in nature, and that could show difficulties in compliance with regards to treatment as well. When we come to geriatric population, a lot of emotional and behavioral problems that the geriatric population might show are irritability, anger, cynicism, and hopelessness with regards to their lifespan. And that again can be traced back to Erik Erikson's viewpoint, which says that the last conflict that we have is with regards to integrity versus despair. So if the elderly feel that they have lived a good life, they have achieved everything that they've wanted, and they've given back to the world, they feel a sense of wisdom, they feel a sense of integrity. On the other hand, if they are very disappointed, cynical with regards to the way their lives have shaped up, that could result in despair, and that would be manifested in their behavior of the irritability and the cynicism that you see in them. Neuropsychological disorders like Alzheimer's, Parkinson's, dementia, and delirium are also associated with not being able to come to appointments on time, not being able to follow the procedures adequately, and not being able to even remember what those procedures or instructions that you had given were. The stressors, especially during these times, which we need to be a little sensitive to, are the loss of spouse, the death anxiety, the financial concerns, and the accessibility issues which lead to geriatric depression and anxiety during this stage as well. The impact of COVID in general and with respect to geriatric population has been immense, as Manu ma'am had also highlighted, that the increased deaths that we found with regards to this age group. So the fear of contracting COVID-19 when coming and visiting the clinics, the anxiety disorders, the obsessive compulsive disorders, and other mental illnesses that have increased during this time, the geriatric population and in general, all the people are more prone to during this time. The lost meaning in life during this time and the feeling of survivor's guilt that comes from the fact that that they've been left after their spouse has left, or maybe after their family members has left, can also create a sense of loneliness, a sense of social isolation that they feel during this time. So briefly, to talk about the dental staff and setting, something that ma'am and sir both have covered is with regards to changing the dental setting in terms of the infrastructure in a certain manner. At the same time, I would also, from a psychological point of view, suggest some kind of training with regards to sensitivity, to interaction, and to receptivity in listening and attending to the patients in a little more elaborate manner, obviously considering the workload demands that you people have, but at the same time showing that respect to the patients irrespective of the age that they come from. Having some posters in your clinic, taking time to explain the procedures is something that needs to be looked into, where the dentist and the psychologist need to work in an interdisciplinary manner and come along together so that the adequate referrals can be made for therapy, and therapy not just for the patients, but also for the family members of the patient. And I would want to end this presentation with the fact that while we are talking about care for children, for adolescents, and geriatric population, it's important for you people as dental professionals as well to take care of yourself, to have that confidence and expertise within yourself, and to be aware of if you are experiencing stress, burnout, because there are immense incidences and papers reporting disorders and stress and anxiety issues that are emerging in the dental professionals as well. So dental community care is what I would want to leave you people with. Thank you so much.
Thank you, Dr. Anisha, for the wonderful presentation. And yes, we have come across a new terminology, that is the helicopter parenting, wherein the parent becomes over-involved. Yes, everybody wants the child is perfect, the child is very successful, and as I put in other words, better than the best we want to give to our children. And that is why I think this helicopter parenting is there, and its time has come when we need to really land. We need not fly high anymore. And in your presentation, you've made it very evident that the first attempt should be to establish a rapport with the patient, especially a disabled patient or special patient, and that trust should be there. That trust is very important, and the importance of multiple visits, because we need to deal with a lot of patients with these patients. And so the multiple visits actually is something which the caregiver also has to understand, because there are financial implications. they may lose on their time, their work for that particular day or particular time. So, and from the dentist point of view also, because multiple appointments, multiple visits also take their time away. But then if you are training and if you are getting trained for special care, then definitely you need to develop a lot of patience within yourself, and also you need to have that, build that special trust with these patients, and multiple visits is important apart from the infrastructure and the rest. That was a wonderful clinical aspect or the psychological aspect which you dealt with. And coming to in the end, there could be, I don't know, I cannot see the questions that have come up, but there are a few questions which I think we can put up to actually is Dr. Shambhat, you're there?
Yes,
Sir, if I
I'm
could
there.
ask
Yes.
you, if I could ask you, what is the scope of special care dentistry in India?
Yeah, scope is very much scope is there in India. Only thing is we need to train the undergraduate students as well as the postgraduate in our curriculum. It needs a big task because we already in the pediatric it is there, but we don't have a separate curriculum for that, which I think from the association level or from the apex body level, we have to put forward to this to bring it into the system so that we can make the separate entry to the special care, especially pediatric group.
Dr. Manu, what would be your take on this?
Ma'am, what I feel is that the projected scope is immense, because currently we are considered as a young nation. Our population is quite young if we see the census. And so suddenly there would be a surge in the older age group. And that suddenly that burden will increase after a couple of years or a decade. So to be well prepared for that, handle that, we need to gear up and to make ourselves well equipped to attend to that. So there is a lot of scope to progress in for the care of the special care patients.
Yeah, that's what even I feel, that when we talk about the special care dentistry, we can very well divide it into pediatric, geriatric, and the palliative care. So that has been wonderfully delineated, and we need to train. Training is very important of the dental surgeons so that they can handle these patients, and the infrastructure. These are the three major points which we come as a take-home message for the community or for the people who are attending this session. Any questions, Dr. Akanksha? Yes, Dr. Vidya Bhatt has written that sadly, oral health is given last option when general health issues are more for these children. Yes, definitely for these people, the other general health conditions are also there, which really need to be taken care of. Okay, and most commonly seen disabilities. What are the most commonly seen disabilities in clinical practice? Dr. Shambhat, would you please elaborate?
Yeah. Dr. Muslimin, regarding this, my take is on that is when you start practicing earlier in 90s, we used to get more of cases of epileptic and cerebral palsy or maybe Down syndrome. But nowadays it becomes more of autistic children are coming to the clinic. Children with autistic behaviors are more common. Maybe it is because the parents are understood the things. Maybe the other part has taken care, medical care has been more. That's why that other group is comparatively less. But to take this autistic children treatment part is requires a dentist little more extra time, as already Madam Janeja has mentioned about that. Anish has mentioned about that. It's true, very time. One is a trust. Of course, again, it goes with the severe, moderate, and the kid, how it behaves. And to take a treatment part of that, when dentist has to spend more time, not only that time, even our staff nurses also, supportive systems also required much better, how they handle. In fact, I want to highlight here, in our institution, we have made one interdisciplinary program for the nursing staff. They train in dentistry in the group. When the certificate also issued for them, they go with the separate care how to deal with the children. This is an interdisciplinary program we are conducted, and I think this will be helpful for them when they work in the clinic setup. because some people, they want the timing part of this thing, they want only the daytimes, that people, they go for dental clinic also. That will be helpful. And as madam said about these same systems can be utilized in the medical setup where the oral health care is required for the palliative care. I think those people can be shown to those people how to take care of oral cavity. That will be more useful in the ICU setup, or maybe in the where the hospitalizations are required for the elderly patients. That's my take on that, madam.
Yes, ma'am. Yes. May I give? Yeah,
Yeah,
sir,
yeah.
very aptly said that the medical personnel need to be sensitized towards the oral need, and there should be more promptness towards incorporating the oral healthcare professional as a team member of the caregiver in this interdisciplinary team. With otherwise, what is happening currently is the oral healthcare provider is called at the later stage when the problem has advanced. If incorporated member earlier in the team, many of the oral care problems can be avoided in such patients. Thank you.
So there is a question. I think Dr. Anisha can answer this. And they say, I wanted to know how we can, as students working in government setup with heavy patient load, reduce dental anxiety in patients.
I think that would require, first of all, that would require an interdisciplinary effort for that matter. Definitely that if it is an intense engagement that is needed, then there needs to be a mental health professional that needs to be involved. At the same time, as a person who's meeting the child or the patient for the first time, we need to trace back what the dental anxiety, what is the reason behind dental anxiety. If there are underlying reasons, if there are very deep rooted issues that are emerging in the form of dental anxiety, then you will have to involve some kind of a mental health professional. At the same time, giving some amount of time in listening to the patient, in attending to the patient, can be enough to begin with the dental procedures as well, if the dental anxiety does not have such deep roots with psychological issues.
Thank you. I think that would have answered the question. Another question, I think, to Dr. Bhatt would be that Sejal Bhaskar has asked, good evening, everyone. My question to the respected panelists would be if they could elaborate on how we work on behavior management for autistic children encountered during our general practice OPDs, and how we can make OPDs friendly. So, Dr. Saab, could you just elaborate a little? Because these things can be taken. Autism itself is a huge topic, and we have special sessions where we deal and we talk about autism in great details. But maybe Dr. Saab, Dr. Bhatt, you would like to talk.
The question is really apt for the audience, or maybe the people who are listeners. The first thing, actually, first you have to categorize which category this belongs. If it's a child is autistic is severe, then it's not easy to treat in the dental clinic. If it is mild and moderate, we can try in the clinic setup. I say mild, definitely we can treat in the clinic, but however, it will take very, very long time. At least you take first 3 visits. Only we have to take care with the parents first, explain the things to the parents, give the picture. That is called PEC, P-E-C. PECs has to be given. What is the setup of a clinic? What you are going to do? All it is given in the picturized form. We have to pass it to the parents. They have to explain daily at home what the dentist is going to do. Following that, only the child will sit on the dental chair. It takes your time too, and plus even your supportive systems also. Once that is through, patient sits in the dental chair. Only my advice is don't make a sudden jerk in the dental chair, like putting the aerator directly, or a light suddenly changing, or they like musics. Usually the autistic children, they like musics. Such things can be used for the supportive system in the dental setup. And once they understood, if a minor treatment, definitely we can go ahead, unless it's extensive treatment cannot be easily handled starting. Otherwise, definitely in the mild cases, we can do in the dental treatment. Of course, there are some people that are trying with our sedations, but I'm not completely agreeing with the sedation for the either moderate or severe cases. But I advise for the starting cases, definitely we can, as long as they understand the acceptancy, we can go with the sedation. Otherwise, I don't advise for sedation too. That
So
is
for
my
mild
side.
cases, yeah. So for mild cases, we can go for non-pharmacological behavior management means, and for the moderate, we can give a little bit of pharmacological aids, and for the severe, definitely GA would be the more
Yes,
advisable.
yes.
So that is how you would go ahead. I think with that, we don't have any more questions left, and we come to the end of the session.
Ma'am, may I steal a moment over here to put on records? Compliments to Dr. Sanjay Singh sir, Dr. Amina, Dr. Ekanksha, and Dr. Deepika, and the whole team for organizing all the event very wonderfully. Thanks. Thank you, ma'am.
Thank you so much, ma'am.
Dr. Mashmi, from my side, this is maybe I think geriatric and pediatric together has come for special care. Maybe the first time maybe in India. I don't know whether it's true or other people has to accept this part. I don't know. But geriatric has a big role. I think, can I take 1 minute, Dr. Mashmi?
Yeah, please, please.
That Madam Manu has mentioned about, Rati has mentioned about the mobile care. I think in Bangalore, somebody has started that, but there was some issue of legal point of they stopped.
I am aware of that, sir.
That is a bit, I mean, I got confused because why they put a send a notice for such people. I mean, I personally agree with they need.
There were valid technical legal grounds, sir.
Okay. I was not aware of that, but okay. Thank you for the updating that part, because, but I personally say it's required actually for the palliative care people who are home care support system, as you have mentioned in their presentation. I think it's a good to the people who are really in the hospitalized. During the COVID time also, it was really needed. So many people they called and they requested how to go ahead for. Thank you, and DENTOCON. Really, it's a wonderful the platform we are together. Thank you very much.
Right. We'd also like to extend a big thank you to all the panelists. It was a very interesting discussion session. And I would like to now request our chairperson, Dr. Moshpi, to please felicitate our 3 panelists.
My pleasure and honor, Dr. Shambhat. Please accept the certificate of appreciation.
Thank you very much. Thank you.
Dr. Manu Rathi, certificate of appreciation.
Thank you so very much.
For your wonderful deliberation.
From you, ma'am.
Dr. Anisha Juneja, kindly accept the certificate of appreciation presented to you on behalf of DENTOCON 2.
Thank you so much, ma'am, and thank you to the organizing team as well.
Thank you, Anisha. I would now request Dr. Anuradha to please felicitate our chairperson, Dr. Moshmi.
Respected ma'am, thank you for contributing your valuable time and expertise and for highlighting the key take-home messages of this wonderful session. On behalf of the organizing committee of DENTOCON 2, Advances in Holistic Dental Care, please accept a token of appreciation for chairing this panel discussion.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you, ma'am. Now, before we end, can I request everyone to please put on their cameras for a group photograph?
बाथरूम से भाग के बाहर आ जाना, ये है ठंड। उस ठंड को मारने जा रहा हूँ मैं, उसकी छाती चीर कर।
Right. Thank you, everyone. Thank you so much.
Thank you. Thank you so much.
Now we'll be, we take a 5-minute break and then we'll be starting with a valedictory session after a 5-minute break. Thank you.
Thank you. Bye-bye.
Colin Powell said, and I quote, "A dream doesn't become a reality through magic. It takes sweat, determination, and hard work." With these inspiring thoughts, I, Dr. Deepika Bablani Popley, on behalf of the organizing committee, DENTOCON 2, extend a heartiest welcome to our chief guest, Vice President, Dental Council of India, Dr. Satish K. Reddy, guest of honor, President, IESRF, Dr. S.S. Jha, Dean, Faculty of Dentistry, Dr. Sanjay Singh Sir. Respected dignitaries, delegates of the conference, dear faculty members, research scholars, and dear students from all over the country, we welcome you all to the valedictory ceremony of DENTOCON 2 and thank you for your presence with us here on this platform. I would like to invite right at the outset our constant source of motivation, inspiration, and support, the Dean, Faculty of Dentistry, and the organizing chairperson of DENTOCON 2, Dr. Sanjay Singh, to address the gathering.
Thank you, Deepika. Am I audible? Am I audible clearly?
Yes, sir, absolutely.
Okay. Thank you, Deepika. Dear friends, colleagues, and students, it is my honor and privilege to welcome you all to this valedictory function of this virtual conference, DENTOCON 2, Advances in Holistic Dental Care, hosted by Faculty of Dentistry, Jamia Millia Islamia, on 22nd and 23rd of January 2022. With great pleasure, I extend greetings to you all on this occasion. I am extremely happy and grateful to our chief guest of the function, Dr. Satish Kumar Reddy, the Honorable Vice President of Dental Council of India, for accepting our invitation. Your presence on this function is a big encouragement for all of us, sir. Thank you, Dr. Satish, for sparing your valuable time. I feel honored to welcome Dr. S.S. Jha, the President of IESRF. Dr. Jha is an orthopedic surgeon who has surgical expertise to correct the physical deformities of patients afflicted by polio, with polio and other orthopedic disorders. Thank you very much, sir, for being with us constantly for last 2 days. It has really been very motivating for all of us. We've had about 1,600 participants in this conference, DENTOCON 2. It is really very heartening and satisfying. They say unity is strength. When there are teamwork and collaborations, wonderful things can be achieved. With these words, I congratulate you all for the successful conference and welcome all the guests, chairpersons, speakers, faculty members, delegates, and students to this valedictory ceremony. Thank you. Thank you all once again.
Thank you, sir, for your valuable words. Your guiding light paves the path to our success. We are honored to have amongst us the Vice President, Dental Council of India, Dr. K. Satish Kumar Reddy. Sir did his BDS and MDS from Government Dental College, Hyderabad. He is a keen academician and a passionate doctor with a vast experience of more than 31 years in the field of orthodontics. He has numerous international and national publications to his name. Sir, may I please request you to enlighten us with your words of wisdom.
Thank you very much for the sweet words. To start with, Honorable Guest of Honor of the Day, Dr. Jasar, and Team DENTOCON 2, and the Captain, Sanjay Singh, and the guest speakers who have participated, the chairpersons, and the participants, and the other senior delegates who have been spending their time in the last 2 days and helping youngsters to learn. Press, electronic media, a great evening to all of you. And to start with, first, let me congratulate wholeheartedly the team DENTOCON 2 and the Captain Sanjay sir, because it is a huge effort. I know it's not a small thing. We have been shifting from a physical form to virtual form because of the COVID, and a lot of conferences are being held. Lot of conferences are being held in a virtual mode, and we have been using the technology, but a lot of hurdles are there. But whatever reports are there, this is one of the wonderful, technically organized program, and the technical team is also need to be appreciated and congratulated. And valedictory function is not a time for speeches and all that. There are many participants who won their prizes. They're eager to take those prizes. And I thank Sanjay Singh, sir, for giving this opportunity to be associated in this program. I really thank you, sir. And apart from it, one more thing, he has given another privilege of announcing the, winners, some of the winners of today's, yesterday and today's program.
So let's hold that.
No, I'm not going to. Unless
people are waiting for that. Our audience will disappear if you give out the results.
No. Unless you give a flag, I'll not start that. I'm just
Yes,
part
sir.
of the talk I'm saying. With all this, last 2 days have been wonderful. That's what I heard. Most of the people are telling. The program is very nice. All the best to every one of you. Have a nice time and keep logging till you take your prize home. Thank you.
Thank you, sir, for your very refreshing words. I would now request Dr. Sanjay Singh to extend our token of appreciation as a memento to Reddy, sir.
This is a mark of our love and appreciation for our chief guest, Dr. Satish Reddy.
Thank you very much, sir. You are always in my heart.
Yeah, this is coming. This is coming, Dr. Satish.
Yes, sir.
Thank you for being with us, Dr. Satish.
Thank you, sir. Thank you, sir.
With immense regard, we welcome our guest of honor, Dr. S.S. Jha, President IESRF. He is a man of charitable disposition and committed to serve the society. Dr. S.S. Jha is an orthopedic surgeon by profession. He chooses to utilize his professional surgical expertise for correcting the physical deformities of patients affected with poliomyelitis and other orthopedic disorders. Dr. Jha is the founder trustee of Ramajanam Sulakshana Pandey Cancer Hospital, Ranchi, and he was awarded the Devki Nandan Mathur Memorial Viklang Seva Saman Ratna. I would now request, sir, to kindly bestow upon us your words of encouragement.
Thank you, Dr. Deepika. I am overwhelmed with your introduction. Well, Splendid is the word that I must say for the way the conference has gone through. Well, this valedictory function, I am reminded of yesterday's faces, all beaming. I must admit, when you are saying bye, your faces are not as beaming, not as illuminating, but still this has to be gone through. So now I do start my formal address, and I may be excused if I am not as brief as my predecessors. Dr. K. Satish Kumar Reddy, the chief guest, Dr. Sanjay Singh, the organizing chairperson, Dr. Amina Sultan, organizing co-chairperson, and also secretary of IESRF, Dr. Akanksha Juneja, the organizing secretary, and all the members of the advisory board of this committee. From IESRF, Dr. Binod Kumar, the vice president, Dr. Sunil Chaudhary, the general secretary, and not the least, Dr. Mrs. Nikita Pandit, a member of the IESRF and also in charge of DENTOCON Secretariat at IESRF. Also, Mr. Rakesh Pandit from our respective innovative publication associated with IESRF. Friends, it's a great pleasure being present here this evening during this valedictory function. But I'm at a predicament for the reason that I have the unique privilege of being the host in my capacity as the president of IESRF, and am also here this evening as a guest. First of all, accept greetings from Innovative Education and Scientific Research Foundation. IESRF, I must introduce, is a pioneer body and one of the leading non-profit organizations dedicated to medical and scientific research. IESRF is associated with various scientists, medical professionals, research scholars, and students who are wholeheartedly dedicated to research and development in the field of medical, health, pharmaceutical, nursing, and of course, dental and allied sciences. IESRF is committed to innovation with quality in the area of research. It publishes 16 journals, of which 2 are dedicated to dental sciences, namely International Journal of Oral Health Dentistry and Journal of Oral Medicine, Oral Surgery, Oral Pathology, and Oral Radiology. Friends, I would like to take you back to the history of organizing DENTOCON. It is the brainchild of IESRF, and the DENTOCON 1 was organized earlier at Seema Dental College and Hospital, Rishikesh. This year, Dr. Amina Sultan, the dynamic secretary of IESRF, has taken the lead and has successfully coordinated between IESRF and Jamia Millia Islamia for organizing this DENTOCON 2. I must compliment Dr. Sanjay Singh, the Dean and Organizing Chairman, for executing a wonderful scientific program with instructional course lectures from dignitaries spread not only from all over the country, but also far and beyond. If we were together this evening in reality rather than virtually, I would have requested you all to offer the organizing committee under Dr. Sanjay Singh, Dr. Amina Sultan, and Dr. Juneja a round of applause by giving a standing ovation. But I'm sure you are joining me in applauding them in your hearts and minds for the success of this conference. I salute the dedication and zeal of all the members and office bearers, not only of Jamia Millia Islamia, but also to Dr. Nikita Pandit and her IESRF team for organizing this conference, which definitely have found out innovative solutions to often tricky and seemingly unsurmountable problems. A virtual conference has many disadvantages, but has the advantage of a larger audience spread throughout the country and even beyond. I'm happy to learn that roughly 1,600 delegates have registered. I, being an orthopedic surgeon, feel so close to dental science because the dentistry is rooted in orthopedic framework. Practically, I have listened to most of the presentations and have been enthused the way mandible has been reconstructed from fibular grafts, and earlier you were using even rib grafts. Like orthopedic surgeons, prosthesis and replacements are being performed apart from routine fixation of fractures with plates and arches. 3D printing is primarily getting evolved and reconstructive surgery in both these facilities. I personally feel that these two specialties, and for that matter, involvement of other specialties like plastic surgery, microvascular surgery, even clinical psychologists that we were just now talking about, can deliver better outcome in their specialties. I would like to instill a sense of confidence, especially for the PG students, junior teachers in training, and all those who have just begun their careers, that all of you are much brighter, stronger, and adaptable after such a brilliant conference. You all must be proud of belonging to this dentistry profession, and I am confident you are already interacting on public platforms to make them understand with all modesty what we do, why we do it, and why it matters. And dentistry, of course, will be appreciated for the place it deserves in human health. I, on a positive note, would like to express my confidence about the safe and bright future of art and science of dentistry in this country. The competence and professionalism of the skill visible during the conference by the stalwarts have been a stimulus to all the learners. Learn, unlearn, and relearn is the essence of gaining knowledge. And I must confess, I have also learned newer things during the conference. I would personally like to acknowledge and thank Dr. Amina Sultan for coordinating between the two institutions and flawless, excellent organization by her spirited and untiring energy. This DENTOCON is an organization with a difference, that as such, there are no president or president-elect or secretaries post who will change their professional collars ceremonially. But for the next DENTOCON, IESRF is going to create a chair of president and other office bearers from amongst the dentist community spread all over India. And hence, I appeal all the dental surgeons to please join our organization, IESRF. I would also appeal all the papers that have been presented here may kindly be put up for presentation in IESRF publication. Venue for the next DENTOCON 3 is likely to be finalized within a week, and you all will get intimated. IESRF congratulates its partner Jamia Millia Islamia, an institution with a legacy of 100 years, and for acquiring NAC A++ certification. Every tooth in a man's head is more valuable than a diamond. I heard this from one of the speakers last evening, and I loved it. And hence, let us work for the mission which you already are on, Save the Tooth, as proposed by Dr. Loghani from AIMS. Friends, in the end, I would like to end with a couplet that after these 2 hectic, busy days, we should not behave like न तुझे गैरों से फुर्सत, न अपने गम से हम खाली, चलो हो चुका मिलना, न हम खाली न तुम खाली. Long live Jamia Millia Islamia, long live IESRF, and long live DENTOCON. Thank you. Thank you for patient hearing.
Very well said, sir. Very well. And you rightly put it in perspective. Very well said.
Yes, sir. Thank you, sir, for your kind words, and we salute your learning spirit. I would now request Dr. Sanjay Singh. Sir, please felicitate Dr. Jha.
As a mark of our respect and a token of appreciation, we present you with a certificate and a memento, sir.
Thank you.
Thank you so much, sir. Thank you so much, sir. We are honored.
This conference would have not been possible without the guidance from our beloved Dean, Dr. Sanjay Singh, sir, who is the organizing chairperson of DENTOCON 2. I now request our chief guest for today to please felicitate sir with a token of our appreciation.
Dr. Sanjay sir, please accept this small token of appreciation for your great work.
Thank you. Thank you so much, Dr. Satish.
Just a second. 1 second, sir. It's just got stuck up. Sir,
no issues.
नहीं हुआ, but it has to happen. अच्छा है घर के बंदे के साथ.
Yes, yes.
The spirit says that it cannot be complemented with a certificate. Right, and it comes here.
Right, now it's okay.
Thank you so much, dear all.
All
my
best,
organizing team, yeah.
We are really indebted.
Sir.
It makes my heart swell with pride to announce that more than 1,600 delegates attended the conference through the virtual 3D platform and many more through YouTube Live. We are proud to announce that we received approximately 250 entries across all categories of scientific paper presentation. We are overwhelmed with the enthusiastic participation of faculty members, postgraduates, and undergraduates in the paper and poster presentation categories. It was a Herculean task for our screening committee and jury members to select the winners. But now, finally, the most awaited time has come, and I request our chief guest, Dr. Satish Kumar Reddy, to announce the results for yesterday's scientific presentations.
Thank you very much, madam. The results for paper and poster presentation. Position 1,
Delhi.
Faculty paper. Am I audible, sir?
Yeah, fine, go ahead.
Yeah. DENTOCON 22-0586, Arpita Roy. And second position, 00368, Sabina Sachdeva. Position 3, 0323, Vandana Reddy. And this is faculty paper, then again faculty poster. Position 1, 0785, Gagandeep Lamba. Position 2, 0288, Iram Parvez. And position 3, 00373, Dr. Tunu Nangia, if I'm not wrong. Then PG paper presentation, position 1, 2 people shared it, 928 and 929. Dr. Garapati Harshita and Dr. Sudhakar Naidu. And position 2, 246, Priyanka Agarwal. Position 3, again shared by 2, 335 and 336, Sanjana Manjarekar and Tejashwani Gorpande. It's okay, sir?
Yes.
Yes,
Congrats.
thank you.
Congratulate all the winners.
Congratulations to all these prize winners and all the best wishes for your future endeavors. May God bless you.
Thank you. Thank you so much. Next.
Thank you, sir. May I now request our guest of honor, Dr. S.S. Jha, to announce the results for today's scientific presentations.
Okay. So, friends, if you are all there, don't hold your breath. Breathe in and breathe out. And I will start from position 3 of PG poster presentation. So I may not read the code, I will read the names only. And if the code if there is any confusion, then only I will read the code. So third position goes to Dr. Rishabh Singh. Second position, there is a tie. So there are 3 persons at second position. Number 1, Dr. Kopal Singh. Number 2, Dr. Naga Dola Kirti Na. Dr. Sudhakar Naidu Sera. So this was for position 2, and now for position 1. Again, there are 2 winners, Dr. Makbul Alam and Dr. Poonam Vakure. Coming to undergraduate paper, undergraduate paper, the third position goes to Shraddha Dudeja. Second position goes to 2 persons, Sikha Agrawal and Tania Thakkar. First position goes to Mehak Rajput, Guru Sanjbir Kaur, Harmanbir Singh Man. And now for position for UG paper, again, the third one, we have 2, Shreyal Punia and Ruchika Kalyanpur. Position 2, we have 3 names, Christina Pereira, Heba Shirin, and Shahid Raza. Position 1, again we have 3 persons, Poonam Senegar, Sejal Bhaskar, Sadia Iqbal. And that is all. Thank you. Congratulations to each one of you.
Thank you, sir, and congratulations to the winners. Next, for all those, sir was there, I know, throughout the whole 2 days of the conference, but there were many who missed. So let me take you through the journey of making of this conference through a small video which we've made. I'll just share that. Thank you. I hope you enjoyed the journey with us. Now we have a small video message from Dr. Ketaki Kalle, the treasurer of IESRF. She sent a small video recording message. She is the assistant professor in the Department of Oral and Maxillofacial Pathology, DYWS Dental College. Just give me a moment and I'll share the message with you all.
Innovative Education and Scientific Research Foundation is extremely glad to announce Research Bonanza in this New Year Fest in the form of unlimited research activities, which would be definitely fun while you learn. I, Dr. Ketki Karele Bhogre, Treasurer ISRF, welcome all the bright minds to become a part of one of the largest academic multidisciplinary society. By becoming a member, one can get unlimited opportunities to showcase their research work in the form of presentations, keynote invitations, videos, podcasts, interview, reels, etc. to get deserved recognition in research field. Also get chance and support to mentor as well as get mentorship from world-class educators, academicians, clinicians as well as doctors. Also get a chance to win certain national and international awards for your research work from a selected jury panel. Also get attractive discounts on various conference registrations, publication charges, as well as fellowships and courses that would be brought up by ISRF exclusively for its members. All this and definitely much more. To know more, kindly visit our website. Thank you.
Thank you all for a patient listening. Before we conclude this valedictory ceremony, it gives me immense pleasure to invite my dear friend and the soul of this conference, Dr. Akanksha Juneja, Organizing Secretary, DENTOCON 2, to deliver the formal vote of thanks.
Ma'am, unmute yourself, please. Dr. Juneja, please unmute yourself.
Good evening, everyone. As we stand here today to give the final vote of thanks, it feels as if the time has just flown by. From inception to completion of this journey of DENTOCON 2, we have seen various shades. We started with baby steps, grew with each going day, and with every member adding something new and making this a very enriching experience for all of us. First and foremost, I would like to take this opportunity to thank our Vice Chancellor, Ma'am, Professor Najma Akhtar, and our Registrar, Sir, Dr. Naseem Haider Jafri, Sir, for all their support. A very special thanks to our chief guest for today, Dr. Reddy, Vice President, Dental Council of India, for gracing this occasion. Thank you so much, sir. A heartfelt gratitude to our guest of honor, Dr. Jha, President IESRF, and to the Innovative Education and Scientific Research Foundation for collaboration and unconditional support. Thank you so much. This journey would not have been possible without our dynamic and most loved dean, Dr. Sanjay Singh, sir, whose energy, guidance, vision has always been a driving force for us. A true leader who drives everyone by example. Thank you so much, sir. Thank you so much. You instill so much confidence in us. A very special thanks to all our esteemed speakers, chairpersons, and judges who have actually made this conference so memorable and a real scientific extravaganza. Well, when I talk about DENTOCON 2, one person whose name I can never forget is our organizing co-chairperson, Dr. Ameena ma'am. I can tell you how much she has pushed me for this conference. Thank you so much, ma'am, for all your patience with me. I know I am very difficult to handle sometimes, but you manage it with so much of ease. This journey, my journey, and the journey of DENTOCON would not have been possible without the support of my very dear friend and our joint organizing secretary, Dr. Deepika Bablani. Dr. Deepika, thank you so much for being the strength and making this all possible. A huge thanks to all scientific conveners, my friends and saviors. I would say that. Dr. Nishat, Dr. Virinder, Dr. Zeba, Dr. Babita, Dr. Bushra, Dr. Harneet, Dr. Amit, with whom I've taken the liberty to trouble them at any time of the day, and they would happily accept and cooperate in any kind of situation. They have really taken this event to our next level. Thank you so much. I would also like to extend my gratitude to the entire organizing team, Dr. Saranjit sir, Dr. Kia ma'am, Dr. Ashu, Dr. Mandeep ma'am, Dr. Priyanka, Dr. Aman, Dr. Salim, Dr. Anuradha, Dr. Vivek Mehta, Dr. Mariam, and many more for their unconditional support. Of course, a very special thanks to Dr. Nikita, Mr. Ranjan, and their team for 24/7 support at the back end and work. I would also like to give a special gratitude to Dr. Nakvi and his team for the technical support. Heartfelt gratitude to all the faculty members who have always stood by us and supported us. And of course, how can I forget? A very special thanks to our students who have actually been the backbone of this conference. Thank you so much, Sadia and Sejal, and all my students. Their efforts are really applaudable. A very big thanks to our office staff who actually took all the pains to be here on Saturday and Sunday and make this event happen. And of course, the real makers of this conference, that is all our dignitaries, faculty members, delegates, and students. Thank you so, so very much for your enthusiastic participation. In the end, I would say, please accept my apologies if I have missed upon any name, but I truly am thankful to each and every person who had trust in us, for supporting us, for encouraging us, and making this conference a great success. Thank you so very much. Thank you so much, everyone.
Thank you, Dr. Akanksha. I think with that, we wrap this conference, and on a note that we've all learned, we've all got inspired to do more, work harder, and put up an even bigger show next time. And thank you all for being with us. Before we actually exit, it's like a tradition now. Please put on your camera so that we can take a photograph, a group photograph. I'm waiting another few seconds so that everyone can put on their cameras. Please put on your cameras. It's memories that we are creating.
Please put on your camera. All those who are there, please put on your camera.
All right. Thank you. Thank you, everyone.
Thank you once again from the bottom of my heart. Thank you all once again. Thank you, Jasar. Very nice.
Thank you, Dr. Amina. Thank you.
Thank you, sir. Thank you so much, sir. Thank you so much. We're really humbled by your presence and your words, sir. Thank you, sir.
Thank you.
Heartiest congratulations. Fabulous conference. Fabulous. Beautiful.
Thank you. Thank you, Dr. Mandi. Thank you. The whole credit goes to our organizing chairperson. All the compliments should be directed towards him. I'm just a part of it.
Absolutely.
No.
Absolutely.
He's the Sarthi.
And
he's the like.
Yes.
His energy is infectious.
Yes. Yeah, that's it.
thank you, Dr. Satish. Thank you, Dr. Jha. Once again.
Thank you very much, Dr. Sanjay sir. All the very best to you for future work.
Thank you so much.